obstetric history. You need to take an obstetric history. You need to do voiding diaries, and that's not really what I want to deal with. There's the examination, abdominal examination, physical examination, and you've got to look at the physical examination for stress incontinence is the induced leakage that happens when patient bears down, and you can even use your finger in the vagina to try and see how you feel the stress urinary incontinence. Unlike the overactive or the urge incontinence, this you can stop with the 2 fingers in the vagina for females, and for males you can also stop it by putting the finger between the legs and pressing the urethra against the pubic arch. So it's possible to make, and that's how you make the diagnosis easily in your office. You can use various other things like the stress pad, which can be a 1 hour, which is less accurate, and you have the 24-hour. In the 1 hour pad, you're looking at not gaining more than 1 gram on the pad after the patient has worn the pad. In the 24-hour, you're looking at the patient not gaining more than 4 grams when you give the pad. And then once you see straining causing leakage, that is stress incontinence. And so when you treat these patients, there's behavioral treatment, there's mechanical treatment, there's pharmacological treatment, and lastly, what urologists do, the surgical treatment. The behavioral uses various types of retraining of the bladder and the Kegel exercises, and you're supposed to rehabilitate and strengthen the pelvic muscle flow. So this pelvic muscle flow is what worries us, and that is what causes problems in patients who have stress urinary incontinence. Of course, we have mechanical treatments. I've never seen them. I've just read about them, that they are gadgets you put inside the vagina to control continence. I'm told that patients don't like them, so they're not very popular. They are effective, but lack of acceptance has been the challenge. Then we have the drugs. There are anticholinergics, and recently the use of the SSRI duloxetine. Duloxetine has been the newest drug in the last 5 years in use on patients with stress urinary incontinence. Mind you, drugs don't always work. You have to combine the drugs with the behavioral treatment. But the question I want our residents to answer, and which therefore somebody should present a proposal in the very near future, is what causes urinary incontinence, and particularly what causes urinary incontinence amongst our people, and why do women have stress urinary incontinence? This is something that has not been evaluated in our part of the world, and when thinking about that, you've got to think about the urethrosphincteric unit. What is the urethrosphincteric unit and how does it work? In Africans, when I looked at the literature, in Africa there is very little awareness, and most of these reports are from Nigeria. There has been very little done, and the awareness amongst our men that there is something I can do about stress urinary incontinence is why people have not sought. But in the recent few years, there is more and more patients who are seeking this. So, as you do that, what is the urethrosphincteric unit? You must know that the urethra is surrounded by muscles, smooth muscle, and a trigonal ring that surrounds the lumen. Now, this unit is the one that you need to know, and so the SHO or whoever would want to do, you need to look at this, and this has striated sphincter, a thin, smooth muscle, and a well-developed longitudinal layer. So this muscle is the lead cause of continence. And unlike what we used to be told in the past, this is what you must aim at when you're treating stress urinary incontinence. The blood vessels in the submucosa also play a role, and those ones may reduce with time, and we shall see this unit is what you will need to look at. And so that is the unit. You need to look at the muscles, you need to look at the mucosa, and you need to look at the vasculature, and those are the 3 key things that people have looked at to be the most important, and this was demonstrated by a group in 2012 from Michigan, is the maximal urethral closure pressure. If you take nothing else from this meeting, it is the maximal urethral closure pressure. This is the key thing that has been seen to be affected in most women, and on 43%, it is low in 43% of women with the stress urinary incontinence as compared with 1.6. And the best is, you see it is in that slide, and you can see that is in those women who have as the control of urinary incontinence by other factors, the urethral axis, the genital axis, the vata, all those things. The key thing is the maximal pressure that is exerted, closure pressure, maximal closure urethral pressure, and that is what you would need to look at. So if you're going to measure anything, it is the maximal urethral pressure. Because any objective measure of support of the pelvis is not easy to measure, the maximal urethral pressure becomes the most important one. And this Michigan group, the Lancet, was able to demonstrate that it has occurred in a controlled setting 57% of the times, in the absence of everything else, and only just 7% would be expected by chance alone. RAD area alone, this is 2012, the Michigan group reported this in 2012, but Red et al. Had shown that the pressure was attributed to striated muscle activity. And that is why improving the strength of the striated muscle is the single most important thing you're going to do to improve the maximal urethral pressure. That is what contributes to that 3% of the pressure. The rest of it, 28%, is the vascular factors, and the remaining 39% is the smooth muscle and the connective tissues. So the smooth muscle is not as important as the striated muscle, which is why putting your legs together might perhaps help. And as women lose this striated muscle, and this occurs from the age of 20 to 25, as was shown by Rudd in 1980, the loss of this causes loss of maximal urethral closure pressure, and this was shown to start at the age of 25, particularly after childbirth. The loss of striated muscle has also been shown in that graph. You can see as you advance in age, you lose the maximal urethral pressure as you continue with age. The smooth muscle, the circular smooth muscle, is important, but not as important as the striated muscle. And again, there was a study which showed that if you looked at it from 0 degrees or at 180 degrees and 45 and 90 degrees, the change was the same. So the density of this also reduces with time, and the change in the smooth muscle strength is not as dramatic as that for the striated muscle. So while the smooth muscle is important, that is not important. So what I would like us to know is that if we are going to study and we are going to look at the stress urinary incontinence in women, the first thing I would like us to think about is how to create awareness. And then the next thing to know is that the question is, what is the maximal urethral closure pressure for the African women? Or what is the maximal urethral closure pressure for our women at the Kenyatta National Hospital? Thank you.
Thank you very much, Professor, for keeping time. And you have raised several questions that I hope will be answered by our young people as time goes on. So please keep time. I noticed some of our residents joined us, find time in their busy schedules to join us after we have made the opening remarks. So for their interest, when you're presenting as a resident, identify yourself, say which institution and which year of study you're in so that you're marked for the Rita Gobet Award. And again, thank you for finding time in your busy schedules to join us a bit late. Private practice, both in Nairobi as well as here in Nyahururu. Welcome, Professor Dr. Werumathu, and you'll be talking about pelvic organ prolapse, cystocele diagnosis and management.
have a pointer? Maybe not. So I'm discussing Cystocele, the diagnosis and management. Next slide, please. Next slide, please. So this is we have no pointer, but this is the pelvic floor. And here we have got the bladder, which is descending. So that's what I'm going to describe, and I'll give you features about it. Okay, thank you very much. Kako wapi? It doesn't seem to highlight. It is not highlighting. Now, Cystocele is an abnormal descent of the urinary bladder but how do we put it there? What do we put it down there?
You are bending over.
Yes.
I can hold it for you.
Thank you. Eh? Come again. It's a bit far.
But you can see it from here.
Yes, I can see. Yes. Yes. How is it? It has gone too fast. Let's go back to this. It is not, technology is not. Okay. Now, when you look at the papers that are presented, they are very difficult grades which are given. The Americans give grade 4 grades, grade 0, 1, 2, and 3. But I found it a bit difficult, so I thought because grade 0 is normal bladder, we come to grade 1, which is descent of the bladder from below the ischiospine, 3 centimeters below the level of the ischiospine. Then grade 2 is when that descent has gone further, below the 3 centimeters below the ischiospine and above the level of the hymen. Yesterday when we were doing the Cystocele, the registrars asked me, can you really know where it is? And I showed them. From the minor, labia minor, you'll be able to see a ridge. And then you have grade 3. This is a descent of the bladder below the level of the hymen to the introitus. Some of these are associated with a lot of discomfort. Although Professor was trying to help me, we have to leave it down. Let's go for the next one. The next slide. Aye. Yes. Thank you. What are the presenting symptoms of the cystocele? You have a dragging pelvic, nagging discomfort of the lower abdomen, and also you get urinary symptoms. For instance, they have frequency, they have poor stream, especially grade 2 and grade 3. Some of them will present with vaginal discharge. Some will have vaginal mucosal erosion, especially the grade 3 because the mucosa is outside. And some of them, like the one I did yesterday, she told me that she gets dyspareunia. And the mzee is just bothering her. Now, how do you associate cystoceles? It's mainly by age. People between 40 and 50, and also people above 50, they will get more of this pelvic floor laxity, therefore the bladder will descend down. The other one, as Professor said, Mogai, is multiple births, vaginal births, and especially children above 3.5 kilograms. Then you have factors which are familial or genetic, because you may find it running in some families. People who have chronic cigarette smoking, they have a problem with the tissues, and therefore the bladder could descend. We have a problem with the obesity. People who, and they have to be told to reduce their weight. Then you have people who may have chronic cough, like bronchitis, bronchiectasis, and some of the patients may have had hysterectomy. And therefore, once they have had that, the pelvic floor is already weak. What investigations do you do for patients before they have surgery? You do the usual things, urinary analysis and culture, you do full hemogram, you do renal function tests, liver function tests, random blood sugar. The other day I was doing an operation in Nairobi, and I was shocked that when we had just finished, the sugar was done and it was 35. Somebody who has not had any signs of diabetes. Then you do a pelvic ultrasound. This is mainly for the patients who have grade 1 cystocele, because you may not be able to see. One will just complain of symptoms, and once you do the imaging with a contrast into the bladder, the radiologist or radiographer will tell you that there is a descent. At the same time, when you do this ultrasound, you'll be able to diagnose other abnormalities like diverticulae, the posterior wall of the bladder. It's important these people are aged, you do ECG so that you can rule out other abnormalities. What complications might you get when you have done the surgery? You may get bleeding, you can injure the bladder, you get poor stream of urine after removing the catheter. I did one case, and after removing 3 days later, she could not pass urine. I had to return the catheter for about 10 days so that she could be able to pass urine later on. You can also have failure to cure the symptoms, and therefore you have to repeat the surgery. These repeated infections can occur mainly for people who have been done the mesh, replacement of the mesh in the submucosal, and it is not a very comfortable thing. I know somebody says that he can also use the mucosa, the rectal sheath, and put it at the submucosa to repair the defect. Now, how do you examine the patients to be able to diagnose it? You put the patient in the dorsal lithotomy position or dorsal position, and you tell the patient to bear down or call Vasa maneuver, and therefore you'll be able to see the protrusion. Cystocele is also called anterior bladder prolapse, anterior vaginal prolapse. That way you'll be able to see exactly what is happening. When it comes to treatment, as Professor has said, they are medical and they are also surgical. The medical ones are mainly Kegel exercises. How do you do the Kegel exercises? Both the men do, but this one is mainly for women. How do you do it? You tighten the pelvic muscles for 2 to 3 seconds, and when you hold that, later on you release. You are advised to do that for about 10 minutes, and you can do it twice in a day. They say after 12 weeks, they may have the symptoms reduced of urgency, incontinence. They actually may reduce the symptoms. I have seen during my training cones, vaginal cones. Vaginal cones are graduated in different sizes. Hold a smaller one, the better. The pelvic muscles will be able to tighten and be able to hold. I have not seen the vaginal rings, and I think they must be they must be very uncomfortable. So Kegel exercises, that's what is supposed to be done. For the repair of this Cystocele, one does it when patient is in a lithotomy position. With the stirrups, you infiltrate jungle juice into the anterior vagina of the urethral vesicle to the top of the cervix. You make a longitudinal incision of the mucosa, then you deflect the mucosa laterally to about 2 or 2.5 centimeters down, and you will be seeing the bladder going down. I normally use my finger, because once you get the cleavage of the mucosa and the the cycle fascia, it will slit down very nicely. Then what you do next is that you put a 2-0 vicryl suture at the corners, so that you'll be able to bring down continuously, starting from the anterior upper part, and you go all the way down. And as you do that, you just see it disappearing inside, because there is a deflection of the bladder into the pelvic cavity. Then you put a catheter, size 16, and leave it for 2 to 3 days. Once you do that, it's a very nice operation to do. Patients become very happy, and you also be very happy yourself. That's the much I can say about Cystocele. Okay, Charlie.
So thank you very much, Brigadier, for keeping time. Our next speaker will be Dr. Dedan Opondo. Dr. Dedan Opondo is a urologist both at the Grutas Cure Hospital in South Africa as well as in Kisumu. And he's going to talk to us about prostatectomy, stress urine incontinence. Thank you and welcome, Dedan.
Okay, good morning. Thank you very much, Chair, for giving me this opportunity to also talk about stress urinary incontinence. Stress urinary incontinence in men is not as common as it is in women. And as a matter of fact, the stress incontinence I'm talking about is iatrogenic. Post-prostatectomy stress incontinence is one of the main concerns that we have for the patient who is undergoing radical prostatectomy. Stress incontinence is defined as involuntary loss of urine. and this is one of the outcomes that we use to measure the quality of radical prostatectomy. It is part of the classical trifecta. We aim to get the patient to have oncologically free margins. That means we achieve oncological efficacy of radical prostatectomy. But at the same time, if we can spare their continence, that is the second part, usually sparing the erectile function. Men generally do not have stress incontinence because of the anatomy, but in this slide I just wanted to highlight one part that will contribute later to the intervention. It's called the infrapubic angle of the vulvar urethra, and this angle is important in maintaining normal continence in men in the absence of the prostate, because once the prostate, the internal sphincter, is out, then the infrapubic angle contributes to part of the continence mechanism. I'm not going to go into the details of continence mechanism, so I'm going to go straight, because Professor Mungai and Dr. Waweru have already talked about them. Stress incontinence related to radical prostatectomy comes primarily from 4 surgical points. There is an injury to the internal sphincter mechanism, which is usually occurring at the time when we are doing the bladder neck dissection. But you're going to be guided by the oncological principles, because you want to get the first prize is oncologically negative margins. So if you do bladder neck sparing, you are able to contribute to some of the continence. But sometimes when you have aggressive disease close to the bladder neck, then you do not have to do, you mustn't do bladder neck sparing surgery. The striated sphincter is innervated with the pudendal nerves, but we also have the neurovascular bundle that also contributes to the strength of the intrinsic sphincter mechanisms. So the striated muscle length that is spared during radical prostatectomy leads to the continence mechanism. So there are people who actually measure the motor units to establish how much loss has happened. Then we usually divide the puboprostatic ligaments, and that division makes the urethra hypermobile, almost close to the hypermobility that we see in females. And that is why some workers actually advocate for puboprostatic fixation during radical prostatectomy. So urethral support, external sphincter, and denervation, these are the major contributors to stress incontinence in radical prostatectomy of the muscle bulk of the patient. So the older the patient, the less muscle bulk they have, the less bulky striated muscle they have, and therefore more likely they can get stress incontinence. Those patients who get adjuvant radiotherapy have a higher incidence of stress incontinence, and those who have preoperative incontinence are likely to have stress incontinence. That is to say, those patients who have overactivity because of bladder changes, primarily because of their premorbid Bph components, will have worse incontinence because they have high intravesical pressures. So those 3 are the main predictors that have been established in literature, and there they are presented in the nomogram. And you can see that the patient age contributes much more significantly than the presence of radiotherapy, and the presence of preoperative incontinence has a much more significant weighting on that nomogram. Now, the incidence of stress incontinence varies in literature from 2.5 to 90%. And these variations really is not because of the intrinsic variation in the surgical technique, but it's because of the outcome measurements. And this outcome is a very labile outcome because it has 2 components to it: the time at which the stress incontinence is measured and the definition of stress incontinence. So most studies use the number of pads used. And you know that is very difficult because a gentleman who comes from one village will change the pad with a very low volume of urine, and another gentleman from another village will change it when it is fully soaked. So then when we count pad use, then we get errors in counting. Natural history of stress incontinence after prostatectomy is that many patients recover. So if you measure incontinence on day 0 and you measure it on day 30, and the indicator is a study, for example, done by Haglund et al. In 2,625 patients, and they had a strict definition of less than 1 pad use in 24 hours, and they measured these at 12 months after radical prostatectomy. And comparing both open and robotic, you notice that the rate of stress incontinence is the same. 1 out of 5 patients will have stress incontinence defined by using a pad per day. And you might, and when you look at the urinary continence rates, they vary quite a lot. So what then should we do as surgeons to prevent? I emphasize this because the treatment is expensive and the outcome is distressing to the patient. So bladder neck sparing surgery where possible. So we should master the technique of bladder neck sparing surgery, improve on neurovascular bundle sparing. You will be able to do the first and the second if you pay attention to the distribution of the positivities of the cause and do risk stratification of the prostate, spatial risk stratification. You want to know where did we get the highest risk disease. If you have a Gleason 5 at the base, you don't do bladder neck sparing. And if the apex is negative, then you emphasize on the urethral stump sparing. Now the most important intervention here, which is most effective, is the urethral stump length. And I'm sure SNK has this experience. I think we've discussed this before. The amount of the urethral stump length that you leave is quite predictive of continence after radical prostatectomy. So in my own personal experience with radicals, I think it's the most important intraoperative intervention that you can do as a surgeon to get the patient to be continent, because the rest is usually very difficult to establish. Now the treatment of stress incontinence has been mentioned earlier with the previous presenters. We have pelvic floor muscle training and the SSRI duloxetine. I emphasize on pelvic, be subjected to pelvic floor training. So in our practice, what we do when we're doing consenting of the patient before they come for surgery, we give them basics of pelvic floor training. And then the day of surgery, the night before, we explain it a little bit. But we take advantage of the day when we come to remove the catheter, usually day 14, 10 to 14. And when we're doing the pericatheter urethrograms, we actually train the patient in the radiology department how to do Kegels. And they love to do it because there's the first time they pass urine, they're fully naked, they're close with you in the radiology department, and you can actually use fluoroscopy to demonstrate to them to kind of a biofeedback mechanism. Then after doing that, we take our patients to where we do the urodynamic studies, the uroflowmetry, and we actually demonstrate for them the Kegel's procedure, and they see it on the graph on the uroflow. So as they interrupt the urination, they can see it. It works quite well because sometimes you tell the patients to squeeze and then they're squeezing their hand. Because when you demonstrate, you tell them to squeeze, sometimes they're squeezing their thighs. So it's quite frustrating for some of the seniors to identify the right muscle. So you use whatever you can for the right muscles to be identified. Now, in the event that the patient has stress incontinence, the treatment should actually not be done in the immediate period, because I told you many of these patients recover. So you want to give them some time and grade the severity, and that's when surgical intervention may come in. And that surgical intervention requires assessment of the urethra, and the most important thing to do is flexible urethroscopy and do what is called urethral coaptation test. So it's best done in the office, no anesthesia, maybe lignocaine, and you go in with a scope and you press on the perineum and see how much, with what amount of force the urethra is able to close. That coaptation test will be predictive of the technique that one can use in surgery to treat this. Because for very soft urethra, one can actually use macroplastic, for example, to try and do bulking to achieve some coaptation. And if you do that, some patients with mild incontinence will get away with it. In the event that you have a urethra that is not having good coaptation, then you need compressive devices like the AMS 800 and the ProAct, whether it's circumferential or hemiscircumferential. Those devices will achieve good coaptation. Remember, the male urethra in that angle that I showed closes by coaptation. Now, those who have had radiation will not close by natural coaptation, so you need the compressive devices, AMS 800 or ProAct. But those who have good coaptation on flexible urethroscopy, you can use slings. And there are different types of slings in the market, adjustable and fixed slings. And a detailed discussion of the merits of each is probably beyond this, belongs to a workshop. Yeah, thank you very much. And that's the end of my presentation, Chair.
Thank you very much, Dendan, for your very interesting talk. We've learned a lot from that, those who do that type of surgery. So our next speaker is one of our two newest female urologists, lady urologists, Dr. Yvonne Karemi, who is going to talk to us about metabolic syndrome in BPH at Kenyatta National Hospital. Welcome, Dr. Karemi, and please keep time.
Good morning, everyone. My name is Dr. Yvonne Karemi. As I was rightfully introduced, one of the newest junior consultants, urology, having graduated from the University of Nairobi, and currently based at the Thika Level 5 Hospital, and with a small budding private practice somewhere around Nairobi. So today we are going to talk about the X factor. And when I mention the X factor, I'm not talking about that famous X factor, which features the mean Simon Cowell. But really, I'm talking about syndrome X, which was it's a term coined by Gerald Driven in 1988. And this was to describe metabolic syndrome, which is a cluster of metabolic abnormalities, including central obesity, dyslipidemia, hypertension, insulin resistance with compensatory hyperinsulinemia, and glucose intolerance. So in 2002, the National Cholesterol Education Program, Adult Treatment Panel 3, defined metabolic syndrome as the occurrence of 3 or more of the following: a waist circumference of more than 40 inches in males and 35 inches in women, a BP of more than 130 with a diastolic over 85, a fasting triglyceride of more than 150 milligrams per deciliter, a fasting high-density lipoprotein of less than 50 milligram per deciliter in women or 40 in men, and a fasting blood sugar of more than 5.5 micromoles per liter. So then I sat back and thought about it, and I went through different papers. In 2016, Garcia et al. Actually reviewed 82 articles, which he selected for detailed evaluation, and 8 were included in his review. The 8 studies enrolled 5,000 patients, of which 1,426 patients, which is 26.4%, had metabolic syndrome, which was defined according to the current classification as defined earlier on. So patients with metabolic syndrome had significantly higher total prostate volume when compared with those without metabolic syndrome. And that is what is highlighted in yellow. But when it comes to IPSS, there was no major difference amongst the patients who had metabolic syndrome and the patients who did not have metabolic syndrome. And therefore, I sat down and I came up with my dissertation thesis, which was presented as part of fulfillment for my award as in a Master's of Medicine in Urology, which was titled The Prevalence and Association of Metabolic Syndrome with BPE amongst men treated at Kenyatta National Hospital. So in my background, tiny font, The background was that metabolic syndrome is a constellation of metabolic derangements associated with central adiposity and insulin resistance. It is thought to develop into BPE. And therefore, I sought to establish the presence of METs in BPE and its association with BPE. This was a cross-sectional study that enrolled 97 men. What is the pathophysiology of metabolic syndrome? So we have, genetic factors, fetal programming, excessive dietary intake, and lack of exercise. This now will eventually lead to insulin resistance, where we have high insulin and insulin growth factor levels, a dysregulation in the hypothalamic pituitary adrenal axis, which now causes hypercortisolism and hypogonadism. And then we'll then have visceral obesity, which causes chronic inflammation with cytokine release, and atherogenic dyslipidemia due to the low HDL and the high LDL and high triglycerides. This eventually now causes metabolic syndrome, which then causes hormonal changes, including increased estradiol levels and low testosterone levels, insulin resistance, pelvic atherosclerosis, especially at the bladder and prostatic tissues, and then inflammation due to the cytokine release. And finally, this will now lead to BPH and lower urinary tract symptoms. Vignosi et al. Suggested a 3-hit hypothesis in the pathogenesis of BPH. The first hit was prostatic cellular inflammation. The second hit was bolstered by metabolic variations. And the third hit was compounded by sex steroid abnormalities. The collective actions of 2 or 3 hits can actually cause overexpression of toll-like receptors, transformation of prostatic cells into APC cells, activation of resident human prostate-related lymphoid tissue, and excessive production of growth factors leading to prostatic remodeling. My inclusion criteria are patients who presented with LUT secondary to BPE with an IPSS of more than 8, the enlarged prostate greater than 30 cc, and a PSA less than 10 nanograms per ml. Exclusion criteria, certainly patients who declined to take part in the study, and patients with suspected cancer of the prostate from either DRE findings or PSA levels. What were my results? The mean age of the study participants was 69.5 years, with a median of 70. The range was 49 to 88 years. The IPSS, more than 77.3% actually had severe LUTs, while 22.7% had moderate LUTs. The mean prostate size on ultrasound was 75 grams. Now this is where it becomes interesting, because the fasting blood sugar, the mean fasting blood sugar was 8.21 with a median of 7.9. The range was 4.6 to 13.6. So amongst all the patients, high fasting blood sugar of more than 7 micromoles per liter occurred in 70 patients, which was 72.2% of the participants, compared to 27, which is just 27.8% of the participants who had a normal fasting blood sugar. Comparatively, 37 patients, which was 38.1% of the patients, reported to be diabetic. And therefore, as many as 34.1% of patients were not off treatment for diabetes, despite having high fasting blood sugar. That is a pie chart representation of the data that I've just said. When it comes to waist circumference, 63% of the patients had normal waist circumference, with 36.1% having elevated waist circumference. Dyslipidemia, amongst the study subjects, 30 had low HDL, while 67, which is 69.1%, had normal HDL. And only 7 had elevated triglycerides, which is a meager 7.2%, compared to 90 patients who had normal levels. That is now just a graph of all the patients and all the metabolic syndrome symptoms that they have. So when it comes to hypertension, really it's almost a close tie because it was 49 and 51%. Triglycerides, as Kenyans, we actually have normal TGs. When it comes to HDL, also most of the patients had normal HDL. Waist circumference was normal, but really what stuck out during the study was that a lot of patients were diabetic and they did not know this. Individual components of metabolic syndrome and IPSS scores, as you can see in the table, there is HDL, low and normal, waist circumference, and their p-values and their odds ratio. When it comes to number of metabolic components encountered in the study, remember that to define metabolic syndrome, you have to have 3 or more. 61 patients actually just had 2 components, while the rest now had 3 or more of the components. Which brings us to the question, is there an association between metabolic syndrome and BPE, and what is the prevalence? So you can see that 62.8% did not have metabolic syndrome, but 37.1% actually did have metabolic syndrome. So a major finding from my study established prevalence of metabolic syndrome in 37% of the patients with BPE. And this study did demonstrate a correlation of severity of metabolic syndrome and BPE. Having metabolic syndrome resulted in higher likelihood of high IPSS scores with an odds ratio of 4 compared to not having metabolic syndrome. And this result builds on existing evidence that there is an association between metabolic syndrome and BPE. In conclusion, the prevalence of metabolic syndrome among African populations is increasing, and worldwide it's actually called the global scourge. NCDs are the global scourge. So it is inevitable that this disorder will become even more prevalent and a major challenge for all healthcare systems in the future. From our findings, the results indicate a correlation between metabolic syndrome and BPE, more so severity as shown by the IPSS. So with limitations in availability of data on metabolic BPE in the African continent, this study provided a new insight in establishing the associations which greatly help to improve management protocols of care in patients with BPE. Finally, this is something that I quoted on my last day in school, that if I have seen further, is by standing on the shoulders of giants, which was said by Isaac Newton. And I'd like to thank the urology fraternity for standing with me. Thank you very much.
Thank you, Dr. Yvonne Karemi, for a nice presentation. The next speaker is equally a new urologist in the fraternity, Dr. Karen Dhiwa, currently working at Karen Hospital. She is going to tell us what is new in eye management. Welcome, Dr. Karen.
Good morning. So I don't think there's anything new from the... I don't know why I was given this topic, because I didn't find anything new in the UTI management. Basically, what I'm going to talk about is, I'm basically going to summarize the guidelines. We know we can't discuss UTI in 10 minutes. So I'm going to look at the most aspects that urologists deal with and how we can go ahead in managing. So I'm Karen Dhiwa. I'm a resident urologist at the Karen Hospital. So I have to declare this presentation is sponsored by CIPLA because they are launching one of their products from IC. So if you look at the guidelines, I'm going to mostly use the EAU guidelines. They classify UTIs into uncomplicated UTIs, complicated UTIs, recurrent UTIs, CAUTI, and urosepsis. So what I'm going to major on is the complicated UTIs, because the uncomplicated is just basically the cystitis. I'll deal with complicated UTIs, recurrent UTIs, and CAUTI. Sepsis we did last course, so I think it's still fresh in our minds. Start with asymptomatic bacteriuria, and this is defined as 2 consecutive midstream samples of bacterial growth of more or equal to 10 to power 5 colony forming units by male in women, and in 1 single sample in men. Most of the asymptomatic are usually the normal commensals, and its studies have shown that asymptomatic bacteriuria may protect against superinfecting symptomatic UTI, and hence no need to treat. Actually protective. And when a patient, especially the young male, comes with asymptomatic bacteriuria, you should always consider the diagnosis of chronic bacterial prostatitis, and a DRE must be done in all these patients regardless of age. Persistent growth of ureas bacteria like Proteus mirabilis, we should also consider possibility of a stone formation. And as I said, in all men must have diarrhea done. So how and who do you treat? So as I said, that it's not a bracket statement that we don't treat bacteriuria, but there are special groups of people that you should treat and screen for ABU, and these include pregnant women, because it's been shown that ABU in pregnant women is low birth weights and preterm deliveries, and you give a short-term antibiotics of 3 to 7 days, depending on the local susceptibility patterns of antibiotics. If you're planning to change nephrostomy tubes or ureteric stents, you should screen and treat pre. And in a patient, you're planning to do any prior urologic procedure, and there's a likelihood of breach to the mucosa, you should do cultures pre-op and treat. Some of us are guilty of this. We just book patients for TRP, for stent removals, without doing. We should. The other aspect I'm going to look at is the aspect of recurrent UTIs. Personally, I see a lot of these, especially girls who are sent to me by the gynaes with recurrent UTIs. Recurrent UTIs are basically, if a patient has recurrences more than 3 in a year, more than 2 in the last 6 months. That's what is defined as recurrent UTIs. Can be either complicated or uncomplicated. And how do we prevent recurrent UTIs? Some have been identified that cause recurrent UTIs like hygiene. Now we tell women wipe front to back. Some patients also get postcoital UTI. So once you identify the risk factor to the patient, you discuss on avoidance of that risk factor. There are non-antimicrobial measures and microbial measures that you're going to look at. And a patient who has significant, all patients with the recurrent UTIs must at least have an ultrasound, and if there's a significant PVR, should be dealt with either by CIC or catheterization, depending on the cause of the CIC, PVR, or high-risk PVR. So what are some of these risk factors? In young and premenopausal women, sexual intercourse is a risk factor. Use of spermicide, a new sexual partner, if a mother has UTI, if you've had a recurrent UTI in childhood, and what we call blood group antigen secretory status. What this means, there are some people who secrete their ABO antigens into body fluids like saliva, urine, and they tend to be prone to getting UTI. In postmenopausal women, patients who have history of UTIs before menopause, for that, Cystocele, patient with a high PVR, blood group secretory status, patient with catheterization, or have a functional draining abnormality like neurogenic bladders, patients who are institutionalized, especially women. So how do you manage recurrent UTIs? So there are so many things that are being sold and are being marketed to by pharmaceuticals, but I'm going to just, from the guidelines, what I found to be of benefit. In postmenopausal women who come with recurrent UTIs, we should prescribe topical estrogen. They apply in the vagina. It will help with the sexual intercourse, and it will also help with the UTIs. There's an oral vaccine that is derived from E. coli 89, has been shown to prevent recurrent UTIs. Also, a role of giving antibiotics in prevention of UTIs. There are two aspects. You can either give continuous low dose or give postcoital prophylaxis, especially in pregnant women who before pregnancy had recurrent UTIs. You give them postcoital antibiotics to prevent them from getting UTIs in pregnancy, because we know the risk factors. So which drugs do you give for when you're considering doing antiphylaxis? It's been shown that you can give nitrofurantoin or fosfomycin, and fosfomycin is highlighted in my conflicts. There are patients who are enlightened and they who get recurrent UTIs, you can actually discuss with them, and they can actually self-diagnose and self-treat. So which things have not been found to be of benefit? There's a D-mannose. Okay, there are some studies. If you look at the studies, it's one of the sugars. It's been found, some studies are showing benefits, others are not showing. So currently, from the guidelines, there is not enough data to support. There is no role of probiotics. We tell patients, go take yogurt, take probiotics. There is no benefits. Cranberry, I know all of us have been cranberry juice, usually basically no benefit. And also there's no benefit of intravesical instillation, especially of hyaluronic acid and chondroitin sulfate. This is in patients who have interstitial cystitis. So my last one is on, not second last, UTIs, and this is complicated UTIs is a UTI if a patient who has an underlying urogenic UTI, and men, because of the nature of their anatomy, complicated UTIs are usually multi-drug resistant, voiding, DM, reflux, immunosuppression, recent history of instrumentation. If someone is developing a UTI while in hospital, isolated ESBL, and if identify any multi-drug resistant organism from culture. So there are SWAP guidelines which were adapted by the EAU guidelines, and symptoms or a typical presentation. And from the previous slide, you can see the heterogeneous group of patients, single or a universal approach to managing this patient. Most of these UTIs, complicated UTIs, are caused by E. coli, and a broad organism cause this compared to uncomplicated UTIs. So what are the general principles? So you manage the urologic abnormality. If a patient has a stent, manage the stent. If a patient has an obstruction, manage the obstruction, because if you don't manage it, antibiotic won't work efficiently. Your therapy depends on the severity, local resistance pattern, and specific cost factors, and you tailor initial empirical therapy. Then you follow from what comes from culture results. So the last one is CAUTI, or catheter associated UTIs, and basically a UTI occurring in a patient who is currently catheterized or has been catheterized in the last 48 hours, and it's defined as a growth of more than 10 to power 3 units in one or more bacteria species in a single catheter specimen, or a midstream voided urine in a patient moved a catheter 48 hours prior. Is a leading cause of hospital associated bacteremia, and if you let a patient stay with a catheter, the risk is 3 per day. So the longer you skip the catheter, the longer the risk of getting UTIs. Risk factors as identified: duration of catheterization, patients who are diabetes, females, and admitted in ICU. So the pathophysiology, as we know, catheterization basically perturbs the defense mechanism and access to the uropathogens into the bladder, and this facilitates colonization of the uropathogen, and now the bacteria now will attach to the receptors in the uro, thus enhancing microbial adhesion. Once the urothelium is exposed, there is bacteria now new binding sites, and the bacteria now adheres and starts. If a patient has an indwelling urethral catheter, usually there is usually pulse below the catheter bulb, and that itself also can just come with non UTI symptoms. And these organisms, something I found important is pyuria from gross doesn't define CAUTI. And if a patient develops symptoms and you do urinalysis and there is no pyuria, that suggests a diagnosis that's other than a CAUTI. So how do you manage? Basically, you prevent, limit catheterization, hygiene, and alternatives to indwelling urethral catheters like It's a bit long.
You can summarize.
So in sum, I want to go to the summary. So in summary, you screen and treat asymptomatic bacteriuria only in pregnancy and patient prior to urologic procedures. Offer topical estrogen dose and postcoital fosfomycin and nitrofurantoin in women. In UTIs, you manage the complicating factor. Limit catheterization. Appropriate use of catheters to prevent CAUTI, and do not prescribe antibiotics before change of catheters because of increased resistance. Thank you.
Thank you very much, Dr. We know UTI is usually a mouth, and at least you have reminded us that we have to do urological procedures in the environment of sterile urine. The next speaker, Dr. Madenge. Dr. Madenge is equally a urologist. He's working as a MTR. Is going to tell us the correlation between international prostate symptom score and post-voidal residual volume in patients with benign prostatic enlargement at Kenyatta National Hospital. Welcome, Dr. Madenge.
Good morning. Good morning. Yeah. So, as you heard, my name is Dr. I'm a urologist from Moi Teaching and Referral Hospital in. So, my study is on post-void residual urine volume. This was a study that part fulfillment of my postgraduate studies in M.Med urology. So we'll start with the definitions. We all know what benign is. It's a condition that afflicts the aging male. It's characterized by enlargement of the prostate gland with narrowing of the urethra. So the prevalence of BP increases with age and approaches 80% by the age of 80. So what is PVR? Post-void residual urine volume, and this can be evaluated via a bladder ultrasound or catheterization. But ultrasound is widely, it's non-invasive nature. So as a background, as urologists, we rely on PVR to objectively assess PE severity due to its procedural availability, affordability, and however, there has been conflicting evidence on the diagnostic accuracy of PVR in determining severity of LUTS and the threshold significant PVR. So there is lack of on what constitutes significant PVR, and no PVR threshold for treatment decision has been established. So most urologists usually agree that volumes of 50 to 100 mils constitute the lower thresholds abnormal residual volume. So what is a PVR in a normal man? A study by has shown that 78% of normal men have residual less than 5 mils, and 100% of men without any LUTS will have a PVR of less. So according to EAU guidelines, no thresholds has been established for treatment. So more research to be done to define and quantify the volumes that indicate pathology. So from this study, the broad objective was to assess the correlation between PVR and severity as measured by IPSS score. And the specific objective was to determine of patients with BP in Kenyatta National Hospital, and to determine the LUTS of patients with BP in KNH's IPSS, and to assess the correlation between PVR and LUTS in patients with BPE in Kenyatta National Hospital. The objective depending on the third objective, to evaluate PVR cutoff and severe loops as categorized by IPSS. So that was a study procedure. We enrolled patients with BPE who were eligible, consented, were given questionnaire, IPSS questionnaire to fill, and KUB ultrasound was analyzed for PVR. The data were documented and analyzed. So, to the results, demographic results, the peak age was 63 to 67 years range, with a mean of 66. PVR, the median PVR was 112 mils with a range of 0 to 1011. 20 the PVR of greater than 100. For IPSS, the mean IPSS, that is within moderate. In terms of percentages, is as on the table there. 7 mild symptoms, 46% had moderate, and 35 had severe. So, regards the relationship between PVR and IPSS, a positive correlation between IPSS and PVR. You can see from the scatter plot, a graph rather. So results for PVR cutoff values done using receiver operating curves to determine the PVR cutoff values for mild, moderate, and severe IPSS. So for the mild of 0 to 7, the mean PVR was found to be 24 mils. And for the moderate category, that is IPSS of 19, the mean PVR was 111 mils. And for severe loads of 20 to 35, the mean PVR was found to be 345. So we go to the discussion. So post-void residual volume, urine volume, is an invasive, reliable, and widely used test. Its diagnostic accuracy has been in contention, so that is why we did the study. So as we saw, the mean PVR was 112. This was higher than from other studies. Late presentation in our setup. So PVR is as a consequence, bladder outlet obstruction or two, and active or a contracted bladder. So patients with other conditions that could PVR, except from BPE, were excluded from the study. Elevated PVR has been elevated PVR has been associated with progression of symptoms, upper urinary tract damage with obstructive uropathy, recurrent UTIs, and acute urine retention. In a study by Coleman et al., men with PVR of greater than mils at baseline were 3 times as of acute urine retention or catheterization at 3 to 4 years. So also PVR has been used to monitor and predict outcomes from BPE. The trial demonstrated a decrease in PVR from 106 mils to mils post-TURP. As we said, we found a positive correlation in our study, and the cutoffs for mild, moderate, and severe IPSS were 24, 111, and 345 mils. So, in conclusion, in our study, we found a positive correlation between IPSS and post-void residual urine volume. Then we deduced that PVR can accurately be used to diagnostic tool to quantify severity of loads in BPE. And secondly, PVR of 24 mils, 111 and 345 mild, moderate, and severe IPSS, respectively, used to as a guide to quantify Lutz risk severity. So I want to acknowledge my supervisor for my dissertation, Professor Dagwatha and Dr. Owila. So my references. Thank you very much.
Thank you, Dr. Madenge. You are actually ahead of time. Thank you for reminding us what we need to. I'm sure there will be a lot of discussion in the Q&A section. I want to introduce the next speaker. The next speaker is from South Africa. His name is James Van Halsett. He's a full of Glasgow Smith Climb as a specialist urologist. He's a co-chair of GSK Internal Urology Advisory and is a member of GSK Global Health and Catalyst. He is an honorary lecturer in the Division of Urology at Blood Medical School and an honorary consultant at hospital in Cape Town. He's going to tell us about predicting clinical outcomes in BPH. Welcome, Dr. James Halsett. Dr. James Halsett.
Thank you very much to the chair. I hope you can hear me. Can you hear me?
Oh, we can hear you, and we can see you also.
Okay.
Welcome.
I don't see the presentation up yet, but I'll start with the presentation. I just want to acknowledge the Kenyan Association of Urological Surgeons and say how much I admire the work you do, your outreach programs, the fact that your conference presents accessible presentations that are relevant to daily clinical.
Oh, we have lost you. You are muted. Dr. James, we cannot hear you. You are muted. Kindly unmute. Kindly unmute.
And now I'm unmuted on my presentation.
Now. Carry on. James, carry on.
So I'm muted now.
We can hear you now. Hear you now. Hear you now.
All right, thank you. So my presentation focuses on the still in correctly predicting what the outcomes are going to be, or in more accurately predicting outcomes. If I could see the presentation, that would be helpful, but I'm currently not seeing it.
We can't see the presentation yet.
In the absence of a presentation, I'm going to continue, and I'm just going to talk through this. So really what we have is a situation. Let me present a case. So we have a 65-year-old patient with an IPSS of 16, severe low urinary tract symptoms, which are mixed, and on clinical examination, he appears to have a prostate of greater than 40 grams. His rate is less than 10.6 mils per second. It's 9.4. His prostate volume on ultrasound is measured to be 43, and his PSA is 2.5. So this is a patient that we see every single day. The patient is obese, has hypertension, so likely has metabolic syndrome. And if we look at, thank you very much. So if we look at worldwide clinical practice for this kind of patient, he would be started on blockers. And I just want to then into where we are. So this would be slide number 5. If you put slide number 5 up, because I'm not able to change this. Where are we in the treatment of of low urinary tract symptoms. If we look at the most widely followed guidelines, there are 5 different drug classes. It really follows a route of symptoms and takes us to an option of 5 drug classes, but importantly, including watchful waiting, lifestyle advice, and again, going back to the previous presentation on metabolic syndrome and lifestyle modification, this is really important. Of these drug classes, the majority are orientated and make to relieve symptoms and to treat symptoms. Much of the data is only 6 months, so not long-term data, reductase inhibitors. So just a thought, but the majority of the drug classes that we offer patients are in treat symptoms. And I want to make a case that we should be more focused on progression. Next slide, please. So if we look at best practice around the world, and we look at, if we look at clinical practice around the world, there's a study from Spain. It's a real-world evidence study showing that of patients who started on medication, 60% start on an alpha blocker monotherapy, about 20% on combination therapy, and then varying lower percentages on phyto and monotherapy. This is the exact inverse of the epidemiology of patients who present with BPH, where about 75% of patients present with risk of progression. But that's what it is in the real world, and we see this mirrored everywhere. I use Spain because there's been an enormous amount of work between the Urological Association and primary care or family GPs in Spain to promote best practice and guidelines, but this remains entrenched clinical practice. Next slide, please. So what insight do we have on what clinical progression looks like? Well, we have the MTOP study published in 2003, and there was a arm in that MTOP study that was followed for a period of 5.5 years. These patients showed clinical progression, 17% overall. The majority of the progression was deterioration of IPSS of greater than 4 points, and that's a significant deterioration in symptoms, with about 6% of patients requiring surgery, about 2% of patients going into acute urinary retention. You need to remember that this was an all-comers trial. We'll never have the opportunity to study long-term outcomes of BPH in symptomatic men again, because we would not pass ethical clearance that we can intervene in a meaningful way in these patients. So this is really, but it's important to say if we studied an at-risk of patient population progression, we would see higher percentages. But this is an insight. Next slide, please. So the guidelines have evolved to reflect risk factors for progression, recognition that we have risk factors, and the risk factors listed here with age, severity, increased prostate volume.
Recording in progress.
Increased prostate volume of 30 mils, elevated PSA, lower Qmax, and post-void residual of greater than 39, and not a particularly high post-void residual volume. But these factors point to increased risk of progression, and the guidelines point to using this to choose optimal therapy for the patient. Next slide, please. But this individualized approach clearly offers challenges to clinicians, and the barriers to choosing optimal therapy relate around questions around efficacy, the potential benefit to patients, what the timing is, and safety considerations, particularly regarding sexual function. And so clinicians, particularly primary care clinicians, and in large parts of the world, BPH, the medical management is in the hands of GPs, opt for alpha blocker monotherapy. This revolves around ease of therapy. There's a quick response. Patients come in the next day. They say, my symptoms are much better. And the patient says, doctor, this is certainly noticed improvement and I can live like this. And the GP is not faced with challenges around PSA interpretation. However, the message that I want to take home is control symptoms, and we look in the long term. We may be masking disease progression. This is something that we should be more aware of clinically. We should be asking questions. We should be scrutinizing this and studying this more carefully. Next slide, please. So just to go back to this case study, this patient has several for progression by age, by IPSS symptom severity, prostate volume, PSA, and Qmax. but the alpha monotherapy, let's see what's going on. So next slide, please. Next slide will illustrate a point. So we look at the long-term growth of the prostate from these studies, which were helpful because these were alpha blocker arms and placebo arms. Average growth of the prostate is 4.5 to 5% per annum over a year period or a 5-year period. This translates into a prostate growth of between 20 and 24%. If we look at that patient who presented with a prostate volume of 43, in 4 to 5 years' time, that patient's prostate is more like 52, 53 grams if you start the patient on alpha blocker or if you are waiting. So there's ongoing prostate growth, and this will lead to a point later on into the next slide, please. We look at old studies like ALTES, which showed that alpha blockers do nothing to address the rate of acute urinary retention or the incidence of surgery over a 24-month period. Next slide, please. So this is quite interesting, and this illustrates the point of how difficult it is to predict outcomes. If you do an assessment of a meta-analysis of over 10,000 patients with BPH who are at risk of progression, the patient's clinical progression is not the same. So not all patients progress in the same way. And these graphs show IPSS. The top graphs show an IPSS starting point of approximately 16, like the patient I presented. And the lower graph show a starting IPSS of 20. And the pattern of progression in terms of symptom progression is the same. The middle graphs, those middle percentiles, the majority of patients out of the 10 will showing gradual progression, but the graphs on the far right-hand side showing rapid progression. And we don't have a good way yet of predicting who are going to be rapid progressors. These are patients we're interested in. We're also interested in the non-progressors on the left-hand side because those patients will do very well on watchful waiting and lifestyle advice. Slide, please. And this is from the same meta-analysis looking at the outcomes of acute urinary retention and surgery over a period, and the top graph showing more rapid progression in patients started on alpha blocker monotherapy, monitoring those patients over this 48-month period. The lowest graph, combination therapy, showing disease-modifying effect, but it's an important graph because over time these numbers start to be significant, and in terms of clinical outcomes, when we look at acute retention and surgery, that is quite impressive. But it's not the only story. We also have bladder remodeling, and we also have in lower urinary tract function. Next slide, please. So this is a congresses is we post-operative outcomes. We say approximately 25% of patients will remain on medical therapy post-operatively for BPH, and those patients for overactive bladder or whatever it may be, but they remain on medication. This publication pointed to much higher figures in the community. This publication pointed to about 45 up to 65% of patients post-operatively remaining on medical therapy for bothersome symptoms. I think that this points to an issue. Are we operating in a timely way? Are we identifying patients early enough? We used to be trained the patient needs to earn his operation. I think that needs early intervention, early disease-modifying effect with medical therapy or with surgical intervention will result in clinical outcomes to the point that we should be focusing not just on symptom control, but on disease process. And we have to try and find better risk indicators to identify those patients who benefit from early intervention. Next slide, please. So just to address this issue about sexually active patients, it's a recurring objection. It's a recurring objection worldwide to say, look, we can't give these patients combination therapy. The patient's young, he's sexually active, he wants to continue a sex life. So I'm really wary about starting the patient on medical therapy because adverse events, particularly sexual dysfunction. I want to just show in the next slide that we are starting to understand this better, but actually the data is quite old. If we look at Ray Rosen's study in European urology in 2003, Rosen showed a very, very clear correlation between severity and sexual dysfunction from the age of 50. So the patient we presented at age 65 with moderately severe low urinary tract symptoms, in Rosen's study of 11,000 surveys, he showed that the vast majority of those patients really have an element of erectile dysfunction and ejaculatory function. And at baseline, we assess these patients. We need to tease out which patients already have sexual function and which patients may have sexual function compromised by choice of next slide, please. And to show the graphs, but this was a randomized controlled clinical study on sexually active men, pH at risk of progression. And what this study showed was that if you start radiation therapy on these patients at the end of 12 months, there is a meaningful deterioration in their male sexual health questionnaire score. In other words, they show impact. The impact is almost entirely confined to the impact on ejaculation, not erectile function. And this is something as well that I think we need to do better to take on board baseline evaluation of sexual function, and then being able to counsel the patient in terms of the impact on sexual function, deterioration in ejaculatory function, and the solid circles are reflect erectile function and erectile function in this randomized trial, and there are very few randomized controlled clinical studies showing drug effect. A non-clinically significant in function in this patient. So let's just go to the next slide. So in summary, I believe that we are preoccupied with symptom control in BPH when we see our patients. I think we need to recognize disease progression. We certainly need to identify and address risk factors such as lifestyle, the metabolic syndrome. We need to actively encourage our patients. We need to establish baseline evaluation of the patient, looking at factors, factor that into our decision making, be brave about intervening with disease modifying effect, whether that's medical or surgical, and we need to be able to counsel our patients and give information about our therapeutic interventions. I hope that's helpful, and I hope that this is clear. Thank you very much.
Thank you, Dr. Halsett. Indeed, it has been helpful, and we appreciate your presentation. We are short of time, so we are only going to entertain questions, what you may call burning questions, so that we can take our, so that we can go to the exhibition. We need to visit us. They make a lot of difference in our conference. Dr. assist me with this microphone, and we pick up 3 questions. Oh, we have there. Okay. Questions, Q&A, or comment?
Is listening or is able to hear this. He's raised some important things that we need to look at in patients with the BPH. And he's rightly said that in patients with BPH will occur in spite of the use of medical interventions, and that we have always known. But him to tell us is, would use of drugs mitigate against the progression? Does it affect progression at all, or is it not doing anything to the progression? Because what we've been told in the past is that it does affect progression. Is it true that the progression will go on irrespective of drugs? We need to know patients who are on drugs and those who are not on drugs, who progresses faster. Because that's the answer you want to know. Who progresses faster? Because if it postpones surgery, that's what we've been selling to our patients. Van Halsett and I have the last 5 years, and that is sexual dysfunction. Nobody has looked at patients with sexual dysfunction baseline and then how they have fared with the use of therapy. Not everybody, but patients with sexual dysfunction at baseline further with the use of the therapy, alpha blocker, and that is going to be important for us, because whenever we have had this discussion, I find my patients who have given combination therapy, and there's a significant tell you, Dr. Can you give me another drug? This drug is my sexual function poorly. I would prefer surgery. And it's mentioned that, which is also true, that a lot of patients who have surgery continue to use drugs. how would selection of patients affect this particular affect? Because this is not new. We've always known that some patients are not happy with surgery, but other people advance the view that the reason they are unhappy at surgery is because they offered surgery in the first instance. Thank you.
You can unmute.
Okay. Thank you very much, Professor Mungai, for raising these important topics. So we really have good evidence from the MTOP study, the conduct study. So there's a series of studies which are now reflected in that the disease-modifying effect offered by rise certainly reduces the risk of clinical progression events, not just symptoms, but also in terms of acute retention and surgery. And the relative risk reduction is in the order of 60%. And the number needed to treat, which is probably a more from the way that study was structured, but from about 11 or 12 patients. And in the conduct study, which was interesting because these were men who were less severely symptomatic, the number needed to treat was lower. If we look at statins, and I haven't looked at this issue for a long time, but if we look at statins and the number needed to treat to avoid an adverse event is higher than that as far as I remember, and in some cases dramatically higher. So I think that there's evidence to show that there is actual reduction in disease progression, and there's never been a claim that it removes the risk of progression, but certainly in comparison, it's different. We know from our clinical experience, we have patients who've been on combination I've got a patient who I've followed for up to 20 years, and this patient continues to be happy. Now, the point is, and this is not to say that we have perfect solutions, the point is that we don't want to overtreat. So we don't want to get into this prescribing cascade, but if we were able to better recognize, we don't have good answers yet, if we are able to better recognize and better categorize those patients who really are at risk of running into issues of tension, Bph complications like bleeding or higher post-void residual volumes predisposing them to urinary tract infections, and we identify those patients who would be great candidates for early intervention with disease-modifying or offering them surgery. But we know that the real world is operate on these patients. Not all patients want surgery, and when we do operate on patients, the vast majority of our patients will have permanent ejaculatory dysfunction. And when I see patients who come to me and they say, I've seen one of your prescribed this combination, I'm not happy because my sexual function has changed. We really go into it in detail. They are talking about orgasm and ejaculation. And when I ask them, what about erectile function? They say, no, that's okay, but when it's just not the same. And they are complaining about ejaculation. And I say, look, this is the balance. This is the way the drug works. And predominantly implicated, the 5-hour is implicated in reduced volume. But in terms of your question about what about patients, looking at patients who already have some compromise in their erectile function, I think that is built into Roborn and Rosen's study, their prospective study of 500 patients, randomizing them to placebo, combination therapy, and looking at those patients, because those patients, by definition, to Rosen's study in 2003, several of those patients would already have had a net reduction in stiffness or already experiencing ejaculatory dysfunction to an extent. And the importance of that was to look at how much their sexual function deteriorates. Those patients on combination therapy reported a significant deterioration in ejaculatory function. That's clear. But what was interesting is that they did not report a clinically significant deterioration in erectile function. That was an unexpected finding.
Next question. Dr. Ikol.
Thank you very much. My question is related to Dr. Dr. Karo's presentation on performing urine culture. Was it all endourological procedures or all interventions? Maybe from a show of hands, I wanted to inquire of us routinely perform urine cultures before procedures. Okay, most hands are down. Are we seeing too many problems because we are not performing these urine cultures?
Thank you, Dr. Icon. Thank you, Dr. Now for urine culture should be performed before you do procedures. You're likely to breach the mucosa. For example, you're doing TRPs, if you're nephrostomy tube insertions, basically all procedures that you're likely to the mucosa minus catheterizations. But if there's a risk of traumatic catheterization, you should also do urine cultures and treat. And you do cultures and treat. Before you do the procedure, make sure that the culture is negative. Don't assume it's negative. You use fluoroquinolines.
You can continue with the same question if that is what you're asking.
Yes, same question that Dr. Icon is talking about from the patient cultures in Kisumu. About 30 to 40 patients have drug-resistant infections. So I think we patient for doing cultures before endourological procedures in this country than in the we have a very liberal antibiotic use and bad complications for missed I think it's something that we should adopt.
Thank you, Dr. Opondo. Dr. Icon, thank you for raising that question. I think we have been seeing complications in septicemia when we operate on patients who have urine cultures. I think it's something we need to embrace. The last question will come from Kabuni. Can you take the microphone? Yeah, you come.
All mothers who are in this room know that by the time you come to see me, even antibiotics. So I don't know the relevance of those cultures, what adults do for obvious reasons, but I don't know the relevance of those cultures, whether we should continue treating and what should we use in treating. A patient who has got UTI, they just are crying when micturating, so you are going for the signs, and there is no culture, though there was bacteria. I don't know what is the attitude and the advice that to do. And again, in pediatrics, possibly there is a paper which is going to what you do in a patient who has got febrile urinary infection. The AUA had given us guidelines. Are they still the same? Because we took a long time. Footy, febrile urinary tract infections, especially in children. And just as a rider for Prof, a lot of Peter, Professor Gogi, Peter, we used to be good friends, and so I haven't changed the name. A lot of patients now coming to my office, babies or children, 7 years, 5 to 7 years, with a referral of erectile dysfunction. These children have stopped having erections, and the mothers are sending them. We're going to start making a new diagnosis of erectile dysfunction in children. And is erectile dysfunction and sexual dysfunction synonymous? Are they interchangeable? Because these are children with erectile dysfunction. Peter.
Thank you, Fred Kabuni, for your concern. I've always advocated for children, and most of the time I hear you asking, do you have a prostate in the children? For the interest of time, because we have a break, I would actually urge you to consider a tea break. Make sure somebody answers Dr. Kabuni's questions. Been back here at 11 o'clock for the next, which is about interactive session on urolithiasis. Thank you very much for listening to us.
Clinic Hospital of Urology in Spain. Dr. Martinez is a staff specialist doctor since 2018 at the stone disease unit in one of the hospitals in Spain. Currently, is a staff specialist doctor disease unit in Barcelona, Spain. Performed workshops as a professor, PCN, RIRS, stone disease, surgical treatment, various centers. He has a great interest in HOLEP, RIRS workshop, which he has run in. He is accredited with the European Association of Urology, and his talk is sponsored by CC Pharmaceuticals. Welcome, Dr. Martinez.
Good morning. You hear me? Good morning. Good morning. Do you hear me?
Good morning from Ururu, Kenya. Welcome, we can hear you.
I don't know if you hear me in the room.
We hear you now. Please proceed. Go ahead, we can hear you.
I have no sound. I don't know if you hear me properly.
Can hear you.
Okay, perfect. So I hope you can see my slides now.
Yes, sir.
Perfect, and I will start the talk. First of all, I would like to thank the organizer for inviting me to this talk and all the colleagues who are attending in this room. We are going to talk about the medical treatment and prevention of kidney stones, and we will talk about inhibitors like phytate or citate. And this is important because nowadays we have new improvements. Every year we have new developments for surgical treatment for this disease, for kidney stones. But the prevalence of this disease is increasing in the last decade. It means also an increase in the healthcare system cost, but it also means a decrease in the quality of life of our patients, and also a decrease in the expectancy and the life expectancy of our patient, because we already know that those patients who has a recurrent disease, who are recurrent stone former, will have 2 times more risk of end-stage renal disease. So the target should be to prevent new episodes in those patients who has recurrent kidney stone formation. According to the different steps that happens when a kidney stone is being developed, we can modify 4 factors in order to reduce the risk of new stones. The main 3 factors are concentration, the concentration of different elements, the urinary pH, and the concentration of inhibitors that try to avoid the development of a kidney stones. There are different types of kidney stones, but if we focus the treatment in the main ones, which are calcium stones, we usually use 2 drugs, thiazide in order to reduce the most frequently abnormality we find in the 24-hour potassium citrate, which is the drug that try to increase the concentration of this inhibitor in the urine, which is the second abnormality we usually find in calcium stone former, hypocitraturia. So we are trying to focus the talk in inhibitors. Firstly, we are going to talk about the more studied one, which is citrate. Citrate is a weak organic acid. We can increase the concentration in our urine of citrate if we increase in our diet citrus fruits, but we have to increase a really huge quantity of citrus fruit in order to achieve the same concentration if we compare it with dietary supplementation. So we usually use citrate salts like potassium citrate in order to increase its concentration. And it is excreted in the urine, and it is interesting because it works as a chelator of calcium, so it reduces the concentration of calcium in the urine, but it also reduces the nucleation, the aggregation, and the growth of new crystals. So it is a potent inhibitor of calcium stone development. But which evidence do we have to say that? There is only just one randomized controlled clinic published in 1993 in which compare potassium citrate with placebo in calcium stone former, but in those patients who has hypocitraturia. And there was a significantly reduction in the number of episodes after fixed 36 months of follow-up. So in this concrete group of patients, we will find a benefit if we use potassium citrate in those patients with calcium stone who has hypocitraturia. On the other hand, we have to keep in mind that after those studies, we have now evidence enough to say that potassium magnesium citrate is even more potent and more powerful than potassium citrate. So if we are thinking in giving our patient supplements of potassium citrate because they have hypocitraturia, we should also be thinking in using potassium magnesium citrate in order to have even more benefits for our patient. But what is the main problem when we try to prevent new episodes? There are treatment limitations because there are patients who have side effects or contraindication for the use of potassium citrate. They can have gastrointestinal discomfort when they take those pills. They can have chronic kidney disease, and we can use potassium citrate because of the risk of potassium, or even we cannot use potassium citrate if we have also infected stone associated with calcium stone. But also there are patients in which we have a completely normal metabolic study, or even we are treating them, we are using pharmacological treatment, they have also recurrence. So what can we do in those patients in which we have correct their metabolic abnormality, or we don't find any abnormality in the metabolic workout, or they do not tolerate the treatment? Well, that's why it's so important now to talk about phytate. Phytate is a phytic acid. It is present in the skin of cereals and legumes, and it is a chelator of different ions like calcium. And it is interesting because close to 100 years ago, it has been studied the link of phytic acid and bone disease. But in the 70s, there were also studies trying to find if it could be useful, the use of phytic acid in those diseases where there was precipitation of calcium precipitation in tissues, like vascular calcification or kidney stones. And nowadays, we know that it is a potent inhibitor of calcium precipitation with no risk for bone disease. And why can we say that? Well, the first hypothesis was said by Dr. Modlin in 1918, who hypothesized that those patients who has a rich diet in phytate has a lower risk of kidney stones. And it was shown and it was demonstrated in 2004 in the huge Nurse Health Study 2 with more than 90,000 women, in which it was shown that a diet rich in phytate has a significantly reduction in the risk of kidney stones. Those women who has a richer diet in phytate has lower risk of developing this disease. That's why some groups, like the group of Dr. Graces in Spain, are trying to see if it could be a pharmacological treatment or a treatment in order to prevent new episodes of kidney stones. And it's very interesting because they saw that if we use dietary supplements in order to increase the concentration of phytate, it increases in healthy and in kidney stone formers. And in the lab, it has been shown that with this study of SO in 2007, that phytate reduce the saturation of calcium, reduce crystal formation, and reduce crystal growth. So it could be a potent treatment in order to reduce the recurrence in calcium stone formers. Why? Because phytate seems to act in all the steps in the development of a kidney stone, in saturation, nucleation, in aggregation, and in growth. And up to my knowledge, this is the first study addressing this point. It has been published 1 month ago in the Spanish Association of Urology meeting. And in this study, in calcium stone formers of phytate every day for 3 months, there has been a significantly reduction in the concentration on calcium when we compare with the placebo group. But also, and this is very interesting, there was a reduction in cross-lab parameters. So this study suggests that we reduce the risk of kidney stone formation and also increase the bone health of those patients. And we also know that patients with kidney stone has an increased risk of osteopenia and osteoporosis. So it is very interesting because it seems that it can be a very powerful weapon in order to reduce the risk of kidney stone and also to increase the bone health. So as a conclusion, we have to keep in mind that there is a really important increase in prevalence in the last decades in kidney stone, that we have very limited treatment in order to reduce this prevalence. And nowadays we know that those patients which a richer diet in phytate has less risk of kidney stone. And if we supplement the diet of those patients with kidney stone, we can increase the concentration of phytic acid in the urine, and we can reduce the concentration of calcium in this urine. So probably we will reduce the risk of new episode of clinical kidney stone. Thank you very much.
Thank you very much, Dr. Batides. Maybe we can just have 1 or 2 questions, and I'll request Dr. Martinez to stay online so that we can all participate in the online session. Any burning question? Okay, no burning question. Okay, no burning question.
Thank you, Dr. Martinez. We'll proceed to the next session. We're going to have an interactive session on stone disease, and we have about 3, perhaps 4 or 5 pages. Dr. Awath, Dr. Nyoro, could you come and display the slides, please? Would ask Dr. Aidid, Dr. Kasim, and Dr. Kimani, kindly, if you can come forward, pick up a seat from the side, and help us in the discussion with for the first case. Kasim, Abdallah, Dr. Kimani. I think you, as we present the case, you will help us understand the films, the diagnosis, and the approach to treatment. Come with some seats, I did. Carry a seat from me. So, the first case, I think both are ladies. Okay, yeah. Could we start, Doctor? So, scroll the slide, please. Nyoro, let's come and do it for us. You can scroll the slides for us. So I'll give the history from here. And we need the microphone with these guys. So the first case is a 45-year-old female, hypertensive on X-Forge and Losatas HT, had hematuria 8 years ago, and then 8 years ago a CT scan showed a right staghorn calculi. At that time we were not quite proficient with PCNL, so she was sent to India, Multiby Patel, and the Desai Mahesh team did a multi-track PCNA. We saw her in 2019, and she had a 1.1 times 0.1 times 1.5 centimeter in the right upper pole, and she was reluctant to have any intervention. She came back to me 20th of January this year with recurrent UTI and was on treatment with nitrofurantoin, no hematuria. Okay, proceed. Next slide. And those are her recent CT. We've just tried to highlight the right kidney and a bit of the left kidney. So I would ask Dr. Kimani to start us off. What is the diagnosis? Is it a new stone? Is it a remnant of the previous surgery?
Yeah, the first thing is to ask ourselves whether we had any postoperative images after the first PCNL. Because if then the stone fragments were there, then one could argue that they were residual stones that have grown. But if the previous images showed complete resolution, and this is what we have, then consider it a second stone. What is important and what I see is the proximity of that stone within the parenchyma, perhaps indicating a calcareous stone. And if the first image one will go with it, looks like a narrow infundibulum of that calyx. And those would be some of the considerations one will put in this case.
Okay, thank you. I think indeed you're right. We didn't have CT scans after the procedure. I think we did one after a few years after she came back. Dr. Aidid?
I think I agree largely with Dr. Kimani, and especially even at 2019 is when we had a stone that was 1.1, isn't it? We don't have maybe the images to see whether that's also intraparenchymal, and I think the rest I agree with him. The management then will proceed further or proceed like that because of the position of that stone.
Yeah, thank you for allowing me to participate in this forum. I largely agree with my colleagues, but the only other thing which maybe I would like to add is that if there was any metabolic workup, in the first instance. And with that, maybe it can give us some guidance whether she's a stone former. Maybe if that could have changed a scenario of treatment and prevention of urolithiasis. Thank you.
Good, thank you. So one of the questions we are asking the audience, is it an intraparenchymal stone, or is it in the calyces, or is it narrow infundibulum, like Kimani says? And what are your considerations as you for intervention? What would be your choice of intervention? Start again with Dr. Kimani.
Yeah, if we are to look at the EAU guidelines on stone size and location, it's unfortunate. I think I heard it's an upper tract, it's an upper calyx stone, and it's less than 2 centimeters, because those are the calculations one would make. Then we will find that the 3 major options are available. That means PCNL is available, RS, and ESWL. However, because of the presence of infections, being an infection stones, perhaps, and the abnormal anatomy that is, then ESWL is certainly knocked out. So you are left with the PCNL and RIRS. Now, the success of RIRS depends on, one, your ability to access that stone. And that is why this is one of the areas you don't just operate with an uncontrast film. Perhaps a good contrast films with the construction helpful. In fact, even answering the question of whether it's a parenchymal stone or it's a calyceous stone. But given the two, if it's a narrow infundibulum that is able to widening by laser, it can be done. And if not, PCNL becomes a consideration. But when you do PCNL, we must appreciate that you will have to find some ways to apply your guide wire within that very narrow and very thin cortex. And that makes it a difficult affair.
Good. Dr. Edith, apart from what Kimani has said and what you're going to say, would you consider laparoscopy?
Okay, laparoscopy, now as we are gathering our own experience, I think this we will not consider at all. For the indications for laparoscopy, you should have a renal pelvis. And I've seen sometimes that we just go in without considering CT scans and seeing that you have got a generous pelvis which you can open and access the stones. And sometimes intrarenal pelvises, actually, we have a valsed urethra. It was very difficult to reanastomose. So, notwithstanding, this stone is also intrarenal. I mean, intrarenal, but intraparenchymal, I mean. So, access of laparoscopy also not feasible here. I think laparoscopy, I will from the list for this patient. The other thing is, PCNL will have been also high on the list, but access will be an issue because you will be right on the target of the stone. You will have problems with the dilation, going through, and the guidance will be an issue as well. RIS also has a lot of challenges. Of course, here is where you will want an II theater for sure. Most of us nowadays, we don't even operate with II. Here is mandatory, at least to guide you if the stenosis, where at least you can, do a little bit of a tissue lasering, at least for access. I think let me stop at there for now.
So Dr. Abdallah, apart from the infundibular stenosis, would you be worried about the thin cortex?
Yeah, I think definitely I would be. And actually I'm a proponent of RIRS. I think I would knock out, definitely as my colleague said, Dr. Kimani, that AESWL will be out of question because of the narrow infundibulum, and that will be difficult for those fragments to expel out. So then we are left with these two, but still I think SNL is a bit tricky here in this sense, the sense that the anatomy if you look at the anatomy, if you look at the far end picture to your right, I think it does anatomy very, very well. And if you look, there is a shadow of there, and also there is also a liver there. So I think here you have the problem of if you are not very, very conversant with pump, you can end up with a lot of complications as far as PCNL is concerned. So I think an RIS would be a very safe procedure to do, and the anatomy illustrates that there is an infundibulum, though it's narrow. You can actually enlarge that infundibula with a laser, and you can fragment the stone and dust it, and you get away with it. I think that would be the best way. I would go that route. Thank you.
Would you be worried with propulsing the stone out of the kidney?
Come again?
Would you be worried with hitting the stone out of the kidney when you're doing your RIS?
No, it's sitting in the middle calyx. I think that's you can actually dust it there, and that gives you, you don't have to really look for fragments elsewhere.
What do you want? Yes, Kimani.
As far as stone retroperfusion is concerned, it's not concerned when you're doing RIRS. It's a patient who has had previous tract, actually multiple tracts for PCNL, and therefore even when you're pumping your water, is not unusual for you to get a calyceal rupture. So it's a real risk and real possibility.
Okay, we'll take one or two burning questions. His hand is up. And
Sorry,
Patrick.
before maybe open to questions,
Yeah, continue.
Just one last comment. If it is a discussion about general management, I think also we should not lose the chance of open. Because, I mean, you can palpate that one from the kidney side and remove it, because it's going to be an issue of stone clearance of all these other minimal access kind of management. So I think that's also something that can be considered.
Okay, good. Okay.
Yeah, thank you very much. In situations where we can do this kind of surgery, if possible, and I'm sure we will get there, when RIRS guide wire, then patient is in supine position and you can probably do a supine PCNL. Is that an option?
Okay. Anyone of you wants to take it? I did.
Combined, yes, it's still feasible because at least you are combining two modalities. But remember when, but remember when we are combining, you're using as guidance from the light of the ureteroscope. You want to, number one. Number two, not just the light as well, the eye that you're using, the radio opaqueness of your ureteroscope. Then you want to enter at that point, the puncture. And so still feasible because you're combining those two, but notwithstanding as the discussion had foregone about each case of each. It still is the limitation, retropulsion, spread of infection, and I think.
Let's have Patrick to comment and also tell us.
I just needed clarification. If I remember my days,
yes.
Either the interlobular vessels run along the infundibulum, and I've been hearing guys saying that they will incise the infundibulum. Are we incising the infundibulum or incise a small opening of a calyceal diverticulum which has in it? I just need some clarification.
Dr. Kimani.
The small aperture of the infundibulum is what you incise, and it's usually most of the times bloodless. But if you go on the sides of the papillae, then you're going to encounter torrential bleeding.
Patrick, the stone is right on laparoscopy.
So you can see there's only a capsule. If that's not an optical illusion from the CT, there's only the kidney separating the from the outside of the kidney. So, but if you do laparoscopy and inside a prolonged leak, because doing rhinorrhaphy typically there might be challenging, unless you're a real expert. Maybe you do partials. So that would be my worry. Leak despite putting a stent and whatever.
Okay. Just to answer Patrick on that, the question which he posed for as far as bleeding is concerned, when you incise the infundibulum, I think from my experience is that I think like do a very deep incision, you just do enough to get your scope in. So once your scope is, I think that's it. So if you make a generous incision, I think you're definitely at a risk of bleeding. But if you just make an enough incision for the scope, for the flexible uretroscope.
I think it should be to
Yes, just maybe a contribution or a query to the presentation. I think you mentioned that presented or the patient presented with hematuria. Not get any other presentation. Should you say symptoms of maybe some severe pain or recurrent UTIs? This is a lady who you have mentioned is unwilling to have surgery. We are spending a lot of which surgical modality we are going to give the patient. Is there a possibility of basically management without surgery? Because where the one is situated, there is no obstruction. And keep the surgical options away from her.
Yeah, I think we mentioned that she has had recurrent pain. She doesn't have hematuria this time. She didn't want surgery. She seems now inclined towards surgery. Yeah. Professor Mungai?
Thank you. Looking at repeat surgeries can be deceiving. And the one thing, and I don't know whether the best laparoscopist would want to be in an area where you have had multiple punctures of the from outside, accessing that kidney laparoscopy is technically very, very challenging. I don't know where you would reach it. Mobilizing that kidney laparoscopically could end up injuring the kidney itself. So I think a laparoscopic approach is a particularly difficult one. You're probably, if you're going to decide you want to get to the kidney stone, go open, remove it. But in terms of, if you're going to do PCNL, the same track that is probably accessible. If you look, even though you are accessing the app, you can still go below the liver, and the bowel that looks there is probably far away if you're going to do it from a prone position, so you can that kidney from behind and access that. If you look, there is a rim of urine that stone, so you can be able to access that kidney stone, and then yes, the cortex through which you have to go is actually smaller. What you might not have is enough room, working room, but you will be able to access the kidney. But working room is going to be different, but you can start by where you reach the stone, because that's the first thing. Put a guide wire, you'll be able to do it. Thank you.
I think Adib, you can conclude for us.
Okay. As I conclude about the laparoscopy, I agree with you, but we've also done some with even who have had nephrostomies, which are very difficult to even mobilize off. My only challenge here will be, number one, you lose the tactile. The way you will palpate that stone to be just pop on the point where the stone is, so that you minimize bleeding. That also control of bleeding. Also, that will be a challenge. So I think for the open will be better than the laparoscopy in this regard, not withstanding the adhesions that will be there.
Comment from Dr. Pondo.
Sorry.
Give us a comment.
Yes.
PCNL.
Yeah, I think this patient is whichever way you look at it, or open. But if you showed the videos, the images, you'll notice that there's an opportunity to do
access to this stone without going through the what Patrick was calling the false capsule. This shows the images. You can do a track that goes almost tangential to the stone, and you are able to dilate it. The reason we're trying to avoid that other side, the lateral side of the stone, because I suspect there might have of the colon to this kidney. So that injury is actually real. But if you should do PCNL and you feel uncomfortable, this is the kind of a patient that you can do their puncture with CT guidance. So we have done that, a similar case of a patient with an anterior diverticulum stone with a large split colon. And if you place this patient prone on the CT gantry, you are able to collimate and actually do your access CT guidance, and then you have all the precision, and then you use mini space. The stone is 1.5. I see a rim of about 5 millimeters. That is already 2 centimeter working space. So if you do a mini pack with CT guidance access, then you're able to avoid the fistula, avoid injury, and avoid the risk of bleeding that would come with any renal access to the stone.
I think Dr. Pondo, my question, I was going to ask you which modality of PCNL you. I think you have mentioned the mini pack. Certainly, a standard PCNL would be extremely difficult.
Is a complex stone, and therefore the patient that once we do a retrograde pyelogram, and then we can discuss treatment modality. Anatomy actually give
discussion, input, Dr. Bondo, Dr. Kasim, and even Patrick and Professor. Good question from Chavda and Dr. Misango. I think we'll go to the next one. We can continue during break or lunchtime on this case. I haven't. I actually need to be guided on what to do. Thank you. We will have a case number 2 discussed with Professor Mungai, our chairman Patrick Mburugu, and case number 2, please. Thank you. Good. Could we start? 34-year-old female, para 0 + 0, right upper quadrant abdominal pain and swelling, fever, chills, and weight loss. No hematuria. Palpable right iliac fossa, right upper quadrant mass extending up to the right iliac fossa. Good. Those are her films. Those are the pre-contrast. Professor, maybe being the teacher here, you could take the students through CT urogram. The diagnosis, possible diagnosis. Yeah.
Can I get the history back again?
Okay. It's a
34-year-old lady with upper quadrant pain and swelling, fever, chills, no hematuria, palpable quadrant mass. So go now to the films, and you see a lot of cysts in that kidney. There are multiple cysts in that kidney. Perhaps on the far left, there may be a calcareous stone, and there may be stone in the pelvis of the. But the for this patient, the reason she has pain is the renal cyst, and I would have wanted to know if this is a familial cystic disease. The opposite kidney looks okay. That kidney is not hydronephrotic. You get told it is hydronephrotic. That kidney is a polycystic disease of the kidney. with stones. Now, and so there you go. Yeah, you didn't want to show me that. So there you have the polycystic disease. And we have a growing staghorn. Obviously, it looks smaller than the kidney because the kidney is cystic, but it is a big staghorn. It just looks small because the kidney is big. But that is a sizable staghorn. And we've got 2 other stones. And these stones are not the cause of this patient's pain. I wouldn't call these symptomatic stones. Perhaps you need to deal with I don't see the urethra. Is there another film that shows us? Okay. This is unilateral polycystic disease of, and we are not we see the urethra now down. Contrast? No.
It's an arterial phase, so
yeah.
Arterial phase.
Yeah, that's the arterial phase. So with the arterial phase, you have that. You can see the kidney very well. So that's the arterial phase. You see the. Yeah. Sorry. Another image. Yes. So that is the image of contrast. The other one was the image with contrast. This one is contrast. Yeah. So if it has contrast, of course the kidney is hardly functional. It's a polycystic disease. Okay? You don't see the urethra at all because when you go along the source, you don't see the urethra. So it still remains a polycystic disease. Probably this kidney has become known. There's very little cortex to talk about in this patient. Most of the cortex has disappeared and is probably too polycystic to be functional.
Okay.
So it is not the cause of pain. The stone is not the cause of pain. The pain is due to polycystic disease.
Okay. Dr. Pondo, what's your take?
Yeah, so this I agree with Prof that a cystic kidney disease, but just one thing that the contralateral kidney does not have cyst. So we are dealing with a cystic disease that could be secondary to the stones, and we have to mention that we could be dealing with pyonephrosis, which is the cause of pain in these patients. One would need to measure the Hounsfield unit of that cystic, a little bit dense than ordinary fluid would be, but because to make a clear determination. The second thing to note is that this patient's renal pelvis, and when you have a contracted renal pelvis, must be either a congenital thing that was going on there, or there is a fibrotic responding to the stone. When you gave the initial presentation and I saw the stone before you put the contrast, I thought we were dealing with xanthogranulomatous pyelonephritis, which is one. If you just told us what the HB is, then we would consider that very strongly. It is one of the rare complications of stones. You get big kidneys. The only thing is that they are less cystic. They have a greater proportion of solid components. So yes, in brief, it's a complicated stone, most likely non-functioning kidney. We're going to discuss the treatment options, but one should entertain XGP kidney as one of the issues.
Good. Okay, Patrick, tuongoze.
Nothing much to add. I think everything that there is to be said. It's just that I'm still not sure whether this is massive hydronephrotic cystic kidney. It's a difficult call. Further. Phase yet. So, like I said, we would need more information. Okay, so there you have the excretory phase. The left kidney is excreting well. You can see the ureter on the far right picture. It's draining. Our stones remain unchanged. There is no damage. So most likely non-functional.
Yeah. So are those loculations or cysts?
That's why I'm saying it's a difficult call to make. Okay. I don't know whether it is massively hydronephrotic kidney or whether it's cyst. it's difficult to make the call. Cyst would be circular. These do not look in one of the
so
in the last
good
picture.
So Dr. Pondo, you talked about pelvis. Yes. X-rays again. It details.
Yeah, so this looks contracted, and you see a stone impacted in the pelvis. If you look at the communication actually between would look like cyst, and the reality is that still images like this would not give you. This is where you need to scroll through the images, and each of those each of the dilations to be able to determine whether there is contiguity and access to each other. That middle image, you can see that they are communicating, which now beats the definition of a true definition of a cyst. So this it's more or less a compartment which is communicating with each other.
Good. Prof, would you like to change your mind from a cyst?
Yes, I agree. As we look at them, we find that the cysts as the usual cyst, and those septi in between the cysts are functional. If you look carefully, those areas between the contrast, but they have their function, so that the renal pelvis did not opacity. I'm just wondering whether I'm seeing gas outside that kidney. If you look surrounding it, like there is gas about it, but she was not for gas in the kidney. So it could be just an infection of this kidney, but it's a big kidney. It's palpable. It's compared to the opposite kidney is about 5 times the size of a kidney. So it could well be obstructed, or could it be that this patient had a ureter ligated or something that happened because it didn't get enough time to dilate the system. You sometimes see patients who have had ureteric ligation. You have ureteric ligation, it just expands and stays like that. And what you are seeing is fluid, the calcified fluid that remains in the collecting system of a kidney that was PUJ obstruction in this, but you could have this as something that was tied lower down.
PUJ or not?
Yeah, I agree with Prof that by classical definition of PUJ, it's a J, it's the junction. So, but this is a contracted pelvis. So we can talk about a pelvic obstruction, but not a PUJ obstruction.
Okay, good. Patrick, what tests would you do in this patient? Any further tests?
So in terms of febrile, of course you'd want to do the usual markers for infection, full blood, blah blah blah, CRPs, and of course to see what to put. And then we are not sure as of now whether there's any function. So some people might argue for this on the direct renogram would be misleading. So you could probably just go with a CT scan and say maybe it's non-functional. And like we said, you could probably want to go through this with your radiologist on the console, so that you get better anatomy than you're just being given on the stills. She has multiple stones, so some people, since now you're going to leave her with only one kidney, for doing metabolic workup so that you safeguard the other kidney with fight it. So yeah, that's what I'll do until now.
I was just wondering whether we couldn't put a catheter through a flexible scope and do a retropielogram and see whether the ureter has any communication with the pelvis. And we would seeing the transverse sections. Of course, you have shown us some coronal ones, but if you had this patient on the console and you did this, you'd be able to. Oh, that's what you didn't show us. All right. Was flexible ureteroscope retrograde? No PUJ obstruction. The ureter is bladder. The stone, but that looks like the stone bulge in the pelvis, and it was. Could it have happened so suddenly? Kidney became non-functional very quickly, and I don't know what I'm seeing on the left. That's I know the left or our patient's left. My left is this is the kidney that we are talking. I have wanted to know what this ureter on my left. That is the right patient's right ureter. What is happening to it?
She has had no intervention, no surgery, just treatment for PUD for a long time.
Treatment for PUD. But then how did it shrink? She doesn't have a dilated system, and the left kidney is normal.
Okay. So what would be your mode of management, Prof?
This kidney is not working. Has not worked for many years. And all I need to know is what is the at removing. Why do I want to remove the kidney in the first place? The reason why I want to remove this kidney is going to cause infection, sepsis, and she can get sick from this. And because her left kidney is good, we have no problem with her left kidney. I'd remove this kidney stones. It's not serving any purpose.
Okay. Would you remove?
Yes, I agree with Prof. There's just some data that is missing that Patrick asked for. The patient's CRP, HB, and white cell count.
HB was low. We
correct.
On the first urinalysis, we put our nitrofurantoin.
Yeah. So E. coli with the pan sensitivity is a generally sensitive organism. Yeah. So, and the patient at this time is febrile.
She had fever on and off.
On and off.
Yeah, she wasn't febrile.
Okay. So my feeling is that we are dealing with a pyonephrotic kidney, and even the thickness, Prof, that we are seeing there is probably out of inflammation on those. What you have two options. If the patient is febrile, that is 38, 40s, one I would do an ultrasound and nephrostomy to cool her down. After that, I would consider doing a nephrectomy.
Patrick, you said about a nephrectomy long ago. Want to do that?
Now that she's septic, you will need to drain the kidney before the nephrectomy. But just looking at that reconstruction, and there is a very nice move of the pelvis and the two collecting systems in that big stone. And this is most likely what caused the obstruction, which just ends. You can even see the point which points to the ureter. So probably that was the cause that finished. It was what finished the stone. I mean the kidney. So now that we know she's infected, I would go the way Dead has said.
Okay. If you're going to drain now, you're going to approach it. Show us the films again. Those are independent loculi.
Look, if you look at the middle image, there are two things that tells me that these things are communicating. One is the presence of that lateral stone. we don't get cysts generally unless it's a diverticulum stone. Second thing is the homogeneity of the content of those spaces, and the middle image suggests that there is at least some communication. So what I would do is a real time. Some of these we now have to make intraoperative decisions. Remember, every amount of drainage of pus helps to decompress the pressure so that the translocation of bacteria reduces. So I would go with ultrasound guidance and drain one of the septae and just put negative pressure and see the response on the others. Remember, our primary aim in drainage here is not to get rid of the pus absolutely. That we can only achieve by doing is to get the patient out of fever, number one, and to avoid intraoperative large volume spillage. So as long, because this is very, if you look at the posterior side that is towards the psoas, there's already a tissue reaction there. This is a chronic reaction. So if you're going to do incision, that dissection to the hilum is going to be difficult. So you want to decompress the system, because you know we're going to spend time there, and with the around that it's very easy to get spillage. So you have spillage and long intraoperative duration. That's why we decompress.
Good. So I did a DTPA, perhaps hastened my decision to do a nephrectomy, and I did a very difficult nephrectomy. But if you show us the coronal pictures, show us the coronal pictures. The coronal city. You can see there the liver to that. There is no plane. And so if you look at my specimen, the Gerota's fascia attached to the liver. I mean, so that that's what we had. I did not decompress. I think after 19, I threw a subcostal incision so that you get to the hilum. About the duodenum and the liver, and yeah, this was a difficult nephrectomy. I think tumor nephrectomy is easier than this. Just go back to the images, the delayed picture there. I think if you see that delayed picture on my left, I think there is a contracted pelvis and a stone. There is an enlarged kidney with multiloculation. With an eye of faith, you can see what they call the bare pore sign. And so this case was a case of granulomatous pyelonephritis. It's a rare condition. I think this is the second one I've seen. And so you have chronic inflammation, because of the calculi, chronic inflammation. You have E. coli in this case, both and post-op. We had pus, actually. So, and then you had all this perinephric fat reaction. So, to be a granulomatous pyelonephritis. Thank you very much.
You are very lucky here, because a lot of granulomatous pyelonephritis, the patients are more sick. They have underlying conditions, usually diabetes and immunocompromised. So you don't find this in a 34-year-old. The ones I've found are elderly men and women with diabetes or people with but for a 34-year-old, yes, that is very rare. It is mostly in immunocompromised and elderly patients, and they are very, very sick. CRP was almost within the normal range.
I didn't do a C. I can't.
And the WBC count? You had to transfuse. A lot of these patients have to be transfused perioperatively. Thanks.
Yeah. Thanks, SNK. This is a nice case of just emphasizing the difficulties with ex-GP kidneys. And for the students, ESR is one of the things that can lead you. If you find a hydronephrotic kidney, large kidney with stones, ESR and HB, and they mimic renal cancer. So the patient sometimes gets scared that they have cancer, and then they turn out to be just not a difficult surgery, and one has to be prepared for it, like you say. Sometimes you have to do some element subcapsular, like probably what you did, right? Thanks.
Yes, and to add to the method of nephrectomy, this is not a kidney you want to go in laparoscopically unless you're a real guru. Because the only one time I've ever seen transection of the renal vein was in an attempted nephrectomy of an ex-GP kidney by a real guru. So you go in laparoscopically there at your own peril.
We did one when we were training in Stellenbosch. The professor did one, and we transfused 16 units of blood. In this case, we did not transfuse. We were lucky. Well, we did transfuse. We did not. Can you hear me now? We transfused preoperatively, and I did not drain the kidney, so we had a stormy postoperative period for 2 days. And she was 53 kilos. This was in October, and she's now 69 kilos. Yeah. Thank you.
Thank you very much, SNK, for this presentation. Maybe just put back the city. There's one thing, the take-home messages, the radiological sign he has mentioned, and there was an image which was shown where there was an indication there is an uptake of contrast, but it's good for us to understand that is in an XGP kidney, you have hypervascularity of the remaining cortex, and that is what actually looks like an uptake of contrast. I think for purposes of this section 2A, we have come to the end. We now have to go to section 2B, and the chairs will be PG Burugo, Matu, and Wambani. Thank you very much.
MMS. Is MMS here? Do you have members of MMS? Can you find out if any of the county people are around? Oh, I see. Thank you. Thank you for showing yourself. So we come to section 2B, which is basically the opening ceremony. And as you can see, we will have an address by the local organizing committee chair, followed by an introduction of the keynote speaker by Dr. Wambani, a short introduction, and then a speech by our keynote speaker for this year, Professor Peter Lawrence Waweru Ndagawata, who is a professor of urology at the University of Nairobi. We'll then have the East African Kidney Institute director's address given by the director of the East African Kidney Institute, Professor Mungai, and then we'll have a presentation by a county government representative. So let's try to keep to time. And my co-chairs are, like has been said, Dr. Maurice Wambani, who is a urologist and a member of the National Organizing Committee for cows. And on my right is our treasurer, Dr. Joshua Matu, who is a urologist in Nairobi and Kitui, and like I said, our treasurer. So, Dr. Charles Waihenya, please come and give your speech.
Good morning. I want to take this opportunity to welcome you to Thompson Falls, that is Nyahururu as currently known, where clouds fall from the sky because of the temperatures that sometimes can go so low here. I'm sure most of you experience the temperatures in the night, especially in the early morning. For my speech, I am going to read. I was the local organizing committee chairman, so you'll allow me to read my address. Now, ladies and gentlemen, it is my pleasure and honor to welcome every one of you to Nyahururu town, formerly known as Thompson Falls. This is our 14th annual scientific conference, whose theme is embracing current urological technology in the counties. During the 2021 AGM meeting, after a very successful workshop in Kitui County, Kenya Association of Urological Surgeons, in collaboration with other partners, passed a vote to hold the 2022 COWS Workshop and Conference in my hometown, Nyahururu, in Laikipia County. We felt it was important to also include Olkalau in Nyandarua County. This would enable us to serve many deserving patients from the two counties who had challenges in accessing urological services and care. A local organizing committee was formed to spearhead the activities of the 2022 Urological Workshop and Conference in collaboration with Kenya Association of Urological Surgeon Workshop Organizing Committee. The fact-finding mission began in March 2021. I was appointed the chairman, and Mr. Gitonga, the nursing manager of LHS Nyahururu, the secretary of the local organizing committee, to lead this team. I would like to thank the team for the immense support, availability, and enthusiasm to ensure the workshop was a true success. It has been 1 year of hard work and traveling as we made preparations for the workshop, bearing in mind we are not resident in the two counties. 6 hospitals were selected for this workshop: J.M. Karaoke Memorial and Referral County Hospital, Pine Hospital in Nyandarua, and Laikipia Health Services Nyahururu, Pope Benedict XVI, Oljabet Hospital, and Charity Hospital in Nyahururu, Laikipia County. All in all, we had 2 county hospitals and 4 private hospitals were included. I would like to thank our God in heaven for giving you a heart of charity. The county governments of Laikipia and Nyandarua, the various hospitals mentioned above, for hosting us unconditionally and contributing their staff, materials, and Mrs. Maitai of Nyandarua and Laikipia counties respectively. The Director of Medical Services for Laikipia County, Dr. Waihenya, my namesake, for his valuable contribution, guidance, and support. My sincere gratitudes go out to the CEO of J.M. Karaoke Memorial and Referral Hospital, Dr. Rachel Kenyanjui, who is with us today, who has worked with us in this journey. Despite being a gynecologist, she reviewed and booked the patients with us. She organized for the waiver of all the patients who do not have NHI cover. And personally, she was there to oversee the operations and clerking of the patients, including pre- and post-operative ward rounds. I also extend my gratitude to the urologist, the anesthesiologist, stroke anesthetists, the urology registrars, nurses, and support staff who have traveled from all over, who worked without micromanagement. A special gratitude to the nursing officer of LH Nyahururu, Mr. Gitonga, and all those in various hospitals who were members of the local organizing committee from June 2021 to date. The management of LH Nyahururu housed our meetings every month and ensured we were well fed. A special mention for Dr. Kanina, Brigadier Wawero, Dr. Washira Jaga, formerly of AMREF Flying Doctors, Professor Mongai Ngoge, whose wisdom was sought from time to time. I wish to appreciate the COWS National Organizing Committee, led by Dr. Patrick Brugo, whose support to the local organizing committee was unparalleled. They took their time away from their busy schedule in Nairobi and took 2 fact-finding trips to Nyahururu and Olkalau. I will not forget our secretariat, Medics Management Services, under the leadership of Kathy Jage, who have tirelessly worked with us on this journey and made sure we were comfortable during the workshop and preparation for this conference. The administrative officer, a sheriff from Kenyatta National Hospital, in her private capacity, offered a lot of support and transported our participants and equipment between the two counties. Our friends from the industry, Olympus, Carol Stores, National Insurance Fund, Glenmark, and others who donated their manpower and equipment that made this workshop a success. It is possible to call out, it is not possible to call out on all those who supported us, but whatever contribution you made, you are in our hearts. We worked for 3 days, from Monday, Tuesday, and yesterday, Wednesday, in all the 6 hospitals, and we managed to operate a total of 204 patients. Both adults and children. And if we were to count the number of procedures, then we would be talking about 230 procedures. We managed, of course, that has always been our... The operations we did included laser lithotripsy, DJ stenting, laser and urological pyrotomy, TURPs, cystoscopies, DVIUs, TURBTs for bladder tumors, open prostatectomies, orchidopexy, hypospadias, herniatomy, and herniorrhaphies, urethral. We had a few general surgical patients like the hernias, but for heaven's sake, we would not have turned them away. One case that humbled me was a 70-year-old man from Dodori, Wakiongo, who has had a urethral catheter for the last 6 years after an episode of urine retention and remained unattended due to lack of money, not even to pay for NHIF rebate. He was returned to the ward on Tuesday because he was the last patient and the team was tired. Coincidentally, it was, as it were, he was again the last patient yesterday, Wednesday. And I listened to his story where he almost made me shed a tear. However, he was operated on and his surgery ended at 8:30 in the evening. The other case is a mother who learned about the camp at lunch hour yesterday on Wednesday and remembers that his son had undescended testes. He had been attending various hospitals for the last 6 years with endless TCA to come again. He collected the child from school and brought him to us with a bundle of old hospital cards, and he was never operated. They were all full of TCAs. The workshop and conference has also continues to serve as a training forum for the urology students and nurses, including 6th-year medical students from Kenyatta University, who assisted in capturing our data during the workshop, especially in JEM referral hospital. Despite the last-minute withdrawal of Kenyatta National Hospital, who have always been a major contributor to this workshop, we have managed to deliver our mandate as COWS, whose objective is to promote and regulate the science and practice of urology in Kenya. I would like to encourage the members of COWS and our partners to take advantage of this gap that exists of charity. I want to urge the county government of Nyandarua to at least provide a general surgeon at JEM, Karaoke, and referral hospital where there is none, so that by the services they deserve. I would like to welcome you once again to Nyahururu. Kindly take your time to visit our tourist attraction sites, including Thompson Falls, the 74-meter fall high on River Ewasongiro, and the hippos therein, Aberdare National Park, Lake Olbolsat, and for the golf lovers, like Professor Dagwada, please enjoy a 9-hole play at our Nyahuru Sports Club. With those few remarks, I cannot hide my joy. May the Lord our God keep you and bless you, pay you handsome for the work you have done. Please enjoy the conference. And finally, today is my birthday. Kindly wish me not just a happy birthday, but a joyful birthday. And thank you for listening to me. Make sure you visit Thompson's Falls, the Thompson's Falls Fall. Enjoy. You can climb all the way down, about 100 meters, and enjoy the breeze of the wet fall as you shed a kilo or two. God bless you, and welcome to Nyahururu.
Happy birthday, Charles, and many, many, many more. Where's the bash? Yes. Okay. So I introduce Dr. Morris Ombani to give a citation for our keynote speaker, Sandagwada.
Put on the slide, please. Put on the slide for citation. What he was in 1977 when he finished medical school. Professor Dagwada, Peter Larry, that's he graduated from the medical school of the University of Nairobi in 1977, 45 years ago. Did his internship at the then Coast General Hospital in Mombasa. He later was posted to Embu District Hospital as a medical officer. Okay. As I said, he was later posted to Embu District Hospital as a medical officer. He joined KNH as a senior house officer in surgery in 1979. He obtained M.Med surgery, upon which he worked briefly as a general surgeon in Murang'a District Hospital before joining the surgical department with the University of Nairobi as a lecturer in 1986. Through the Commonwealth Medical Urology Fellowship Program, he received his urology training in the UK between 1989 and 1990. This involved attachment to Nottingham University Hospitals and the Institute of Urology in London, where he worked among others John Blandy and Tony Mandy. He joined the surgical department of the University of Nairobi upon coming back, where he rose through the ranks of lecturer, senior lecturer, and subsequently professor. He has worked with the leading surgeons in Kenya, East Africa, and Africa. In urology, he was mentored by the late Professor Nelson Awori and Professor Joseph Oliech. Peter Dagwada has dedicated his entire urological work, entire working life, spanning over 40 years in teaching, research, and practice of surgery at the medical school. He has mentored many surgeons, and indeed most of the surgeons here and have gone through him, past and present. He has many publications to his credit, supervised many postgraduate surgical candidates. He has been chairman of the surgical department, been external examiner in many other medical institutions. He's a founder member of the Surgical Society of Kenya, the Pan-African Association of Urological Surgeons, Kenya Association of Urological Surgeons, among others. He has been part of the team involved in the formulation of the curriculum for the M.Med Urology of the University of Nairobi. He's a senior member of COUS, Pausa, EAU, and PAUS. He just retired from the University of Nairobi recently to actively, but he's not tired. But he's still actively involved in the activities of the association. He remains a pillar of support in the practice of surgery in the country. I feel privileged to invite Peter LW Mother to the guest speaker.
Thank you, Patrick. I didn't know that you know all my names. I'm privileged. Now, I'm very privileged to be invited here to give a short speech on the history of urology in Kenya. As you have heard, I don't think I needed to introduce myself. My name speaks for itself. I'm going to give a brief history on how we started and how and why we are here today. What I can say is that the history of urology in Kenya can be said to have been one of the ingredients of general surgery. And in the past, all the urological procedures were preserved of the general surgeons who had interest in the practice of urology in Kenya. But we do know that the majority of these surgeons were trained both as undergraduate and postgraduates in Makerere because University of Nairobi did not exist as such until 1969, but before it was a constituent college of East Africa. So in 1967, most of you remember Professor Joseph Mungai, along with the previous cabinet secretary called Dr. Joroge Mungai, who sat down and said that instead of sending the students to Makerere or Europe, we better have our own university. And they started the Faculty of Medicine in Nairobi, where the clinical area was based in Chiromo. Oh, okay. Lakini imekwama. Hakuna. Sorry about that. This is what we call the technology mishaps. I should have used my own. Let me use my own.
As we sort out the technology, I think I can still go on with whatever I had on my laptop. I'll start again. In 1967, July, as I have said earlier, the Faculty of Medicine was started in Nairobi, and the preclinical department were based in Chiromo, and the clinical areas in Kenyatta National Hospital. It's good to say that apart from the general surgeons who were incorporating in teaching the other graduates, it was not until 1970, so it is recent, 1970, when there was a general surgeon who had a great interest in urology. His name was Mr. Green, who started urology as a single person, but he had to enlist the help of other general surgeons. He was lucky. In the same year, he was joined by another fully qualified urologist from Makerere University, and his name was Mr. Henry Benjamin Obonyo, who later on was also added. That time, there was a gentleman who had gone to UK to study obs and gynae, but later on he changed to general surgeon. He developed an interest in urology, that is the late Professor Nelson Awori. And that's why when we talk of urology in Kenya, we cannot talk without mentioning the name Professor Awori. Now, 3 of them worked until mid-70s when they were joined by Professor J.S. Oliech, who augmented this team, along with 1978, when this gentleman that we need to highlight, Simon Kagiri Drango, who joined them as a tutorial fellow. And although he was a tutorial fellow, he worked like a full-fledged urologist because he had a lot of interest. Now, the 3 of them, Professor Awori, Oliech, and Kagiri, did a lot, but Kagiri had to leave the department to go to UK in 1985 to study urology, where he stayed for about 1 or 2 years. In his void, the department found that there was a void, and I needed to come. Actually, that time I was working in Muranga as a general surgeon, but I was recruited in 1986, where I worked for some time. The following year, there was a gentleman who was in Lagos working there as a urologist. Most of you know Professor Magoha. He joined us in 1888, yes. And now we had a good group of urologists in the department. But since I was a junior person, I was not trained fully in urology. Kagiri, when he was a tutorial fellow, along with Professor Awori, they were credited with the first kidney transplant in a very unfortunate young lady from Turkana, from Pokot, but actually she was a Turkana. She was named Kokoini in 1978. The problem with this girl is that she had a pelvic kidney, or rather a horseshoe kidney, which the visiting surgeon then thought was a pelvic mass. But unfortunately, those days we used to believe that any mass in the abdomen belongs to the pathologist. So unfortunately now this mass happened to be a horseshoe kidney, and the child now went into renal failure. The AMULEF, Dr. Wachira is here, did a very good job. They flew this child to Nairobi. Why this child was not taken to Kenyatta Hospital is because that time Kenyatta had not developed fully on dialysis. There was a Dr. Baksho, who was then the president's physician, through her own offices, she was able to get a crude dialysis machine. So this girl was kept on dialysis machine. But luckily, there was another chap who was in ICU with brain death. So I don't know how it happened, but from the records, it is said that he did not offer his kidney, but I think the system facilitated getting the kidney. Yeah. So that was the beginning of or rather it was an evolution in Kenya. We started now the kidney transplant. However crude it was. This child survived for about 2 years. And the reason why the child survived for 2 years is because at that time, around the same time that this transplant was going on, we were fortunate now to have a resident, fully trained pediatric surgeon and urologist, and most of you have gone through the hands of Professor Chambi, and you know how meticulous he was. So he assisted in that transplant, and because these were small vessels, the big surgeons, as they were called, were not able to maneuver, but he assisted them a lot. And that's how it is said that that team did open the eyes, the government saw that there was a need of developing the urology. Now, as I mentioned earlier, Kagiri had to go away for urology in UK, where later on Ndaguada and Magoha joined the team and augmented. Now, as we were being trained, from that time, 1978, the practice of urology now improved a bit. And it's good to say that until 2013, most of the operations were being done both in Nairobi Hospital and Aga Khan Hospital, because Kenyatta had not bought the machines. But soon after that, with the help of Professor Ongeri, I think you know him, there was Dr. Abdallah, and who was the other one? And Doris Kenodia, who was a pediatric nephrologist. Actually, I did a lot of work with her in Gertrude. Did acquire some machines, and that was time now when we started training the local nephrologists. And by 2013, about 100 transplants had been done, which is a credit to that group. Nephrologists and urologists started now working together very harmoniously. The only problem that we had at that time is that the vascular, those of you who are doing transplants today, the vascular anastomosis was a bit of a problem. But when I came back from UK, because I found that the transplant is not a big deal, in fact, there it is being done, it was being done by the registrars at night, because they use the cantavalic transplant. So I involved the vascular surgeons to be a part of the team. And actually they felt very appreciated, and the procedures now went on and on. That's why these figures now rose to about 100. As we are here now, why are we here? Before 1992, there were a few urologists trained, and most of them were working individually. As you know, there was what the late Professor Awori used to call the comeback syndrome. Dr. Mathu Awori knows about that, the comeback syndrome. So people were working independently. But we thought perhaps it is good to have a joint sessions in the evenings. So 3 surgeons, led by Kagiri Dirango, Samnaki, and I, decided to have a joint group for discussions like those two cases that were presented by Waberu, this is how we started. And we found that there was a need of incorporating more people. But it was not until 1992 when the then chairman of the department was requested by Dr. Alex Danso to avail some surgeons who are interested in urology to go there and launch what now was called Pan-Africa, that's PAUSA, Pan-Africa, what is it? Yeah, whatever. When we went there, we were amazed. We found that the South Africans, the Egyptians, and a few people from West Africa, mainly Ghana, not Nigeria, but Ghana, they were really organized. They had local chapters. So when we came back, we said, why can't we start? And again, the same group invited now the surgeons who are there practicing urology. There was Professor Oliech, who is our father in general surgery and urology. There was Magoha now, and there was Robin Mogere and Richard Baraza, and another one called Dr. Dhaka, who are practicing privately in Aga Khan and MP Shah. When we met, we discussed how do we come together and form a local chapter within the POSA. And because most of us were members of BAUS, we decided now to plagiarize the word BAUS, and we formed CAUS. Instead of British, we said Kenya. We did not seek permission from BAUS. I don't know whether they can sue us or not. So we formed CAUS. Now, with formation of CAUS, we realized that we required the help of the pediatric surgeons because of the pediatric age group. We were lucky then because Professor Kiambi was around. There was Dr. Wachira, Nelson Wachira, and Dungu, who were incorporated into the group then. And we encouraged people who are interested in urology to go further and study urology. So after some time, we saw an increase of the number of more urologists because some of the people who had gone out for training were coming back. And the majority of these people went to Moshi. It's a credit to a professor called Professor Escherman, who really was very keen to train the local people. There are also some people who went to South Africa, like my namesake there, Dr. Waberu. Others went to Egypt. And recently, of course, there were some people who were in Korea. By 2015, we had increased the number of the CAUS members to about 32. If I'm not correct with the figures, you correct me. 32 by 2015. Then, during our regular Saturday meetings, one of us, and I believe is Dr. Kanyi and his group, who proposed that since now we have a large number of urologists, why can't we start our local faculty which can train the urologist? And him and his select committee were tasked to draw a curriculum. But they said since the Department of Surgery was within CAUS, and they are teaching, they are teachers, so then we needed now to go in and formalize this curriculum. Professor Mungai there and Professor Oliech, Owila, and I, plus a few urologists in Kenyatta, that's Dr. Monda and Otele, were very instrumental in drawing up this curriculum. And we started the program in 2013. And since then, we can stand here with this group, with these people who are here, as well as you people who are sitting there. Since we started, the first group, we could not get the intake then because there was already an existing MD programs, and we have changed the curriculum from 3 years to 5 years. But we allowed people who are doing the basic sciences, if they developed interest in their that year, to join the program, the area of their interest. There was one chap called Dr. Kagiri. I don't know whether he's around here. He's one of the pioneers. He's around. He's not here. Who was alone. So actually, you can understand how somebody can be greeted by so many people. Even during the examination, Dr. Awira commented that we are harassing this chap because all of us are on one candidate. And Professor Magoha did not want to mince any word. Actually, Mungai is the one who was trying to temper, Professor Magoha, because he was a bit rough. He didn't mean to be rough, but he wanted to know whether this chap is enough to work in the district or not, alone, without any supervision. Now, with that, we had now started a proper training program. And the first lot which came, I believe I saw some of them here. There is Dr. Amandi, Abonyo, Omito, and Buru, who are the second lot. They went through difficulties, but with the help of the faculty in Kenyatta campus, that when I talk of Kenyatta campus, I'm talking of the university and people working for the Department of Surgery in Kenyatta. We did a lot of work and they were able to go out. And I'm happy, Mr. Chairman, deliberately, I sat somewhere and I watched them doing the TURP. I can sit back and present my prostate to them because I'm very happy. The next group, at least this time we had problems because of the sponsorship at rest. There was a Dr. Hamed, Shak, and Nyaga. Are they here? Yeah, a few, I think some of them are there here. Then the following year, that is the fourth group, we had the largest group. I think there were 8, Dr. Wira. Yeah, there were 8. There were 7. 3, 4, 5, 6, 8. All right. This morning, you heard the presentation of 2 ladies. The first 2 African ladies to qualify as a urologist. And I think we can give them a big clap. Then there are, of course, because of the gender issue, we should not leave men alone. Even the ones who are men and not women, we can clap for them. Then, in December, we are expecting to graduate another 5. Next year, in projection, we have 4. So you can see that we have grown over time from being 3, 6, 30 to the current group. Now, Professor Mungai can sit there and smile a bit because in the department, as we sat, we were lucky to hijack a program that was supposed to have gone elsewhere, but he was, through his good offices and a good articulations, he convinced the then DMS, instead of having a trauma center, because people are going to India for the stone surgery and kidney transplants, we formed something called the Kenya Kidney Institute. But we had wanted to form a fellowship, or rather a postgraduate fellowship school for the urologists now who are being trained to go there and do the fellowships. Our aim initially was to train general surgeons. Later on, those people can go and form another group now of adult urology and pediatric urology. Currently, the pediatrician or the pediatric surgeons are doing a very good job. You had a joke this morning from a pediatric surgeon who was asking about the erectile dysfunction in a 5-year-old. I don't know whether he was joking or he was serious. Where have we come from in Kenya? You know, medical services in this country have been very tortuous. This is how we began. You can see that thatched house there. That was a rural health center, which was improved by the other one. And these two diagrams are a replica of what was happening in the country. Can you go on, please? Next. And the colonial time was still there. You see, this is the hospital staff who were working there, how they were dressed. They were like askaris. In fact, most of the hospitals used to be run like a military barracks. And every morning, these people had to parade. And they more go along to inspect whether they are clean or not, and whether their uniform is starched. I don't know whether some of you know this about starch. And press so that that line, if you are not careful, it can give you a linear laceration. So that's how we are. Now, around 1934 or so, now Dr. Mungai is lucky because where Iyaki now is shooted, that's where there was what we call the civil native hospital, which was made of timber, and you can see that timber there. Don't ask me how I got these pictures. I had to do a bit of research to get them, which later on had to be shifted because of the problems. That place was infested with rats and all those things. So they went down and put up that building, which is down there. That then was the King George. And you can see how it was, King George. Most of you who are trained in Kenyatta went through the old hospital, and you can see now it is not like that. It's improved. Even Nairobi Hospital was copied along that model. All right? So now, today, as we are discussing, can't we say that we have come from very far? Because those surgeons who are practicing urology then, they were doing open surgery. Good discussion about that stone with that patient that Dr. Well presented. And most of the operations, for you to be called a general surgeon with urological intent or intention, you have to do prostatectomy properly. And I can tell you, when you are learning, we used to float the days when they have done these operations, because at night you cannot sleep. Most of the operations were suprapubic, a lot of leakages, etc. All right? Then, but before that, there was another chap who came to Kenya from India who was called Dr. Kandivi. How many of you remember Dr. Kandivi? Yes? Who introduced a perineal route. But I'm telling you, he had problems with general surgeons. He was vilified. I don't know why we don't like new innovations in Kenya. These are the operations which were being done in America and Europe. He had to do a few cases, then he ran away, he went to Eldoret. I don't know whether he did those ones or not. Now, around 1989, no, 85, 86, Professor Ulich now introduced TUR. But then, TUR then was not the way we know it. In fact, we were just looking in, do cystoscopy. If they find a tumor, they had to open and cystofilgrate the tumor. We didn't have an instrument. Later on, we improved. We had now the proper cystoscopes. Now, Kagiri and I, having come now from Europe, we introduced the proper TUR. And we were credited with a few TUR procedures before now we gave to other people. Now, those days, we didn't have the luxury of, go on, please. We didn't have, yeah, go on, go on. Go on. Go on. We'll come back to that. Go on. We are trying to rush. So you can see the instrument that we had then were these crude ones. But later on, we acquired these ones, and now we are able to do. But the problem then, even if we had these instruments, it was a one-man show. We had only one eyepiece where you used to go like this, and we were always bending our backs like that. By the time you finish one procedure, you have a backache. And teaching was a problem because you look for the ureteric orifice. Now you tell your assistant, come and see this. This is the ureter which is here. By the time you come in, you can't see the ureteric orifice, but you are scared of telling the your instructor that you are not seeing it. Oh yes, I've seen it. Yeah? Now, we had to improvise that. We bought another instrument which was incorporated to the telescope. It was a flexible one. There are two types actually. There's one which is articulated and another one is flexible. So that one, at least now, you can show the learner what you are doing. Because there was a bit of lying. You should ask somebody, here is the router. And then you come out and then you say, oh, we have done a good job. But you know that you have not done a good job. Now, with those equipments, there is no lying. So you have to show them where the ureteric orifices are, even where the tumors are. Then soon after that, you people are lucky. You have the machines which can show you the images in the open procedure. No, I mean the images which are augmented, and you are able to now, instead of having problems of the back, the ergonomics of urological surgery has been revolutionized because you can sit comfortably on your chair and you start doing the work. The way now you are seeing these machines here. What else can we say now, Patrick? You remember some years back, because some of us who are trained in Europe were not trained with this single eyepiece. They were trained with these towers. And sometimes the towers can fail. And when they fail, what can you do? You have to go back to what our forefathers were doing. But it is not the same. The vision, you see that one, how that person is bedding like that. See the back. Huh? That guy in future would have had problems with the back. Go on. That instrument, you can see what is down there and what is there. Go on. Now you can see now the comfort. People are dissecting when they are looking up like that. Even stonework has really been made easy by this. This now, you people are lucky because, let's go ahead. If for those of you who don't want to do open surgery, there's that problem or that procedure where you put some instruments and you look inside to see. And this work, we need to give the gynecologists credit because they are the ones who revolutionized this. And you can see that gynecologist. He's looking at the ovaries and the rest. And you can see the back because even those days, they didn't have the screens as such. Later on, these laparoscopies, and today, laparoscopy is the thing today. And it has made everything, what was very difficult then, to be easy to be done. For instance, if you are removing the stones, you know, most of our patients had very big scars. Huh? And aesthetically, some of them were coming with the incisional hernias, with another abdomen protruding laterally. Today, that's something which is history, is not big enough. Even things like pyeloplasty. Today now you can do all this. Yeah? And life has become very easy. The problem is that not every hospital can afford that, but we need now, before I say that, there's something else. Let's go back, please. No, there's something that you had flashed and then you... Yeah, go on. Go on. Oh, you're going backwards. Go forwards. Huh? Sorry, forward. That one there. You see that? Now, this is something that we thought was impossible in the past, where somebody can sit somewhere and the machine is doing the work for him. This robotic surgery. And very soon, I think, since now we are very many here, I think some of us will invest in that, but it's not 1 or 2 shillings. And yeah, you cannot do robotic surgery unless you have done your laparoscopic work, because actually it's the same principle, only that you those arms are controlled. The controller is sitting somewhere else, but the ports are more or less the same. Now this is where we are today. What lessons can we learn? Is only that we have to thank the Almighty God. He has given us the wisdom to be where we are. Our dream now, since now we are increasing the number of urologists, and you can see this room is full. Formerly, in fact, if you got 10 people, you are lucky. But now you can see, I don't know what is the attendance today, and you can see all this. We are very happy to see this. Now, with the urologists, what is the way forward now? Our dream is we needed now to form what we call the specialist units. And these special units can have some special people with special interests. We need to have about 7 groups in urology. We need to have pediatric urologists. We need to have the radiologists, uro-oncologists. What is can you make me? Reconstructive surgeons and the renal stone guys, so that we have the perfect work. Actually, there are about 7 areas. And don't forget the transplant. If you are doing transplant, you are doing transplant mainly. We don't want people now to be jack of all trades. If you want to master something, if you are a reconstructive surgeon, just concentrate on that area. If you are a stone person, there. And that's why now, with PSNL, which we thought were impossible, Dr. Opondo now, you have a very heavy load. You need to train many people so that at least we have a center in Kisumu, we have one in Nyeri, Mombasa. Do you have? Abdallah, why are you keeping quiet? Yeah, okay. He's in private, maybe that's why. Yes, we need to have all these centers so that there's no reason of saying that you want to take patients to India or UK. And in fact, now since we started, Dr. Brugu will attest, since he's our boss here, he will attest to the fact that we have reduced the number of patients going abroad for this operation, because we have had some commitment from NHIF. And I think now we need now to return a good favor to them and do good jobs. And I think with that, when I exit this podium, I'm very happy to see that, and I'm going to report back to my senior, Professor Oliech, because, by the way, I forgot to pass his greetings, that he wished this group a successful outcome. And I need to tell him that his works were not all in vain. And the Almighty God, wherever he has kept Kagiri and Oliech, he knows that he started a good job in Kenya. With those few words, I think I better close. Thank you.
Thank you very much, Professor Peter Ndagwatha, for that great and inspiring speech. The take-home message is that when you are determined, you can be anything. They started cows when we had 3 or 4 members. Now we have 48 members. What could be done in these centers that time, we're able to do almost 80% of the procedures done worldwide. The next speaker is Professor Peter Mungai Ngugi. Professor Mungai is not new to us. He's a district urologist, professor of urology in University of Nairobi, the director for IACI. IACI and the cows have a long intertwined relationship. He's the main sponsor of workshops for the last 6 months. He's the professor behind today's massive attendance. Without Professor Mungai's support, we can't be here today, and you can see we're house full. He has sponsored more than 70% of the participants for the workshop and the conference. Professor Mungai, we don't take that for granted, and we're very grateful for your support. We only wish that you maintain the position in IACI so that cows can prosper and grow big. Welcome and address us. Thank you very much.
Thank you very much, Dr. Matu, the Executive Committee of cows, all invited guests, participants, and all others with other roles, our exhibitors. It's my great pleasure today to once again talk about IACI. If you have a few slides, if they can be able to project them, I'm okay. When I look at the room today, I feel greatly honored. In 1994, when I went to the UK for training, I was sent by Simon Kagiri Dirango to go and train in urology. And while I stayed there, I was offered to stay. But I wanted home. I come from here, the weather is nice. It can get cold in the night, but it doesn't become anywhere near the English weather. So there was no way I was going to have the English weather. The slides are still opening. So my whole idea of, please get the presentation for me. As I left, there was a dinner held on my behalf by the Sussex County and Brighton General Hospitals. And the CEO, the head of the NHF Trust there, had decided to come for this party for this young man who had stayed there for some time. And he asked me, now that you're going back to Kenya, where are you going back and what is your dream? And I used to admire some people like Tony Monday at the Institute. I can't get my presentation, yeah? But I can go on. I used to admire the London Institute of Urology, where we wanted to train. And my dream was, and that's what I said, that the day there will be an Institute of Urology and Nephrology at the University of Nairobi, I'll have done my part for Kenya. I didn't know it would happen, but today it is a reality. Put it on slideshow. Today it's a reality. Professor Ndagwetha, Professor Oliech, I truly thank you for having helped me go through this. This institute was going to combine the functions that Professor Ndagwetha talked about. It had 3 thematic areas: urology, nephrology, and nursing. Right now it has expanded a little bit more than that. A few changes have happened. I don't know whether I should say this loudly. Sometimes you have clouds, but it always changes. So even the weather that you've seen now that did look favorable to you as IACI, because cows owns IACI, will either pass or rain. They will not remain there forever. And so it used to be then in the College of Health Sciences, which has since been broken down, and now we're under the Faculty of Health Sciences. It's still the East Africa Kidney Institute. Most of the secretariat that we had have been taken away. It was launched in October 2014, and like Professor Ndagwetha said, the main reason was 2 things. One was transplant as a big issue in this country. 2, urology. Remember, prostate cancer. Around that time, very many people were talking about their prostate cancer. So it was not very difficult to get the institute together. But the key thing that got this, it is when I was called one afternoon, after having been bashed by the principal of the college for talking about it all the time and talking to my boss about it and making him have difficulties, is that I was actually talking about it. And I had many presentations. Kenya was very helpful in what we did. Cows was very important in this, and so was the Kenya Renal Association. The 2 organizations that really own East African Kidney Institute. So when I was asked to present, to be the chair of a committee to run this, it happened that I had it on my iPhone, and after I was the then director of KNH suggested my iPhone, which is what you'll be able to. In our language, we are told, mwanaume atembei bila fimbo, because if you don't have it, you may not go. So that was it. Now, why were we looking at this? The kidney diseases, the neurological diseases, a major cause of disability and death in this part of the world, and they are very poorly served. Urologists have made her said that there's a big burden of prostate cancer in this part of the world. A lot of them go unnoticed, and the majority of our percent of our patients present with undiagnosed metastatic prostate cancer. A lot of our patients with end-stage renal disease present without even knowing that they had it. Recently, a chairman of the and told me he has gone into end-stage renal disease. He doesn't even know how it came. He only knew he had some hypertension, but he didn't even know they found he had a creatinine of 1,000. The other day, somebody very big in the society rang me because he was very worried of a PSA of 6. And I thought it was trivial. But he wanted everything done. He wanted an MRI, he wanted a PET scan. Never, I've learned, ignore. When we did an MRI, he had a suspicious lesion with a PSA of 6. When we did a biopsy, he had a Gleason 10 tumor. When we further evaluated him, we then looked back at the PET scans and the MRI. He had metastases in the spine. So these are diseases that you people know how to treat every day, but sometimes I don't know how to treat. If Dr. Jokin Jirain is here, we were just discussing this patient while she was still in Nairobi. And those are some of the challenges that we get on diagnosis. And that's why the Institute was made, so that we can treat our patients better. Urology is a nascent trade in our country. Nephrology even bigger. Of what we've done. And that's why I said mwanaume ni effort. Around 2010, we were looking at the dialyzing patients, and there's a girl we had acquired from Barcelona, and with that we talked to NHIF. Little do people know that we were the first to ask NHIF. Now they with the training, the first people who would oversee this dialysis, and we have trained more than 300 staff who are overseeing the dialysis in the entire republic, both in the private and the public sector. We trained the first nephrologists for this country, both adult and pediatric. We did the first nephrology nursing, both in diploma and at the master's level. And parcel of this hierarchy. It's just that we had to go step by step. And we are where we are because of a lot of people. And never is it a one-person thing. So you've seen that vision that we had, that we should be internationally recognized. I had thought of this when I saw the Institute of Urology in London. We had to provide quality education, and we had to contribute to the development of skilled manpower in this region. And we had to contribute to manpower mobility in this region. And just a few weeks ago, I think it was 2 weeks ago, the Medical Practitioners and Dentists Board looked, I was supposed to go to that meeting in Mombasa, but I couldn't make it because of other things we were doing. Look at the harmonizing curricula, and it was attended by people from all over Africa. Because we must do this. It is now not possible to send people to Europe to train in urology like I did and Patrick did. It is virtually impossible. Getting people to go and train in South Africa is also closing. But probably you don't need to. Because like what we have seen here, there are many people in Europe, many trainees in Europe who would like to see what you saw. But not only did we become a Kenyan institute, we became an East African institute. We became an East African institute, so we are training for both Kenya, Uganda, Tanzania, Sudan, Burundi, and the South Africa and Rwanda. And that was the dream I had in 1996. How good it is to see your dream come true. You don't need to have money. You don't need to have godfathers. All you need is to have a dream. And so I'm sending out those urologists going out from the university now. Do not feel like you're lost. It's very possible to feel you've asked the county chief officer to buy you a tower and he hasn't. I worked with my own instruments that I bought with a loan, and I was using these instruments in Kenyatta National Hospital, not for private practice. And I was using, of course, my one eye for a long time. And I think I probably stopped practicing just when Kenyatta had brought in the towers. But there is something good in that. There's something good in that. You see, that's where we are in the construction. Actually, we are further than this. It's just I couldn't get a picture of this. We are now painting this building. Once we have finished painting, those are the people we have trained. Those are the things that we do. Those are whom we partner. And I'm proud to report even today. Sometimes it's good to brag a little bit, isn't it? I'm the first urologist in Kenya to get a huge grant, because $12 million is a big grant. And so, and I'm not getting this for me. I was discussing that with Matu and Opondo this morning. It's going to be a national training. So I would ask you to where you go, start something. Start doing something that will change Kenya. Start something that will help. You are in the hometown where I was brought up. Except for those who used to listen to family TV for a while, where I used to do some Sunday shows. You wouldn't even realize why I did urology. But some people remember what I used to say on television. The reason why I became a urologist was a dream I had when I was 5 years, when I was here. And the dream was because I'd been in Kenyatta National Hospital, and I used to pee in bed. I was admitted there for a very long time. And I used to pee in bed, and nobody knew what to give me. It's not like today when you can give desmopressin. And what those nurses used to do is pick the bed sheets and beat me with those bed sheets because I've peed in bed. But what I did and what I liked was a young doctor. The young doctor would come and console me after I've been beaten by the nurses. I have nothing against the nurses, it's just that's the way it was. And so I said, one day, siku moja ama siku, I'll treat people who have problems with passing urine. So when I was offered this by Kagiri Dirango in 1993, I felt that my dream of 1965 had come true. So have a dream, everyone has a dream. What is the Institute? Programs. We have the urology program. Urology program is one. And Professor Ndagwada talked about us having had a dream of fellowships. It's good you didn't go fellowships in all those disciplines that we've talked about. We are actually now, as an institute, experts of curriculum development, recognized by Commission for University Education in Kenya and recognized by Inter-University Council of East Africa. So there's more and more that we are going to do. That building is going to open in April. A lot of the urologists who are in KNH are involved in the things that we are doing there. And there are many things we are going to need to do. That institute is going to be populated by these people here, but even more importantly, by those of you who are graduating. We shall probably absorb all of you, and the counties that don't want you will have to come and look for you 10 years from now. Because that, I'm told, is the big challenge, that the county, it's good that my friend, Governor Muridi, he's a friend of mine of many years, even before he went into politics. I think the counties need to learn one thing, if there is a representative of the county. Please take care of your specialists very well. They are very, very expensive to train. Right now, it takes a urologist 5 years to train at the University of Nairobi. It is going to cost nearly 1 million shillings a year to do so, because it is 600,000 shillings as school fees, and your living expenses would probably come to that much. So, if these people are training themselves and coming to you looking for a job, they will soon be sought by the surrounding countries. And Kenya has not reached 80 urologists yet. And yet the burden of urological care is so big. What is my dream? That we shall offer specialized training program, observer programs, that we shall offer fellowship programs, that we shall mentor other institutes, sister institutes, to become like IACI. We do not want it to remain just a KNH University and KMTC issue. We would like this to spread nationally so that Kenya and Kenyans should not have to wait like the patient of Dr. Waihenya to be last on the list on the day when you do not know whether even the people will ever come back, because the people of cows might come back here after how many years for the count? 47 years is when they come back here. So if you are waiting for another camp, you know the camp will come back here for 47 years. Dr. Waihenya, Dr. Waweru Madhu, and myself called for these people to come here. There is nothing special about us, but they came and gave you this, I think the 4th outside workshop, because we were first in Malindi, then Kisumu, then it's the 5th, then Meru, then Kitui, and now we are in Nyahururu, our hometown. Learn from these people. And lastly, I've talked about IACI being available. I've had fights with counties releasing people for training when I was paying for it, when I had the money to pay for your trainees, and the counties would refuse to release their doctors to come for free training which we're offering. That money comes to an end next year. So if you have people to train, you bring them this year. And forever, don't ask IACI for training. But for members of cows, for what we have done for 6 years, next year is still available. We have secured funds for you next year. Thank you very much, and God bless you.
Thank you very much, Professor Mungai. You told us a man can brag, and then you continue to say there was nothing very special about you, meaning Laikipia, but there's something special about Laikipia, in that the LOC was really dedicated, and they pulled this off. So, like you said, allow me to brag on your behalf that without the LOC, this would not have come to fruition, and you are a member of the LOC. So we are glad now to to invite the hosts, our hosts in this county. We were based in Laikipia and Nyandarua counties. So we have with us today Madam Maitai. Madam Maitai is the CEC. I'm told CEC means County Executive Committee Member for Health. Karibu sana to talk on behalf of your county. And after that, we'll have Dr. Kinyanjui, who is a medical superintendent of JM Kariuki Memorial Hospital, to talk on behalf of the Nyandarua County government. Thank you. Welcome.
Asante sana. Good afternoon. I know I'm standing between you and lunch. And for that reason, be assured I'll be very brief. My name is Honorable Rose Maitai, the County Executive Committee member in charge of health. Happy to be with you today. Allow me to bring my governor's apology. It's politics time, 5 months to politics. I'm sure you may know that he's heading Azimio politics for the Right Honorable Raila Odinga, and he got caught up in that, so he couldn't make it. Kindly accept his apology. Do you? Yes. Asante sana. Now, I want to talk about our county in a very brief manner. We are LHS, Laikipia Health Service. When I walked in, the moderator tried to mention that, or rather to pronounce it. It wasn't coming out rightly. One of the presenters called it Laikipia Health Services. It is Laikipia Health Service. And we are in the midst of rebranding and re-engineering ourselves. I know we are mainly called the Department of Health, or the Department of Medical Services and Public Health. Remember when we got into the new constitution, 2010, what were we calling the police? It was police force, yeah? It was Kenya Police Force, yeah? But when we did the constitution, we rebranded it to Kenya Police Service, yeah? That's the same thing we are doing with ourselves, because we want to be a service. We just don't want to be a department, like the Department of Agriculture, like the Department of Water, like the Department of administration. We want to be a service. Why the service? The main objective of this is to see how close we get to universal health care. I'm sure you understand how difficult that is, more than we do, when we talk of universal health coverage. I listened, I think, to Dr. Waihenya when he was making his remarks. And, the many patients you were able to see. And, he mentioned that one of the patients had to wait for 6 years. Another lady had to wait for his son, I think for, again, 4 years or thereabout. And here we are talking about universal health coverage. And you can imagine a period of 6 years, and I'm sure there are many other examples and incidences we can give, where people wait for a very long time if they ever get the right treatment that they need. So why we want to rebrand ourselves as Laikipia Health Service is to see how close we can get to universal health coverage. Universal health coverage, okay, this is not working? Still work, okay. So universal health coverage, what is it about? The four fundamental principles. It's about equity, it's about accessibility, it's about affordability, it's about quality. And when, for example, we talk about accessibility in Laikipia Health Service, in the last, I think, about 1 month, we have opened 3 new facilities. Laikipia is vast. If you move to northwest, you border Baringo County. Right at the border of Baringo County, we opened a facility called Nakwang. The area is mainly dominated by the Pokots. So that's Nakwang. It's our latest facility. Before we opened that facility, the residents from that area would walk for about 11 kilometers to get to the nearest facility. Again, when you go to north, a month ago, we opened another facility called Lekiji. It's in the middle of Auljogi Conservancy. Before we did that, the residents from that area, again, would walk for about 12 kilometers to the nearest facility. So, as we speak today, Laikipia Health Service has 87 facilities that are well distributed to ensure that we serve our residents well. It is quite difficult to have all the imaginable healthcare to the citizens at their nearest point. For example, take laboratory services. Initially, I said that we are a service and 2 level 3 hospitals. Because then, if you are somewhere near level 1, level 2 hospitals, then hardly will you access most of the medical care services. So if you go to the level 2 hospitals, dispensaries in this case, you will hardly find a laboratory. So what are we doing to ensure that the patient who visits our level 2 hospitals doesn't have to travel all the way from to Nyahururu or to Nanyuki or to the nearest health center or a level 4 hospital. We have commissioned our public health officers. We have border borders, motorbikes if you like, that pick samples from the dispensary. Once the patient come to our dispensary, then the sample is referred to the next facility where a laboratory is. What that does is that one, the cost, the patient cost or that transport cost to move to the next health center is reduced, if not completely eliminated. Therefore, none of our facilities can be said not to have laboratory services. Doesn't that not increase our accessibility to healthcare? Doesn't it? So I just wanted to give that as some of the efforts we are making as Laikipia Health Service to ensure that people are then able to access healthcare in the easiest possible way, difficult as it may be. And of course, we have affordability. As we speak today, 55% of Laikipians are on HIF. We have deliberately gone out of our way to ensure that we sensitize and mobilize citizens to register for themselves to get into this insurance cover. And of course, we have people, by virtue of their economic status, they are not able to register for themselves. We, like Laikipia Health Government, we are paying for NHIF for 10,000 households. That is in addition on what the national government is doing. The national government is doing for us 14,000 households, and we as a county government of Laikipia, we are taking 10,000 households in that attempt. This is all to increase the affordability to healthcare. We love partnering with other organizations for services, and especially specialized services that we are not able to offer as the county government of Laikipia. That's why, honestly, I cannot thank you enough for partnering with us in this particular one. I think from 8th to 9th of next month, Mata Hospital is also partnering with us at Nanyuki, Laikipia Health Service, again to offer an equally highly specialized treatment for our patients. Why did I want to mention this? Because I repeat, I want to take this opportunity to sincerely thank your association for taking time to be with us, to spend your time here, to spend your resources here, to spend your skills here. I remember when we first mentioned this to the governor, I met with Professor Mugai's first team, that when they came on the ground the first time, and when we mentioned this to the governor, of course the first thing he asked is, why are the private hospitals involved in this? And of course we had to explain to him, Dr. Waihenya, the Director of Medical Services, had to explain to him that first, you are here for very few days, and our hospital here in Nyahururu is not able to accommodate all the cases that needs to be attended. I'm sure I can thank you on behalf of St. Benedict Hospital. I'm sure I can thank you on behalf of Charity Hospital that we partner with in many, many other areas. No, I know I know some of us work in the private sector, others work in the public sector. I'm sure you'll agree with me. In any country, when you see the private sector thriving, in many circumstances it's because the private sector has failed. Is that not so? Yeah? Thanks. The public sector has failed, yeah? When you see the private sector, for example, especially in the services that the government is mandated to, if you see private hospitals doing extremely well, it's because the public hospital, the public hospital schools are not doing a good job. If you see the private hospitals driving very well, it's because the public hospitals are failing. We like Laikipia Health Service, I can assure you in Nyahururu, in Nanyuki, we get challenged when a patient chooses to be in St. Benedict or in the Charity Hospital and not like Laikipia Health Service Nyahururu. because we believe we should offer equal quality services just like any other private not afford particular services. And of course, we are limited in our own ways. That's why I repeat, we are extremely happy to partner with other partners who share the same objectives and values and principles like we do. I want to rest it at that. I thank you so very much. I still want to ask Professor Mungai. I know we can only do this 47 years from now, but I request that you consider, especially because you come from this county, kindly consider partnering with us more, even before 47 years are over, because I'm sure we need that. Asante sana. May God bless you.
Probably yet another reason why you can give the governor why we used private hospitals is because the patients in private hospitals are also Kenyans. That having been said, we'd now like to welcome Dr. Rachel Kinyanjui to give us a few the county government of Nyandarua.
Good afternoon, everyone. I'm Dr. Rachel Kinyanjui. I'm a consultant gynae, the medical. On behalf of our CEC, Dr. John Mungai, who is not able to attend to this, we wish to express our sincere gratitude for having partnering with us. I think we are the one with the most surgical patients done, and our passion was to enable our patients get the access, and they got the right technology. Personally, I've been working with Dr. Aweru Matu. He's among my mentors. That is where I was able to clerk some of the urology patients. So we were able to attend to more than 53 surgeries, and all of them, even for the ones who didn't have an NHIF, were able to be waived. We've not had a general surgeon from 2016, but there are plans to have one. There's a recruitment in the next 1 month. This time we'll be able to attract and retain. But meanwhile, I've been linked up with the PhD, and we hope to be organizing monthly camps, especially for the pediatric. Unfortunately, because we'll expect another scenario like this one 47 years from now, hope it will be shortened. Thank you.
So thank you very much, Dr. Kinyanjui. We were really impressed by your hands-on managerial style in organization of this company. So we now come to the end of this ceremony, but we'll have a small ceremony to give tokens of appreciation to various people who participated in the camp. MMS, okay, doctors, and Dr. Carol. So please come forward and give these tokens to our appointed. So, MMS, where are you? So in no particular order, this is just random, we'd like to ask a representative from Pine Hospital to please come forward. Juliet, please come and help us, even for the interest of time. Pine Hospital. Okay. Any representative from Pine? Okay, there being no representative, we'll find ways of getting the token to them. A representative of Oljabet Hospital. Oljabet? Okay, we'll get it to them. Charity Hospital? Yes, Charity? Oh, you're Charity Hospital? Oh, okay. Oh, sorry. Okay. Yes. Representative Dr. Kinyanjui, guess that will be you. So, J.M. Karemi Hospital. Just a token of appreciation from Kenya Association of Urological Surgeons for 15th. Yes, Brigadier? Yes. You enjoyed your stay there? Okay. Thank you very much, Brigadier. I'm told Mr. Gitonga is around. Mr. Wilson Gitonga. Okay, Mr. Gitonga, thank you very much for hosting us at LHS. I'm corrected that it is not level 4, it is LHS Nyauru. So, thank you, Mr. Gitonga. Mr. Gitonga is the Nursing Services Manager for LHS Nyauru. I'd like a representative of Mater Hospital. Mater Hospital. Thank you very much, SMK, on behalf of Mater Hospital, who have always graced our Cows Week camps, including donation of equipment and other things. Next, I would like to call upon Professor Ndagwada. Professor Ndagwada would like to give you a small token of appreciation. You can take it to him there. He's seen enough. Okay. Students, all come here. That was a family photo. Grandfather, father, and children. Okay, and finally, I would like the project manager of Yaki to come forward and receive. I was told the project manager of Yaki. Dr. Juk, come over. Dr. Juk is the reason why we are here. We would not have afforded to pull this off if he had not loosened his purse strings. Thank you very much, Dr. Juk. If you remember Dr. Juk, he was our host in Malindi when he was younger and slimmer like me. So, Dr. Juk, thank you very much for continuing to support us through Yaki. Please, when we get our letters, don't file them. You know you never file them, but don't file them, act on them immediately so that we can have successful camps like this. Thank you very much, Dr. Juk. You want to say a word?
Something. Good afternoon. Good afternoon. I'm sorry, I've just sneaked in. What they have done. I was a bit late because I was trying to organize logistics. I know after this, I know I was going to get your call. Say to organize everything before I come here. Anyway, as said, I'm Dr. Juk, the project manager, IAKI, and my senior father there, Professor Mungai, as our director. And I do believe he has said everything, what you're planning as IAKI, and he was able to share the good news that so far, on the issue of construction, we're almost complete. We expect by June, the East Africa Center of Excellence will be ready. We're in the process of procuring equipment, and we have engaged users to ensure that we get the quality, so that by the end of the day, when operationalize, we will not have any issue. Anyway, without saying much, I want to appreciate the leadership, because I believe one thing that is talked about father. I know they are my fathers, and I appreciate them, and they have always been in the balcony. And there's something I admire. I think I was born a soldier, but I'm practicing it in medicine. You must ensure that we are at the balcony to ensure that we see exactly what is happening. As far as training is concerned, I know we have invested in enough resources, and as Professor Mungai said, by next year we'll be closing down. But that must not come as bad news. Initially, you have been inviting people, allowing people to do applications, but unfortunately, there are some regions, I don't know if they're allergic or what. We find that people are coming from 2 to 3 regions, and that is the issue we had with Professor Mungai. What's not happening? There is something open, you've been paying everything, but I believe we are going to continue doing that. Anyway, what I wanted to say is very simple. We want to start a center of excellence. And then we go to definition. What is a center of excellence? Do you want you to come there, we do dialysis, you go home, and then you say you're from the center of excellency? Dr. Mbrug, make it clear. We want to change the quality of life of our people. So when you talk about center of excellency, I think you can best explain what you're talking about. So as far as equipments are concerned, you've done everything with the users, and I believe that very soon we'll advertise. You've said you have only 2 urologists. 2. The ones who have graduated now. Or ladies. They're only 7. Okay. This is the good news. Very soon we are working on the strategic plan, and you're going to have East Africa Center of Excellence as a hospital on its own, a training and giving services, and there'll be a very long advert, and I expect you'll bring them like 50 of them. We have the capacity and muscles to have them in the institute. Is that bad news? Oh, good. So please be prepared. The opportunity is coming, and we expect you to come and run our center with you today until tomorrow. Thank you very much.
Thank you very much, Dr. Duke. And then finally, our last token is to a man who has been very instrumental in the well-being of cows, the man who holds the purse strings of cows, the man who holds the keys to the accounts, a man who has finished 6 years as treasurer of cows, a man who is none other than Dr. Joshua Matu, who is sitting here behind me. Thank you very much, sir. Unless we pull a Putin, Dr. Matu cannot stand again for treasurer position until the next elections, because it's a 2-year term. So we'd like to thank Dr. Matu for what he has done. He's been a very, very able treasurer of our organization. His attendance to the finance committee that he heads, and also the national organizing committee where he's a member, has been admirable, and we really want to thank you from the bottom of our hearts, Dr. Matu. Karibu. Thank you very much, Joshua. Thank you so much. Okay, so I understand county government of Laikipia wanted to say something.
Hope you liked our partnership too. Did you enjoy working at LHS Nyahururu, for those who had an opportunity to do that, and the cooperation of our staff? Our motto and our vision as LHS is quality healthcare for all, if you witness that, Dr. Mong, Professor, yes, and we intend to continue doing that because that is what we must do. And to appreciate you, my team from LHS Nyahururu has a zawadi for you. Getonga and the team. Very good.
Afternoon. This is a token of appreciation from LHS Nyahururu. It has been a good teamwork with the members of COUS from the time we started organizing, and we are really grateful for that partnership. We were able to operate a total of 62 patients during the 3 days. So with that, we come to the end of this opening ceremony. We are very, very, very late we are late, isn't it? And as they used to tell us when National Youth Service, here ugali haina mfupa. In other words, we meze kama capsules. So meza ya ugali kama capsules, we come back on time, yeah? Okay.
Position of fibrous plaque that causes that curving of the penis, and so it interferes with the process of sexual intercourse and may cause pain during sexual intercourse. Some of the patients may have obvious curvature, but others you need to induce on the extreme end. I'm sorry for those who are on this other side. This effect, there's a hinge here. This one is a bit better, but that one is the worst one. There's another one called hourglass deformity, but that is hinge. So it comes out mostly for some of the patients it's obvious without an erection. For others, you need to induce an erection. That is the same condition but with the foreskin intact. What's the natural history of this condition? There are two phases, an acute phase and a stable or chronic phase. Acute phase, there are painful erections, and then the deformity of the penis settings of painful erections according to workers in this line. Is very scanty. From 2014 to 2019, only 7 cases had been seen in the entire Kenyatta National Hospital in the general practice. But I'm sure that the consultants who practice at Kenyatta see some of these patients in their private practice. But I was only able to pick 7 cases for the year 2014 up to 2019. And the age was ranging between 23 and 10%, with a peak at 50. And this is not a rare disease, and it has no racial predilection. It's associated with various other person ages, the commoner it becomes. Other metabolic conditions like diabetes, mellitus, hypogonadism can also be associated with psychological factors. Erectile begins with trauma, which may be like a one-off event or repeated microtrauma, which causes dislamination of the lamina or the layers around the tunica. Trauma initiates an complex inflammatory reaction. So deposition of growth factors like transforming growth factor, flow that I mentioned, and there's a classification known as Kelumi, which I'll not go to because of time. And there's a palpable plaque, and ED may to see the patient with a spouse. Because when you ask matters sexuality, the patient will tell you sexually is okay. But then you do a PD, peroneous disease questionnaire, to determine the severity of the condition. We prefer to assess the patient when they're having a natural erection, not erection induced by drugs. The natural erection gives a better idea of the severity of the condition. And you can ask the patient to send you photographs. Sometimes I ask them to do a WhatsApp presentation to me, so when they get a good erection, they WhatsApp me the picture. Then I'm able to advise. Imaging ultrasound is critical to decision making, can tell you the degree of curvature, although you use a device called a goniometer to determine the degree of curvature. MRI, CT role is controversial. The other things like hypogonadism. So I go to management. There are two types of management. The non-surgical or non-intervention management can be done in cases where the curvature is not severe. It is said that if the curvature is less than 30 degrees, probably there's no need for management, active intervention. You just counsel the patient and advise them on how to survive that condition. For oral medication, Potaba comes in handy. Potassium aminobenzoate, a member of vitamin B complex, it reduces collagen formation. It also reduces serotonin by increasing monoamine oxidase, resulting in reduction of antifibrotic properties. So Potaba has been used, vitamin E has been used, tamoxifen, colchicine, carnitine, pentoxifylline, PDE5 inhibitors, like tadalafil in this case, either alone or in combination to improve the International Erectile Index and quality of life scores. Potaba, vitamin E, tamoxifen, colchicine, carnitine, pentoxifylline. Then you can also have intralesional. Intralesional, there is a collagenase Clostridium histolytica, CCH. Others are like verapamil, nicardipine. I'm just mentioning them because of time. Interferon 2 alpha. I'll talk briefly about collagenase, Clostridium collagenase. Collagenase Clostridium histolytica. It is said to selectively degrade collagen type 1 and type 2 in connective tissue and increases apoptosis of fibroblasts. It has been found by workers in this area to cause improvement in the size of the plaque and reduce the level of deformity, and also improves the symptom score according to research which was done some times back in 2013. You can also have topical application of drugs, drugs which can be applied topically, other sedative drug administration, shockwave lithotripsy, shockwave therapy, extracorporeal shockwave therapy can be also used. It causes direct damage to the penile plaque. It improves pain, penile traction, and vacuum therapy. They act almost through the same way, same mechanism. I'll go quickly to surgical therapy, which is the mainstay, is a gold standard treatment. And indication for surgery is a stable deformity of at least 6 months from onset. Inability for the patient to engage in penetrative sexual intercourse due to deformity and inadequate rigidity. And surgery can also be applied where conservative management has failed. And if you are anticipating to do penile rehabilitation, like if you want to use a prosthesis, you can combine together with surgery to elongate the penis or to correct the deformity. So surgery, there are two classes, basically the penile shortening procedures and penile elongating. And in the absence of hourglass, there should be absence of be less than 20%. The advantages is that there's a short surgical time. Then there's the dot procedure, as you can see. Procedures we use grafts, which can be autologous, allografts also, and xenografts. Xenografts are not as efficacious as autografts and allografts. So the ones preferred are either auto or allografts. Procedures, they have comparable efficacy, whether it's Nesbit, modified, Diachias, 16 dot, simple application, efficacy is comparable. Graft materials, synthetic materials give poor results compared to autologous or xenografts, but synthetic materials generally are associated with a low success rate. Currently, what is new, they are saying that extra tunical grafting of peroneal disease to correct preferable. So the graft should be put inserted between the Bart's fascia and the Dartos fascia. Rather than cutting on the tunica albuginea, you just dissect the intermediate plane, especially in the hourglass deformity. When you cut on the tunica albuginea, you're likely to have consequences of erection. That's a flow diagram summarizing the surgical correction of peroneal disease with or without prosthesis is a gold standard. And surgery is indicated when the deformity or rigidity interferes with sexual function, prioritize the curvature or the erection or both, and warn the patient that this operation is not without side effects like shortening of the penis, erectile dysfunction.
We'll discuss the varicocele patients, which will depend on your competence and facilities which you have. When and why are not controversial. Not just to decline 1% of men with secondary infertility. Renal metabolites, here the renal vein, lead to poor sperm quality and testicular arrest, and that's why we have to intervene surgically. It's associated with the progressive and cell will halt and further damage the testicular function. In most men will have improved spermatogenesis, and in children, the testicle acquire the same size, in many cases like the opposite side. Etiology is not well known, but there are various associated factors. They thought to develop from a backup of venous blood flowing in the internal spermatic vein due to incompetent valves within the cell. Reflux in collateral veins, and these include, these are non-secondary varicocele, and these are due to venous thrombosis. Varicocele are either due to poor surgical skills or and the patients are fertile. Pain or heaviness or dragging filling the scrotum is a common presentation. Infertility accounts for that 5% in all men with fertility issues. How do we evaluate a man who comes to you with varicocele? This man should be examined. Physical examination is the most important, other than the diagnostic procedures. It should be in a warm and comfortable environment so that the testes can be relaxed and you palpate and make a decision on that. Grading, we have a grade 1 where you get palpable vascular when there's vasovagal maneuver on the patient. The grade 2 is investigations. Sometimes we subject patients to a lot of cost for no reason. Varicocele requires surgery or clinical diagnosis. The rest we are doing it just to confirm what it is the right thing. The common one to do is a scrotal Doppler ultrasound. The report is user dependent. The MRI is indicated in few cases where you are suspecting underlying mass causing the varicocele. Same for geography. Why and when is the varicocelectomy indicated? And that's indication for the cell. Now, patients are pain because varicocele is quite tricky. Scrotal pain is the same pain. Grade 3 varicocele is straightforward indication. Patients with recurrent varicocele also qualify for surgical intervention. Testicular hypertrophy, patients who request from this condition, and the fitness needs for the patient. By that I mean that when a person knows that he has a problem with scrotum, more so touching the manhood, he'll always come to you with a complaint, no matter what. So he believes that even a small cyst there is causing all his problems, so he wants to come out. So those are things we make you operate on a patient when there's no indication for that. Fitness are patients who require to stand for a long time, and they have a varicocele, the condition might get worse. So those ones you really need to attend to them. Why and when? In adolescent or children, when endow is still controversial, fertility to these people is not a problem. It's the relatives or the parents or the guardians who motive. So the boy will complain of pain, but the father or the parent might read the same. So you take in consideration that. And the first difference. How you do it will depend on many factors. Competence and skill of the surgeon, age of the patient, surgical facilities available, and the financial implication to the surgeon and the patient. The techniques are various of them. They involve the standard open surgery, which is macrosurgical varicocelectomy. Macro means you're not going to use any magnifying system or means. So you're going to rely on your eyes alone. You'll agree with me that sometimes, if you're going to use your eyes, you may miss some fine venues or veins, and you are like to miss, in the end, to get a recurrence of the same problem. The approach may be inguinal or subinguinal. Don't attempt a scrotal, there's no benefit. A laparoscope, a laparoscope, or a robot. The advantage of microsurgical is that the small veins will be visualized, you'll be able to identify them, and the artery. So you'll be able to do a good work. The challenge is one. Most of us are not conversant with the use of microsurgery. So when you start doing them the first time, you get a problem, but over time you become competent. Then we have laparoscopic varicocerectomy, which can be transperitoneal or retroperitoneal. The outcome is the same, whether you do retroperitoneal or transperitoneal. The difference is retro takes a bit of time, trans is more simpler. Then we have robotic assisted laparoscopic procedure and angiographic embolization. Embolization is not a surgical procedure. I'll put it here for the purpose of completing the discussion. You are supposed to give a patient all the options available for the condition, not the ones you can do, as I put it there. So microsurgical electron is done by urologists not conversant with microsurgery. It's like to miss small veins, which later lead to recurrence. Paloma procedure is electroperitoneal ligation of the spermatic vascular structures. Then you have the standard inguinal approach, the Yvonne's reach. And if you do that one, you like to get more, you like to miss the small veins. And the veins which you're supposed to ligate are the external spermatic, cremasteric, and you're supposed to open the external spermatic fascia, the cremasteric fascia, then internal spermatic fascia, then you'll be able to see the dilated external spermatic vein. And the ones you identify, you are dilated, you ligate them. But you must make sure that you don't injure the artery or the vas. In microsurgery, we either use a loop, can multiply 2.5%, or macros multiply by 8%. And the subinguinal approach is the best. This magnification allows you to identify the testicular structures and isolate the lymphatics, and then you'll be able to go do surgery. Laparoscopic surgery is not superior to another method. The only thing is that it's a bit expensive, but the outcome is good. Now, for competence and procedure, the outcome is determined what you expect. If you get a recurrence rate, they are always higher in all procedures except microsurgical resection. Hydrocele formation, which is a complication because of injury to the lymphatics, they are high in all procedures except microsurgical for reselectomy. Follow-up is in clinical examination for recurrence, quality of semen for fertility issues. Pregnancy rate, which is the most important for these patients, is best if you do microvaricocelectomy compared to other measures. Conclusion. Current evidence shows that microvaricocelectomy is the gold standard technique as the best pregnancy rates and the minimal post-op complications and deaths. In pediatric population, the best method is controversial. It depends on surgeons' preference and equipment availability. And you can see the percentages there. Thank you very much.
Thank you. Thank you very much, Dr. Joshua Matu, for that excellent presentation. Our next presenter is Dr. Mohamed Awarf. Dr. Mohamed is a fifth-year general surgery resident at Mata Hospital, going through the COSEXA program. He'll be presenting to us on a bladder neck contracture after TRP and radical prostatectomy.
Thank you very much, Chair. I'm going to slightly change the name of my topic from bladder neck contractures to vesicourethral anastomotic stenosis. This is because in 2014, this was changed to show that the vesicourethral anastomotic stenosis is actually more pathologically descriptive for this condition that we are talking about today. And this is a fibrotic narrowing at the vesicourethral anastomotic site, and it usually occurs in the first 6 months, but is very rare after 2 years. The incidence is dependent on the surgical approach.
Just a minute, Dr. Mwa. We are marrying the urologist who are scoring the residents. This is our first resident who is present, so please be aware of that. Sorry for the interruption.
No
Please
problem.
go ahead.
Thank you. So this is a fibrotic at the vesicourethral anastomotic site, and it usually occurs in the first 6 months and is very rare after 2 years. The incidence is dependent on the surgical approach, and the wide incidence is also due to the fact that there has been many technological innovations over the last few years, from open to robotic and also laparoscopic. So the data shows that radical retropubic prostatectomy has an incidence of around 0.5 to 30%, radical perineal prostatectomy around 3.8%, for robotic assisted it's less than 1.4%, and when you have salvage robotic assisted radical prostatectomy post radiotherapy, the incidence increases to up to 26%. Some authors actually quote up to 35%. From the capture data published in 2007, the incidence overall all modalities was around 5.2%, and for radical retropubic prostatectomy was around 8.4%. Our local data seems to suggest we have an incidence of around 6%. This is according to the data published in 2018 by Dr. Waweru. These factors can be categorized into pre-op and intra-op. Pre-op factors include a higher grade prostate cancer, advanced disease, a large prostate volume. Others can include coronary artery disease, hypertension, diabetes, smoking, obesity, and older age. Intra-op factors include extensive blood loss and the tension on anastomosis, the use of a running suture or robotic assisted surgery, and surgeries that have been done by high volume surgeons, usually more than 40 per annum, actually seem to have a lower incidence of this condition. Most of these patients will present with obstructive symptoms, but if radiotherapy had been offered, they'll actually have some urgency and frequency. Sometimes recurrent UTIs may be the first sign. Diagnostic workup should include a medical history, including radiotherapy, a PSA to rule out recurrence, a uroflowmetry, a PVR. Gold standard currently is a retrograde urethropography combined with avoiding cystourethropography. This will provide information about the location and the length. Cystoscopy also has a role to play in terms of giving us information about the diameter and the relation to the external sphincter, but we will leave it at a later discussion whether this is feasible in our setup and the cost implications to our patients. MRI has a big role to play in giving us information in regards to the relationship to the external sphincter, exact length of stenosis, and the severity of fibrosis of surrounding tissues, and should probably be considered as part of standard workup for this condition. So what do we do ourselves to mitigate this condition? We induce some permissive hypotension around for a systolic blood pressure of around 80 to 90, a thermal meticulous dissection, and instead of doing a flash transverse transection at the apex, we try to follow the curvature of the apex to have a canoe shaped. And as Dr. Opondo had argued earlier, these extra inches are actually very valuable to us. You also need a good bladder neck reconstruction and to end with a tension-free anastomosis. Treatment will be dependent on whether the patient is continent. If the patient is incontinent, you also want to know if the urethra is completely obliterated. If it is, then you need to insert an SPC or patency. You can do transurethral incision with a Collins knife, plus or minus CIC. For the continent patient, the guidelines are different depending on the society you follow. The EAU advises dilation or transurethral incision. The AUA advises dilation or incision or resection, but leaves it at the surgeon's discretion to choose what procedure they want to do. The SIU and ICUD advises dilation and incision with a success rate of 37 to 69%, and with repeat endoscopic procedures can increase to up to 91%. There's no consensus currently whether laser or the knife is better. And of course, you need to avoid incision at 6 o'clock because this is a thin tissue plane prone to rectal injury and fistula formation. If the stenosis is recurrent or recalcitrant, there's a role of triamcinolone and mitomycin C with a success rate of around 83 to 99%. Stenting initially had actually been largely abandoned because of problems with migration and tissue overgrowth and pain, but the discussion has actually come back again. There's this study that was done in 2019 by Nathan, and they recruited patients from 2013 to 2017, and they had 30 patients, and the mean interval time between prostatectomy and the stent insertion was 13 months with a median age of 62, and with a mean follow-up of around 3.6 years. This was a staged procedure, with stage 1 having a dilatation and incision or resection of up to 30 French, and then a catheter is left in situ for 2 weeks, then the stent is inserted and left there for 1 year. The results actually showed an improvement in IPSS scores, IPSS quality of life scores, the Qmax, and the PVR after removal of the stent, with a 93% success rate. So they concluded that this minimally invasive technique had faster recovery time compared with other techniques such as bladder neck reconstruction or urinary diversion. It provides superior patency results compared to other techniques such as bladder neck incision and injection of mitomycin C, and thus should be considered as part of first-line therapy. For the very frail and very old patients, you can actually perform permanent catheterization. You can, if you have failure of 3 endoscopic procedures, then you proceed with open reconstruction. It has several approaches, can be either be abdominal, perineal, or abdominoperineal approach. The advantage of the abdominal approach is the fact that you can actually save the external sphincter, but there's a lot of fibrosis because this is not virgin tissue and you might have to perform a pubectomy. For a perineal approach, you might go into virgin tissue, but you might not be able to save the external sphincter. It is important to counsel these patients honestly when doing the open reconstruction. Future prospects, we need to think about the standard use of MRI in our diagnostic workup. We also need a novel classification to include the grade and etiology. Unfortunately, most of the studies that I have quoted prior to this were actually retrospective, and thus there's a great need for prospective multi-institutional randomized studies. Thank you.
Thank you very much, Dr. Mohammed, for that excellent presentation. Our next presenter is Dr. Samuel Kagiri. Samuel Kagiri works at Odhaya, which I told is an extension of KNH, and remember is the consultant that Professor Dagwada was mentioning is the first graduate of the M.Med Urology at the University of Nairobi. So Dr. Kagiri is talking about urinary diversions in adults. The question that he needs us to answer is what is appropriate for us. Welcome, Dr. Kagiri.
Thank you, Chair. As I consider this question, I wanted to find out from history what has been happening, and our focus is based on what they were doing in the past. And you can see all the way from the about 200 years ago, and the focus was mainly on the procedure, complications of the procedure, and the names are as varied as the procedures themselves, but the focus was mainly on the procedures and the ease of doing the procedure itself and the complications that come thereabout after. But when they were classifying them, mainly it was based on what type of gut are you using, at what level, and is it going to be continent, is it going to be incontinent, are you going to catheterize the pouch or not, are you going to create a pouch that has its own continence mechanism, and they are varied. There are varied methods where you'd see you're considering the patient, you're considering the disease process that's happening, you're considering the complications that are occurring. Are you putting a permanent procedure or are you putting a temporary one? depending of course on the pathology that the patient has. But as you're making the decision, no single procedure is universal for all patients, and this is supposed to be employed as per patient basis, and depending on, you do something different for trauma versus tumor, you want to see the patient's renal function, just the overall status of the patient. Is the anatomy normal or not? A question of patient preference is there, and are you able to do the procedure yourself when you're making the decision? And of course, this is the biggest question which I'll dwell on, quality of life in this 21st century, and that's where the decision-making process is moving towards. So crucial for your success, remember this is knowledge you're imparting in your head and translating through your hands. So you have to know the anatomy, the physiology, you're understanding the technicalities of the procedure, how to handle the tissues, the ureter, the bowel, is it normal, is there good supply, and of course, accurate apposition of gut, and a thorough understanding not only of the procedure and the patient who is you're administering it to, but the complications that are going to come about from your procedure. So whichever method is utilized, you want something that's closely resembling the bladder in most aspects if you're able to, preferably non-refluxing. I'll give a comment on that. And low pressure, you want something that does not absorb, something that is very similar to the bladder that has the pathology and has been removed. You want to preserve the renal function, and again, this is a patient, so quality of life. You want the patient to be able to live a healthy and not a shameful life from your procedure. So, like I mentioned earlier, there are various ways of doing it. There are conduits, and they're fundamentally two types, and they are named based on the type of gut you're using. And each, like I mentioned, has its own specific way of saying, are you going to do this? What are the complications based on the kind of gut you're going to use, how high, how low? And from studies I've seen those over the last 30 years, there've been a focus on the ileal conduit just because of its ease of use. And this is a study just showing that it's one of the simplest ways, and it's been challenged, of course, based on the complications that occur mode of diversion. Again, when you look at colon conduits, they still have a role, the transverse colon. When you're thinking you're higher up, and most of the low abdomen and pelvis have been irradiated, you think about it would be close to the kidney based on how good or bad your whole ureter is. The sigmoid conduit, of course, ease of use on the left side, and just because of the thicker tissue, you're able to tunnel your ureters much better as opposed to using the ileal part. But when you look at long-term complications, and this is much earlier, but complications still similar to what we see today. Most patients have bowel-related complications as opposed to very closely followed by renal complications, and you'll see structural complications based on the surgery itself are not as high as would have thought, including strictures and narrowing or stenosis of the anastomosis. And the older the patient you have, the more likely you're to get these complications. Again, similar to ileal conduit, similar to jejunal, just what's different is the metabolic aspect of it. And this is almost like a summary of the syndromes you'd expect to get based on which part of bowel you use. You use the jejunal, get more of the hyperkalemia. You use the ileum, you get more of the hyperchloremia. And of course, that drug absorption, bone metabolism, osteomalacia, all those factors are also there when you're selecting which kind of diversion to use. So long-term deterioration was initially thought to be because of stricture, and most often, from the studies that I've seen, it's actually because of lack of ureteral motility, infection, and stones. And people lean more towards the refluxing as opposed to the anti-refluxing when you're speaking about long-term failure of renal function. And again, as simple as it may be, all sutures are supposed to be absorbable. And of course, the ureteric stents are supposed to be removed 4 to 6 days. And they should be retroperitonealized. I'll skip this about continent diversions, but mainly it's just stating that you're focusing on the patient, and this patient has to be motivated. So again, when I was looking at the data, I saw a lean more towards continence to give patients quality of life. And there are many studies that show this was a systematic review of abstracts, and they were trying to compare the surgical techniques that have been used and which diversion have been used. And ileal conduits have the lowest operative complication rates. Of course, these are good centers with adequate expertise, but highest reported post-operative morbidity, and this we're talking about long-term. While orthotopic bladder is there, and it seemed to move towards being a gold standard in the early 2007, 2008, all the way up to 2013. Differences with the ileal-based neobladders is not that significant. And this was a study just to confirm the same, and they were showing the clinical outcomes of sigmoid and ileal. And these were patients who had bladder cancer. But both types resulted in comparatively similar outcomes. And the outcomes they were looking for, these were long-term. The voiding function and the ease of emptying the neobladder itself. And again, leaning also towards the sigmoid neobladder, it is often disputed but seems to be very popular. When you compare the two, the ileal neobladder is more often chosen, and the reconstruction of the orthotopic, when you compare, this was mainly focused on the voiding function long term and the ease of voiding. It was particularly directed towards when the decision was being made. Most women, especially older age, had this procedure done on them. Again, similar. They were looking at ileal orthotopic bladder following radical cystocele tubular segment just to allow for a good long-term ease of emptying the bladder itself. And they showed that if procedure is done well, postoperative instructions are followed well with this ileal orthotopic neobladder. Complications such as outlet obstruction, if they are sorted out early, then this is quite a good method of diversion. But in conclusion, this was something shown by the WHO. This was look at over 7,000 patients after cystectomy, and this was together with the SIU trying to find out what is good, what is appropriate at that time, leaning towards one over the other. And the question of quality of life now started being highlighted at this point in the early 2007. But still there was a significant emphasis on the procedure itself and how well it's done, and how you modify the procedure to add an afferent limb that improves your outcomes. At that time, 47% of all these cases considered using the conduit as opposed to neobladder as opposed to using a conduit. Again, similar outcomes were shown. The trend is more towards liberal use of ileal conduit urinary diversion. This was in 2009. And neobladder at this time was the most commonly performed urinary diversion, but in patients who are younger than 65 years in their center. And the trend continued, and currently this is what is happening in the West, and they wanted to see what exactly is being done in terms of urinary diversion. And the trend has changed now. It's more of incontinent, 85%, to continent, 14.5%. Most surgeons are tending to pick this up, and whether it's in a high volume center or an academic center, the rate of continent diversion was seen to be declining. And this was mainly because of the introduction of instruments for quality of life. And during the past decade, most of these instruments have influenced the practice of urology, regardless of whatever management process, whether it's cancer, whether it's reconstruction. The patient is key, not the procedure. I find it good to know the trends are, yes, towards incontinent, ileal conduits, but again, the focus still remains on the patient. And the younger the patient, the more important the focus on quality of life. So current limitations to this are the standardization of the tools being used to assess the quality of life, and of course prospective studies, just like the previous presenter said. So this is a beginning point for us at least to decide on what procedure to choose for our patients. Consider first the quality of life and outcomes. So again, the future is tissue engineering. Hopefully that comes sooner than later. Thank you.
Yeah, thank you very much. Our next presenter is Dr. Oluoch, giving a presentation on genitourinary injuries in patients with multiple trauma at KNH. You can introduce yourself. There are people who are grading the, okay. Sorry.
Thank you. Thank you, Mr. Chairman. And good afternoon, everyone. My name is Onyango Loch. I'm a younger urologist. Yeah, I'm going to present on a topic, a research thing we did at the Kenyatta National Hospital, where we looked at the pattern of genitourinary tract injuries in patients with multiple trauma at the Kenyatta National Hospital. So as a way of background, as we all know, trauma is an important public health challenge globally, as well as genitourinary injuries are known to affect both health and health-related quality of life. However, the genitourinary injuries are often overlooked because they occur in the context of multiple trauma. The epidemiology and presentation of genitourinary injuries are wide-ranging. If you look at literature, you can see the prevalence of genitourinary injuries in places like Scotland being as low as 1.5 and as high at 10.5 in Michigan. When we also look at the prevalence of individual genitourinary organs, there is a big difference between what is seen in the Western world and in Asia and from what is seen in Africa. You can see in Nigeria, the most commonly injured is the urethra. Yet in the other regions, it appears to be the kidney. However, the pattern, the mechanisms of injuries appears to be similar across, with the blunt injuries being the most common across the globe. Why this study? Because of the variations, the wide variations across the globe, we thought that it's necessary to know our local data. We thought that the rationalization of this will help us get the resource allocation right, and we'll have a focused clinical training This will also help raise clinicians' index of suspicion while evaluating patients with multiple trauma. Hence, better patient outcome, and will help us generate risk. We employed cross-sectional study where we included all the patients with multiple trauma at the Kenyatta National Hospital, and we excluded all the patients with isolated genitourinary tract injuries. We looked at 384 patients employing Cochrane's formula, assuming finite population. And we duly got the approval of the relevant authorities. Our results, after looking at 384 patients, we found 52 patients with genitourinary injuries, representing 13.5%. The age groups reflected what is in the trauma literature worldwide, with the population at their 20s being the most affected. The individual genitourinary organs affected were mostly the urethra, the kidney, and the scrotum. The majority of our patients presented the flag mechanisms reflected what is in the world literature, with blunt trauma contributing to majority of our injuries. Of the blunt injuries, motor vehicle accidents, motorbike accidents were the most prominent. Stab wound and gunshot wounds carried the day in most of the patients who sustained genitourinary injuries. The other injuries that these patients suffered when they got the genitourinary injuries were mostly pelvic fractures, chest injuries, and bowel. The highlight of the finds injuries we found out to be male, involving in motor vehicle accidents, bicycle accidents, and gunshot wounds. This prevalence is clearly higher from what is recorded in Scotland at 1.5%, in Iran at 2%, and in USA at 10%. And this goes towards explaining the wide urinary tract, as we have said, is the urethra at 51.9%, as per the finding of the study. This is against what is in the Western literature, which puts urethral injuries at 4%. But our findings were similar with what comes from Nigeria, which as part of an African population might reflect our true position also. The study was limited with inability for us to do retrograde urethrogram at the Kenyatta National Hospital. It's not easy to do this in an emergency setup, but also other workers who worked in resource-poor populations encountered similar. Urethral injuries are the most common in our setup. So what will we do with this information? I think that we need to develop more interest, knowledge, and skills. And we need to train more genitourinary reconstructive surgeons in this region. Thank you very much.
Thank you very much, Dr. Ranyango Oloch, for that very nice presentation and for keeping urology resident at the University of Nairobi. So for the assessors, please make sure that you assess Dr. Kimani. We'll be presenting on the incidence of biochemical recurrence in prostate cancer in Kenya, a retrospective cohort study. Welcome, Dr. Kimani.
Good afternoon. So I'm going to present a study on the incidence of biochemical recurrence in prostate cancer. Prostate cancer is the most common malignancy among older men globally and also in Kenya. And the localized disease can be treated with curative intent using a radical prostatectomy or radical radiotherapy. And biochemical recurrence is defined as increase in PSA level above 0.2 nanograms per mil after radical prostatectomy, or increase in PSA levels above 2 nanograms per mil after radical radiotherapy. So the current global data shows the incidence of biochemical recurrence to be 30 to 40% after radical prostatectomy and up to 50% after radical radiotherapy. And factors that have been associated with invasion, baseline PSA, tumor volume percentage, and even age. So minimal data is available in our setup to elaborate on the incidence of recurrence and the role of clinical investigations, specifically imaging in determining selection of patients, is not well elaborated. Because most of for patients, for us to make decisions to operate them, they will undergo pelvic MRI, and we even have a role of the extent and location of the disease. So objectives, we wanted to determine the incidence of biochemical recurrence in prostate cancer in our environment, and to elaborate on the role of imaging in selecting patients for radical treatment. So we did a retrospective cohort study, which was included 64 patients who underwent radical treatment with curative intent for localized or locally advanced prostate cancer. And we had 3 sets of studies that we pulled. One was by Mburugu et al., had 23 patients, by myself, 9 patients, and Waweru et al., 32 patients. And these patients were seen between 2010 and 2021. So in the study by myself, we had an N of 9 patients, mean age of 63 years, and patients had undergone radical prostatectomy and brachytherapy. And this was the T staging of these patients, with a mean baseline with an N of 5 between 10 to 20, about 21. And prostate size was on average 20 to 40, with an outlier of 100. But when it comes to biochemical incidence of 55.6%, with a confidence interval of 21.2 and 86.3, with the second study, we had an incidence of 30.4, with an confidence interval of 13.2 to 52. And for the third study, we had a N of 32, with an incidence of 25. And pooled incidence from this data shows that our local incidence of biochemical recurrence is about 31.3, ranging from 20.2 to 44.1. And this is in keeping with the current global data, which shows that the incidence of biochemical recurrence is 30 to 40%. Chemical recurrence. From the study with N is equals to 9, that is 9 patients, we had 2 patients who had negative MRI findings, yet one of the patients developed biochemical recurrence at 1 year. And yet, MRI pathology discordance rate was 33%, with upstaging, pathological upstaging of the disease. So that tells us that probably MRI does not tell us enough about the extent of the disease. And with the advent of newer imaging, are there better things we can do? So we know that MRI, the T2 weighted, has a sensitivity of 22 to 85%, with a specificity of 50 to 99%. And this wide variation is due to maybe equipment, patient selection, experience, and accuracy of pathologic correlation. Yet, MRI has poor prediction for microscopic invasion, with a sensitivity of 40, specificity of 95, and accuracy of 76. And this is key because when you want to operate this patient, you actually want to make sure that the disease is truly localized within the prostate, and if it is localized outside the prostate, maybe just within the regional lymph nodes. But then MRI does not tell you much more regarding that, especially if there is microscopic invasion. Moreover, in our environment, as we said, we used endorectal. We don't use endorectal coil, yet endorectal coil has a better sensitivity compared to external coil in terms of the imaging techniques like PSMA PET in our environment. Perhaps it's time we think of what can we do. Can we screen our patients better for radical therapy? Because we know that for lymph node detection, PSMA PET has a better lymph node detection rate with a sensitivity of 94 to 100 and specificity for 66.7, with a specificity of 66.7 to 99.7%. However, there is no consensus on whether MRI or lymph node or calling PET should be used for lymph node staging. So, in conclusion, the incidence of biochemical recurrence is still high in our region like other areas. We have no clear definition on the role of imaging because newer imaging techniques, these are newer imaging techniques which probably we need to assess the influence of PSMA PET on incidence of biochemical recurrence.
Thank you very much, Dr. Kimani. You have really kept the time well, and my co-chair is also a presenter. So Dr. Edward Mugaro is a lecturer and a consultant urologist at Moi Teaching and Referral Hospital, will be presenting on management of neurogenic bladder at Moi Teaching and Referral Hospital.
Good afternoon. Yeah, I present this on behalf of my colleagues that we work with. Dr. Msawa, I think, is in the audience, and it's on management of neurogenic bladder, challenges in service provision. As we know, neurogenic bladder is a bladder dysfunction due to neurological dysfunction, which may be caused by trauma or a disease process. It describes conditions ranging from a reflexic non-contractile bladder to the detrusor of activity. The dysfunction may be because of storage or micturition, and there may be either bladder and activity or a bladder of activity deferred to spinal lesions cause the detrusor of activity and the detrusor sphincter dyssynergia, leading to back pressure, upper urinary tract dilatation, and eventually compromising renal function. When a patient gets spinal shock, immediately after spinal cord injury, weeks to 12 weeks. So care of neurogenic bladder is a long-term and lifelong bladder care, and it requires regular medical assessment to provide social continence, prevent upper tract damage, and life-threatening urinary tract infections, and eventually renal failure. These burdens. Besides spinal cord injury, we also have other disorders of the nervous system which depend on. I have two cases to share 30 years earlier and suffered a C4, C5 spine injury. He developed paraplegia and was first seen in 2015, first in our clinic in 2015, where he had been referred because of a right renal tumor, which after surgery turned out to be a spinal injury hospital, which mainly involved an indwelling catheter that was later upgraded to assisted clean intermittent catheterization upon discharge. He has been managed for several episodes of UTI, usually managed after urine culture and sensitivity. And the last urine culture grew E. coli, and the latest blood. And his renal function over the 30 years has relatively remained normal, indicated there. And the second case is a 19-year-old female who attended neurogenic bladder early in childhood and managed by a clean intermittent catheterization. A micturating cystourethrogram, which had been 13 years earlier, that is when she was around 3 years old, showed an increased bladder capacity. Ultrasound shows a bladder capacity of 344 cc's and grade 1 hydronephrosis. And her renal function also remains relatively normal despite the fact that she is on CIC. So nervous and the peripheral nervous system. A significant number of these patients manifest urinary dysfunction, yet optimum treatment is still not available for majority of our patients. In 2016 global incidence and the prevalence of spinal cord injury was the incidence 27 million globally. And within the low and middle income countries, spinal cord injury incidence was 330 million. In sub-Saharan around 4,000, and a prevalence of 83,000. And about 70 to 80% of these patients are expected to, with the complement of clinical. Our biggest two referral hospitals have very basic, evaluation for these patients with neurogenic bladder. Diagnosis is based in studies. Patients with neurogenic bladder and their family members and or caregivers need specific information and training, pain and met. Guidelines provide a resource of reference in management within a given environment, depending on availability of expertise and resource in the setting. It is only South Africa in sub-Saharan Africa which has guidelines for management of neurogenic bladder. And this may indicate either lack of recognition of neurogenic bladder as a problem of vision. But a positive factor in the management of neurogenic bladder in our environment is a strong social structure and family support for patients with chronic diseases, including neurogenic bladder. And this is exemplified in our two patients. These are patients who have led a relatively good quality of life. For the first patient, the clean intermittence, and in this case for this patient is the wife. And for the second patient, she has been on clean intermittent catheterization since early childhood, which was being performed by the mother until she became a teenager and able to do it herself. Family members are increasingly becoming important allies in the care of chronically ill patients. And the treatment options for neurogenic bladder include conservative and pharmacological and surgical, and pharmacological and surgical methods. And the main goals of management are preservation of renal function, improved continence, reduction of urinary complications, focuses on therapy to facilitate bladder filling and storage of urine, and treatment to facilitate bladder emptying that assists in preserving both renal function and the social function that affords patients an acceptable quality of life. In sub-Saharan Africa, we have very little literature or studies on neurogenic bladder. And one study that I came across was in Botswana, and The care was very basic, mainly urethral catheterization and use of CI. Studies on management of patients with the neurogenic bladder includes an entire array of care. Apart from pharmacological and non-pharmacological care, they also offer surgical treatment for patients with the neurogenic bladder. So CIC in our setup and generally remains the gold standard for bladder emptying in patients with neurogenic and urethral stricture. So in conclusion, management of neurogenic bladder is lifelong with high financial health service needs, which affects access to comprehensive medical care for the patients. Despite limited resources in low resource settings, patients' assessment and bladder management can still be done with minimal resources and with acceptable outcome. A strong social structure in sub-Saharan Africa is an important factor in the quality of and development of relevant guidelines will likely improve care in resource-poor settings. Thank you.
Thank you very much, Dr. Mugaro, for that presentation. 2 or 3 questions because of we are running short of time from the audience before we go to another short interactive session on prostate cancer. Questions from the audience? From your 7 patients, which procedure was performed and which one do you perform?
Our doctors at KNH prefer Yacha procedure, longitudinal incision transversely. I needed you to ask me if I can answer. Is whether we do any grafting procedure. I've never personally done a graft procedure. I've seen it in the diagrams. I attended a session by one of the practitioners. The guy from Turkey is called Ates Kadioglu, saying that all the graft materials used except the synthetic materials. Synthetic materials are to, especially when they are developing this graft, somebody was of the opinion that dermal graft is better in terms of the tensile strength. And where do they harvest it from? Around the groin. They just get a tissue there with the skin and then they remove some of the skin and fat. And then they get that is efficacious. But now the technique, the new thing in that line of practice is that you put it between the Bach's fascia and the Dartos fascia, especially the complex ones like hourglass deformity and hinge deformity. So in our practice, the archer, we do incision longitudinally, then we close it transversely. I've seen from that series of KNH, we are doing urethroplasty. We also get some penises which have a curvature, but they are not, by definition, Peyronie's, because Peyronie's is a triad. That triad of curvature, plaque formation, and maybe associated pain. So those ones are not Peyronie's. There are some men generally, even in this audience, if all the men were to strip, you'll see lots of curvatures on the penis. But they are not Peyronie's by definition. So those ones, when we are correcting, when we are doing correction, that is called plasty, we usually just do with the stitch plication. We just plicate, we don't incise. But for Peyronie's, I think most of the practitioners are in favor of longitudinal incision. On the tunica, you don't penetrate the entire tunica and Virginia, at least most of it, maybe half, and then you close transversely. Thank you.
Thank you. No, the question is not yours. You have already said thank you. I'll watch. I hope he hasn't left. Multiple injuries. Is he here or am I going to? Okay. You're even here. I wouldn't have taken a month. Now, of this multiple injury surgeries, till everybody has come on board, or do you advocate that we actually start the repairs, the surgery for the genitourinary when other specialties are coming into it? I'm more interested in the fractures of the pelvis vis-a-vis injuries of the posterior urethra? Do we go first or do we go last? What's your preferred? Lord, that's a good question. Thank you. Let me give you the mic.
Thank you, Dr. Kambuni, for the question. Yeah, in the setting of multi-trauma, it's multidisciplinary management. Depending on what is pressing, you go first. Because the patient might have renal injury that might need embolization, nephrectomy, and such like. When it comes to urethral injuries, I don't think there is consensus on what to do with the posterior urethral destruction defects in the acute setting. There are quarters which advocate for scopic alignment, but the outcome is not good.
Looks like there's still some burning.
No, it's not burning anymore. I know there is coffee time, so we are going to share. But since we have a critical mass of urologists, especially pediatric urologists, it might be advisable for us to go in fast. Because then the tissues are fresh, the tissues are friable. Surgery of the urethra, 4 or 5 years later, becomes a near impossible procedure. Think about it, let's discuss. I know the topic is wide, but let's not fix and go for suprapubic and wait a year or 2 years later. It's really a difficult surgery, an inconveniencing surgery, a psychologically traumatic surgery, because you see, once you dysfunction that, you know which organ it is, the whole life kind of is dysfunctional. It's open for discussion over tea, but that's my thought. Thank you.
We'll allow
Mr. Kimani, regarding instance of biochemical recurrence in prostate cancer, are there any studies to show the incidence in biochemical recurrence in patients who have gone external beam radiation therapy, which is really the only other modality in our setup? I've seen your comparison with the 3 studies, yours, Mburugu, and Oheru is 30%. In terms of us being able to advise our patients, which is the modality to probably think of, I think the world incident, 50% is in external beam, and I think 30% is in radical. Can you just tell us whether there is any of this? Have you seen from your colleagues from radiotherapy?
Kimani, go ahead.
Beam radiotherapy. From the data we had, I didn't give the results on that, but there were the biochemical recurrence. However, there are patients with external beam radiotherapy who have still shown that they, who was even within our data, there were patients who had a biochemical recurrence after even undergoing either radiotherapy and brachytherapy. However, we didn't give the specific statistics, but I think that is because of limitation in terms of future forum. Thank you.
Dr. Otele, for sure you know I'll ask you this question. Now, thank you for exposing that men have curvatures, but I just want you to comment on the use of intralesional installations, and particularly steroids, which I know for sure quite a number of urologists use. The last time we had such a discussion in the department, I think we were discouraged to use intralesional steroid installation. So if we cannot use the steroids, what is available in our setup at the moment that you would encourage us to progress into? Thank you.
But because of your question, I have to come back again. Yeah, steroids are condemned. They are not recommended, as you've rightly put it. But in our setup, the best Clostridium histolytica, also known as Xiaflex, and it's also in oral preparation in tablets. but most practitioners prefer to use injection. They inject it in the tunica albuginea. And it is said to reduce the collagen type 1 and type 3, which feature in that scar, which is recalcitrant, that tends to persist and fails to go away and causes curvature. And they have done a study. The study is known as IMPRESS. IMPRESS study was a double-blind, placebo-controlled study where they were looking at the efficacy and the safety of CCH, safety of collagenase Clostridium histolytica. And they found out that it is actually efficacious if you compare to those who are using placebo. So the best option is CCH. In my practice, unfortunately, we don't see many cases, so we don't have experience. But I believe 1 or 2 surgeons, especially the older generation, may be doing this. Or our good friend from Aga Khan, Dr. Idit, might be using the same. So I think intralesional is Clostridium, a collagenase Clostridium histolytica would be a better option.
Let's get a comment from Dr. Idit as we close this session.
Thank you, Chair. And Dr. Otele, I'm not asking you a question, but this was just a comment now we have got extracorporeal shockwave therapy, and we are on the 5th patient with a Peyronie's disease. We are also using it for erectile dysfunction. Dr. Mugalo, neurogenic bladder. There is also the role of nerve stimulation, which we now also do, the InterStim sacral neuromodulation implants, although they are very expensive. But there's a cheaper version where the posterior tibial nerve stimulation. They have also good results.
Thank you very much, Dr. Idit and Dr. Otele, for those comments. We think we are going to the next interactive session. I don't know where Dr. D.K. Kimani is. I think he's the one supposed to read this session. Somebody has lost this very important disc, which will allow you to get it out of the hotel. So please, if you are the one, you make sure you come for it. Dr. Kimani.
One is a radiologist, Dr. Sam Nguku, and the other one is a pathologist, Dr. Alan Ngugi, who will be helping us navigate this session today. But it will be as interactive as possible. I wanted to inquire from us, Dr. Mburugu, the last time you ordered a PSMA PET, what was the indication?
The last one. I can't remember of it, but there's one which a patient insisted on, which I think is more relevant for your question. But I think the last one was a recurrence, a PSA recurrence, where a biochemical recurrence where we had left the tip, I think one of the tips of the seminal vesicles.
Dr. Idid?
Actually, there was not so good indication. I mean, Dr. Nguku, I think we always discuss with the patients, and the primary indication is always not for staging. But this patient, I think, was high, what do you call it, VIP, and we were going in for radical, so we wanted to stage thoroughly, just to be sure that we would not have any recurrence. And I think that was a weak indication.
Good. So, the prostate remains challenging. Prostate cancer remains very challenging, and we need to be on the lookout for, one, patients who are not your typical patients, and number two, we'll be bombarded with a lot of information that is new. How do we use that information? And number three, we will remember that the prostate does not behave the same at all times. I'll have two, and if time allows, three patients to be discussed. Okay, scenarios. One is DGM, a 68-year-old male who's a businessman from Ngong, hypertensive, who's on modulatic and Nirol, and his brother has a history of prostate cancer. He's a health-conscious gentleman. We had been on regular follow-up since March 2018 with mainly mild low urinary symptoms, urgency, weak stream, and had been on sometime D-term but for a short while. He had a remarkable physical examination, except quite a large prostate. Didn't feel nodular. His PSA had been fluctuating between 5.6, a mild rise to 6.2, and 6.7 the last time that he was reviewed. And by the time he was seeing us, he had a PSA of 23. He had a 112-gram prostate on ultrasound and a PVR of 12 out of 257 cc's. He had on the iliacs, one of the nodes, 24 millimeters. He had several, two biopsies actually, done by the radiologist, image guided. One only did 6 cores. The second one was 10 cores, both of the radiologists. He insisted that he did actually 15, but the pathologist says he received 10. So the question is, where did those samples go? Dr. Nguku, what are the undisputed indications of PSMA PET today? The undisputed.
Good afternoon, and thank you to Dr. Kimani and the CAUS organizing committee for inviting me to attend your annual scientific meeting. And you know, PSMA PET is a very contentious issue right now. Sometimes I think we are very lucky to have it available in the country, but it's also a blessing in disguise. It has been abused, and I've attended multiple tumor board meetings where discussion on indication and discussion on its use has been very contentious. But it's good to follow guidelines. And if you consider the undisputed ones, traditionally when PSMA PET became available about 8-9 years ago, initially we had F-Colin, which, as much as is also very good, does not outperform PSMA PET. So PSMA PET has proved to be king when it comes to prostate cancer imaging. And one of the main indications then was highlighted that now the PSA level that is considered biochemical recurrence is actually 0.2. Initially, we started at 2, we went down to 0.5, now we're at 0.2. I've seen cases of less than that, 0.2. We still are able to sometimes identify actually sites of biochemical failure on PSMA PET. So PSMA PET is very sensitive for evaluation of patients who have biochemical recurrence. The next big indication is in the setting of targeted therapy using, in particular, lutetium-177 PSMA, or recently we now have actinium, which is an alpha emitter PSMA. If you are going to use that for specifically patients who have castration-resistant metastatic prostate cancer, then of course you will have to have a baseline PSMA PET to be able to, see what you are going to treat, and then you treat what you are going to see on the PSMA PET. And then recently, both the NCCN guidelines and the the European Association of Urologists, the EAU, has updated their guidelines on and high-risk prostate cancer. Primary staging of those, of course, this has to be done judiciously based on availability. And if, for example, and we'll be seeing in other cases, sometimes it's actually an overkill. You don't have to do it if, for example, you have seen disease on other modalities. But those three are the main undisputed indications. Thanks.
Thank you, Dr. Gugu, for that elaborate discussion. The issue is now here, we have a patient who 2 biopsies are negative, the PSA is high, MRI is suggestive. Would you consider this as an additional indication?
Yeah, so we see this kind of things. It's a challenging situation you are in. Your MRI is showing something, PSA is rising. You have to tell the patient where this is coming from. It's an unconventional, I have to say, indication. If you look at the appropriateness of use criteria, would be, not strongly recommended. It would be like a score of either 2 or 3 or 4. The only justification would be in the setting where, for example, you have done your multiparametric MRI, like in this case, it's showing an obvious lesion. If you're not sure that what you're biopsying is resulting in negative results, then you can do a PSMA PET to see whether there's another lesion that's actually more avid than what you are seeing on the MR, and then target that with your ultrasound biopsy. But this is an unconventional indication.
Thank you. And this is the PSMA that was done. Your comments?
So I think this must have been a pressure from your patient.
Yes.
Or just
we can enlarge that image.
What we use is F18. There are different ligands for PSMA available. Traditionally, we had gallium-68 PSMA, which is the most widely used. But what you have available in the country right now is F18, PSMA 1007. And one of the biggest benefits of F18 1007 is, as you can see from the image that is projected on your left, which is a MIP image, which is a summed image of the PET, is that there is very little urinary excretion. So you can't see the ureters and you can't see the blood. And that's one of the shortcomings with gallium-68 PSMA PET, because if you have urinary excretion, then it becomes very difficult. And within the prostate gland, the patient has a very large gland, as you can see. The bladder is just displaced anteriorly there on the second image, the fused ligand avid. SUVs were 48. There was a left external iliac lymph node which had been seen on the MRI, but it was not very avid. I think the SUVs were well below 10. Usually we say, the sons and the parents will look the same. So this was invariant with the primary lesion in the prostate, and we thought it's unrelated. But clearly there is an obvious lesion in the peripheral zone on the left, and corresponded interestingly to the same lesion that had been seen on the MRI.
Thank you. So this is one of the areas where PSMA is actually downstaging the disease.
Multiple, study beginning of 2020, and it did show that in addition to, of course, upstaging in some cases, in about 17 to 25% of patients, they will be actually downstaging. Nodes that were, pathologically, because on morphological imaging with MRI or CT, you're just looking at the size. So a node is above 10 millimeters, you consider pathological, and less than that, reactive, and vice versa. So with PSMA PET, we see nodes as tiny as 4 and 5 millimeters, which are very avid, which would be 2 centimeters. That is not PSMA avid, so which would suggest it's probably unrelated. So it does downstage, yes.
Long-term treatment that the patient had received, does it have an influence on PSMA? Or in the pre-treatment? For example, if we accidentally gave Casodex for this patient before we sent him for PSMA PET, would it influence the imaging?
Yeah, very good question, and it has come up with many urologists that I have spoken with. There is literature to show, and I have seen also from my experience, that initial administration of ADT does actually upscale. The only thing is that it peaks at around 3 to 4 months, and after that it may start to drop. So it's a very risky balance. The only time that people do recommend its administration is, for example, if you have a patient who has biochemical recurrence and you want to increase the sensitivity of the PSMA PET in picking the site, you can actually start the patient on ADT and then do the PSMA PET. You have a higher chance of picking the lesion compared to maybe them being scanned without any ADT. But in this particular patient, I don't know how long they had been on the on ADT but I usually recommend you just do it in a cold, naive, treatment-naive patient.
This biopsy, Dr. Wawero, should it be a pathologist preserve or should it be a urologist?
Good. I think one is that we have a prostate of 112 grams and a PSA of about 13 because the patient was on DTAM. I think with this kind of a lesion that is obvious on MRI, I think for this one there is a guidelines, but there is also the common sense that if you have 112 grams and you're doing 6, they actually do up to 20 sometimes, and they tolerate well. I think whoever does the DRE should be the one who should do the trans-guided biopsy.
Which brings us to Dr. Ngugi. When we send you these biopsies, would you consider, when do you consider them adequate?
These are good questions. So the basis for considering a good biopsy is actually to look at the objective of the biopsy. And these are mainly to achieve accurate risk stratification for the patient, disease localization, and as well to achieve a good concordance between the biopsy and the whole gland, whether you've done a radical prostatectomy or imaging. Now, in terms of the number of biopsies, I think the extended 12 core with an addition 2 cores from the apical region is what is now being widely recommended. Dr. Wero mentioned up to 20 cores, which is now going towards the saturation biopsies, where the prostate gland is sampled every few millimeters. A number of studies have shown that to a number of interesting things. One is that when you sample the apical region and the far lateral region, you statistically increase the diagnostic yield. So in the extended prostate biopsy, we should always make sure we sample the far lateral regions as well as the apical regions. For the initial biopsies, the recommendation is to do the 12 or 14 core biopsies, and then if you do need a repeat biopsy, then the saturation biopsy may suffice, including sampling. Very important to now submit no less than 2 core biopsies per container. And I'll talk about that a lot, but because one of the things we do find is that when you submit multiple cores in a container, 2 things will happen. Number one is fragmentation. The pathology says so 20. So what has happened is that the core has fragmented. The other important thing is entanglement of the cores. Basically, the cores are like threads and they basically entangle in there during transportation. A number of computer simulation studies have been done, and they've actually discovered that fragmentation and entanglement can lead up to 40% loss of the tissue surface area. And that's a big loss to your sample, which you have done meticulously. So the guideline, not just where to do the biopsies, not just the number of biopsies, but to ensure that you don't put more than 2 biopsies or 2 core biopsies in one container.
Great. Maybe increase the thickness of the cores. Gauge 16. Wait a minute, 16 versus 18.
Maybe the pathologist will have been better to answer that. But I think if you increase the gauge, then you increase the complications. Of course, bleeding being number one. Of course, seeding of infection as well. So, and pain after the biopsy. So I think maybe the smaller we can yield enough tissue, I think will be better.
Any different opinion? 16 versus 18? gauge 16 versus gauge 18 needles. But all said and done, we get a histology. And one of the things, if we send themselves, and they come back, almost invariably, there will be a change in the Gleason scoring. Why is it so? Is it that we are not very well trained as far as Gleason grading is concerned? Is it an acceptable thing that there will be variation? But why all the time we are getting a variation from what we had? And it's not a simple variation of 3 plus 3. Sometimes it's 3 plus 4 to 4 plus 4, 5 plus 4, which has clinical implications.
Your question is touching on observer variability. There are several levels of observer variability that we look at. One is inter-observer variability. This is between more than 2 pathologists. So you give pathologist A this same biopsy and you do the same for pathologist B, and you want to see what each of them calls it. The other level is intra-observer variability. This is a case where you give the one pathologist case A, and 6 months down the line you give them the same case and you want to see what they call it. If you look at inter-observer variability and you look at some of the studies which have been done, and if you do an aggregate of all Gleason scores or all group grades, the variability or level of agreement measured by a Cohen's-Kappa statistic is usually coming to moderate. Some studies will report a high level of agreement. Now, the novel way of grading prostate cancer, which is the group grading system or the ISUP group grading system, reports higher levels of agreement because it's only, that said, people have gone further and tried to find out what are the real contributors of this variability, and they've identified a few. One are Gleason grade 3 plus 4, which is a group grade 2, versus Gleason grade 4 plus 3, which is a group grade 3. And we all know now that as much as the total is 7, they have very different outcomes and progression-free survivals. In these cases, they found that this is where you have the highest variability. Another source of variability are grade groups 4s, which are Gleason 4 plus 4. Now, remember, you also have a 3 plus 5. You can also have a 5 plus 3. The total is still 8, but these are very different diseases. Now, if you have a pure 4 plus 4, it's very important to make sure you don't have a 5 in there, because that will change that from a 4 to a 5 automatically. And so these are the main areas or problematic Gleason scores that cause most of the variability. That having been said, I'll go back to what I mentioned earlier. If the sampling or the submission of the biopsies is a problem and there's been loss of tissue, then that is usually lead to some of these discrepancies. Number 2, training of pathologists and standardization of that training is important, because if a pathologist is not up to date with the current grading and they're not refresher trained, then you'll have discrepancies. And number 3, and this is going into the future now, is the role of artificial intelligence and machine learning in actually grading prostate cancer. This is happening in a number of hospitals in the West.
Thank you. The final considerations from N1 to N0 on our staging. And number 2, that could as well have implications on the treatment, because initially, if we didn't have the PSMA PET, we would have maybe shied away from doing a prostatectomy. But now with the PSMA PET, is telling us we can go ahead and do a prostatectomy. I don't know from a clinical point of view whether this is a good thing or a bad thing. And more so when it comes to Dr. Kimani's concerns about the staging, especially of the N, where we are told that the PSMA PET seems to be doing better than our conventional imaging. The question is, in a clinical world, is it helpful, or is it an issue of discovering something too early and then giving you an impression of a better outcome?
Yes, I'm feeling like I should direct the question to. Unfortunately, we are dealing with an issue of increased sensitivity, and there's a very nice talk by Professor Hoffman, who has done a lot of work on PSMA PET about struggling with increasing sensitivity and where to strike the balance. Because as you have rightly pointed out, and as Dr. Ernest mentioned, we now know PSMA PET is way superior for nodal and extranodal, other extranodal sites of disease evaluation compared to conventional imaging. MRI, of course, remains superior in the T staging. Now, does identification or lack of disease using PSMA PET alter clinical outcome? We still don't know, and that's where the lead time bias comes in, where imaging modalities such as PSMA PET may not, whether you had treated the small sites you have identified with a more sensitive imaging, or ignored them and gone ahead to do, for example, radical treatment, and disregarding these new sites that you have seen. And most of the guidelines that we are using for prostate cancer treatment, in particular the STAMPEDE trial, imaging for staging purposes, and the clinical outcomes, for example, treatment of oligometastatic disease, are informed by that. Now you have a PSMA PET available 12. So do you deny that until we have more information to tell us that the sites of disease that we are seeing will, based on...
What happened to this patient? The patient disappeared on me. Maybe he went to Dr. Brugu after 2 failed biopsies. So I didn't get to see the
number of urologists now. And they should be doing biopsies. I have done these biopsies with radiologists. I have taught some. I have done some with those who think they know. And you find that they go to the central zone all the time. You tell them, go to the lateral zone, go to the apex. They don't do that. So you must be missing a lot of prostate cancers. I think it's high time as urologists.
Okay, actually, that is one of the needs we identified as a faculty, both in KAUS and Kenyatta National Hospital, University of Nairobi. So within the next probably a month or so, we'll have a dedicated ultrasound machine, and we should be able to train and perform ultrasound-guided biopsies at Kenyatta National Hospital.
So good news from it. Maybe the lateral projection minimizes the risk of bleeding. That's why guys are going central.
Yes, thanks. I just want to emphasize what SNK is saying. I think with the advancement that we're having in urology in this country, I'm almost sounding gross, but I think it should not be fair to have a patient getting their biopsies done, especially this kind of patient, without proper ultrasound guidance. And when you say the patient has a PIRADS 5 lesion, PIRADS 5 has an element of size. That lesion should be visible on an ultrasound. And so if the patient has to go for a PSMA PET scan to identify a 1.6 centimeter.
Thank you.
I'd like to add a comment to Dr. Waweru there.
Yes.
On the importance of targeting the lateral zone. And the benefit, the additional benefit is actually helps you to predict whether there is the extra prostatic tissue on pathology, and we can actually tell you whether there is actually tumor there. In addition, you can also predict the probability by targeting the lateral zones. And then once you are actually lateral zone biopsies and put them in separate containers.
Thank you. One last comment from Dr. Matu.
This is a question to you, Dr. Kimani. Do you think MRI ultrasound fusion biopsy could have improved or changed the results of this particular patient? And number two, I think the time we know that this procedure is painful. No man is done about once, twice, want to go the third time. Can we be more polite and put this patient on anesthesia if need be?
The software to do so, but every time we are being told there's image guided. Dr. Ngoku, fusion. Is this cognitive fusion reality? So to answer your question, we do not, the MRI ultrasound fusion will be the way to go. We don't have the facility.
Well, cognitive fusion is just a fancy name for what Dr. Puno was saying about seeing the lesion on MR, doing the prostate ultrasound, and having the MR image of the prostate with you, peripheral zone, or in this region of the prostate, and do multiple biopsies in that area instead of just doing non-targeted biopsy. But I think more importantly is template biopsy, which I don't know whether you are going to talk about, but template biopsy is even way better for patients that are highly suspected to have disease and you can't find it on routine biopsy. So, and I totally agree with the issue of anesthesia. I think we are punishing men with biopsies just plainly, yes. I'm not sure about transferring the biopsy to the urologist. It means less revenue to us, but that's fine.
As we go template, maybe making MRI rooms more friendly so that you can work with your needles there.
Thank you, Dr. Kimani. Prostate biopsy is painful. If you are going to put every patient under anesthesia for prostate biopsy, it's going to be very expensive. I think ideally, under ultrasound guidance, you can be able to, since 2006, we need to take our responsibility as urologists and do our job because we understand the prostate better than any other specialty. Thank you.
Dr. Opondo, this template thing, this template thing, what is it?
Yeah, so the template concept in prostate biopsy comes from statistics, the concept the prostate a chance of being biopsied. So when we take 12 biopsies systematically, that will give us the template. But then when we add imaging, the question has always been that yes, we might have evenly distributed our cause across the prostate, but then the tumor is small, maybe just 5 millimeters or 10 millimeters, and our needle does not go through it. And that is why we need additional tools for targeting. And the first tool for targeting has been the multiparametric MRI. People have used ultrasound with microbubbles, and I already see DK is now moving into PSMA for targeting. I mean, albeit accidentally. The idea is that we want to evenly sample the prostate based on the size and then reduce the probability of any losses. Now, one of the reasons why, even if you do template biopsy and you have a lesion that is suspicious on MRI, you need to target that lesion, is because those did not pick on reporting. And the lesion that you will pick, say if you do 12 standard on the template and then you do 4 on the target, you might find that there's some other lesions on those other parts of the areas that the MRI did not show. So when you do the MRI for biopsy of the prostate, it is not just done to tell us whether there is metastatic disease. It's actually helping us to target the lesion. And whichever mechanism one uses, whether it is cognitive fusion or software fusion, or even just ultrasound, or we can say we would do a PSMA ultrasound fusion cognitively, one has to bear in mind that the most dangerous lesion is the one that the MRI will pick. And in this case, we're talking about a Peyronie's file. So it should be systematic biopsies or the template biopsies plus the targeted lesion. That is what would be defined as an adequate value for money for the patient who has already spent money for an MRI.
Multiple biopsies.
Actually, with your needle, which you can see on transrectal ultrasound, it is not painful. We've done over 1,000. I can remember the ones who complained of pain. They are less pressed. as you do the biopsy. If the rectum is loose, even if you're doing few biopsies, you bleed from the rectum. And I think that's what you should worry about. Of sepsis, we haven't seen an increase in sepsis, and our sepsis rate has been below 5%. So I don't worry about the sepsis.
So we'll quickly go to the second case, where PSA as an unreliable witness. There are many cases of CA prostate with the normal PSA, and there are many cases with high PSA and no cancer. And equally, there are cases of CA prostate with incongruent PSA. You find a very aggressive disease with low PSAs. AGW, this case is what Professor Mungai was discussing. It was managed by Professor Mungai and Dr. Jiraine, who is around. A 61-year-old male, businessman residing in Nairobi, no history of chronic illnesses, allergy, family history of malignancy. Father had prostate cancer at 96, and sister had breast cancer in her 60s. Has been on annual PSA review for the last. Go to India for problems of back for review for a slit disc, which showed the sacralization of L1, multiple metastatic lesions in the lumbar vertebrae without collapse. L4-5 disc compressing the thecal sac and encroaching the neuroforamina. CT done same day, multiple same day. Also an MRI of the pelvis, which showed a multifocal right external iliac metastatic lymph nodes and multiple bone metastases. He had a trust the following day with 5+5 and with perineal invasion. Sclerotic skeletal lesions and no lung or liver lesions. BRCU, 61, male, businessman from Nairobi on
pelvic bones, right femoral trochanteric region in the sacrum, in the sacroiliac joints, spine and rib. So this patient, I think, looks like a lot of pressure on Professor Mungai. Did come back for a PSMA PET. I think they wanted to exclude visceral metastasis, which is that scan shown there. Now, from experience, when we have done PSMA PET and bone scan in patients, multiple, way more lesions and way more avid lesions on the PSMA PET relative to the bone scan. That tends to be almost invariably. For this particular case, you can see the lesions are not impressively avid. If you compare this case with the first case, the SUVs were, the first case that we looked at, the SUVs are not very intense. We were looking at SUVs that were ranging between, having said that, they were still at PSMA avid, but not very impressively so. There was disease within the lower panel. You see these lesions are very sclerotic and very osteoblastic in the sense that they are very sclerotic. So traditionally, bone scan has proven itself to be very superior in evaluation of this kind of bone lesions. Thank you.
How common is this set by the bone scan?
Is has shown to be positive in up to 95% of patients where there is remember FDG is the tracer we use for the other cancers. So these lesions tend to be FDG avid and prognosis is generally poor. The other smaller proportion is small PSMA expression compared to the traditional adenocarcinomas of the prostate.
So we had to see the last of bone scan.
Case in point, we shouldn't throw away bone scans just because we have a more sensitive imaging modality. And as we discussed earlier, such a patient where you is really debatable, because what if you see, for example, you have seen 20 lesions on the bone scan and then you see 50 on the PSMA PET, it doesn't really affect your treatment approach for them.
And how good is PSMA PET as a?
I don't have a good answer to. I think there is still a lot of work being done with PSMA PET in terms of treatment evaluation, post-treatment evaluation. Interestingly, the few cases we have performed PSMA PET as a baseline and a follow-up after treatment, mainly either with ADT or with EBRT, or even with radical prostatectomy. The outcomes of the comparison is very good. And one of the things I must mention here is bone scan, unfortunately, as much as it's very, even the treatment-related healing of the bone lesions may be positive on a bone scan for a very long time. But this is not usually a challenge with PSMA PET and even with things like FDG PET, and that's why it may make sense for you to do it as a follow-up. But again, I think the big question would be to 3 or 4 patient is happy. So if you're doing it just to confirm that the patient actually is doing well, it doesn't make a lot of clinical sense. Of course, it's nice when you show a patient these were multiple lesions on your previous scan, and these are only maybe 1 or 2 that are and they are less avid compared to what they were before. But in terms of the clinical information it gives, maybe is questionable. I think it should be used very judiciously for follow-up.
Dr. Alan, are you able to predict?
Yes, who have prostate cancer and they have. And there are a number of prostate cancers which behave like that. One of them has already been mentioned, would be a poorly differentiated or undifferentiated prostate cancer. So remember, when we're talking about differentiation, we're not just talking about how the cancer or the tumor looks like, we're also talking about physiology. So the undifferentiation or the dedifferentiation affects the physiology as well. That said, most of the prostate cancers will actually express, be they small cell or large cells. On the 7 o'clock position, you can see what is the conventional acinar adenocarcinoma. Image A above, you see 2 types of tumors here with pattern. And this is at low power. And this is another section where you see it has the same kind of appearance. Acinar adenocarcinoma here, and another poorly differentiated tumor here, which we can't tell what it is. On higher power, you can see the nice 4x4. This would be a 4x4 prostate adenocarcinoma. I would like you to notice that just below it you have another group of cells here, and these are lymphocytes. And they are totally different from this tumor, which you see here on high grade and on high power. And if you're close enough, it was difficult to. And this brings me to the role of immunohistochemistry in assessing prostate lesions. Here I've done 4 markers on the same epitope that Dr. Nguku uses, now on immunohistochemistry. So as you can see, these are residual prostatic glands. These are actually malignant, but they're still active. So it tells you this is unlikely to be adenocarcinoma of prostate. Image B, I've done a synaptophysin. Synaptophysin is a marker for neuroendocrine tumors. As you can see, the residual prostate glands here are totally negative, but the high-grade tumor is highly positive. This tumor expresses keratin on here, and earlier I had pointed to the fact is that lymph nodes are differential for such high-grade malignancies. And so the conclusion here is that this of the prostatic chips, but also has an adenocarcinoma 4+4 occupying about 10% of the gland.
You have, I think the few times I've seen these atypical presentations, it's you who brought the cases.
Yeah, I think we discussed one which had a PSA of 0.2 secret and very poor response to hormone. So yeah, it's good you brought it up. But before I give you back the microphone, what is the role, Dr. Njau?
Yes. So that is the other important role for immunohistochemistry whenever we get metastasis. And here perhaps you're thinking about metastasis to the prostate or metastasis of the prostate carcinoma to other organs. So the common, of course, they are quite adjacent. The 2 organs are quite adjacent. The 2 tumors may look the same. So in terms of clinical requisitions, please give us a history of whether the patient has a bladder tumor. so that we can decidedly do immunos for distinguishing between a high-grade urothelial carcinoma from a high-grade prostate tumor. Another tumor we may likely see is an adenocarcinoma from the urinary bladder. And these are more subtle, they are more difficult to resolve. In this case, we usually use a monoclonal PSA. And the reason is that an adenocarcinoma from the urinary bladder will also pick up polyclonal PSA. So you cannot use your standard PSA immunos. Both of them will highlight. Adenocarcinomas from the colon. Experience I've also seen infiltration of the prostate by leukemic cells or lymphoma cells. And the commons, and one may actually think it's a prostate adenocarcinoma. Again, immunos are very important in this case.
Yeah, we are privileged to have two of our friends. What treatment are you going to give? These patients are not expressing PSA. And number two, how are you going to follow up this patient now that even PSMA PET is not picking out so well some of these lesions?
I think what was interesting was because it was a patient who was highly having a health-seeking behavior, presented with what the urologist sort of had thought, or because he had no symptoms with a PSA of 6, but went for something unrelated. Then unfortunately we found that he actually has metastatic and high volume disease. So now currently, after him using abiraterone for about 6 weeks, his current PSA is 0.1, we are seeing with the PSA. Secondly is that he already has metastatic disease. So the issues that we have were some of the lesions that we're seeing on the PSMA PET were on weight-bearing bones, especially within the femurs and part of the lumbar spine. There was no loss of height when we looked at both the CTs and the MRIs, but then we the injection from the biphosphonates, and we have data that we do not necessarily have to use the biphosphonates monthly. There is data that 3 monthly would still be as effective as monthly treatments. Again, reducing the frequency of the times that he has to come into the hospital. The other thing was he had asked for a review of his biopsy slides, and I think they were availed because we were quite curious and thinking that maybe he has some neuroendocrine differentiation. And then for that particular patient, then we would want to lean more towards chemotherapy-directed treatment. PSA is done, then we have to sit and think as an MDT, now like we have done that, to sort of rationalize what is the treatment for this patient, because he's not the typical gentleman that you see with metastatic disease. Finally, is that he is very fit. He has no symptoms. So then the second thing is to rationalize, are we going to start giving him symptoms because of chemotherapy? To what benefit? So I think that discussion has to be held between the treating team and the patient. Thank you.
Thank you. She has said everything. But basically is taking every patient as they are. As a clinician, I think interrogating the results in front of you vis-a-vis the patient's presentation and letting the patient talk. DK don't just write the prescription. I think listening to the patients is what might tell us eventually missing or gaining. Because if somebody dismissed that PSA at 60, that's, yeah, you might have most likely then would have lost the chance to treat this patient. MDT discussions cannot be overemphasized. Patients are difficult, and the easier ones are the most difficult. And I would encourage ourselves to talk to each other. Thanks.
I'll be asking you also is, when a patient comes, are the Europeans right in omitting DRE in their assessment of primary prostate cancer?
Time, we'd still have missed it. So what would I have done? So I know him for that long. I think we've got to rethink the value of PSA. PSA will not give you all the cancers. That we know, and you've said so. And so the digital rectal examination is very important. But I have done thousands of digital rectal examination on this man. He's a very good man. We've become friends. He used to work for Total as a company. Now he owns petrol stations. there is a challenge that he gave me, that if you see even a PSA of 4.5, maybe you should biopsy. I didn't think of that before, but any rise in PSA with a PSA of 6. Now, I'll spill the beans today about the Indians. We had a quarrel, which is why we have become friends. When they got there and realized they had nabbed me, because I'd missed the cancer, they offered the patient orchidectomy. And I don't think we have discussed the orchidectomy here. Should we have given this man orchidectomy? And I argued with them until we agreed orchidectomy was the wrong thing. 2, they were not keen. They're nice guys. And now we have Jirine, and she was talking to them while we were here. And they invited me to the conference, which is good. We have become an MDT for this patient. But should we, and I'm not sure whether they were wrong, Zoladex any better for him? What about the addition of the Casodex as a maximum androgen blockade? Then I'll go to the bone treatment, which is what Alice and Njoki are talking about. Chemotherapy is good. He hasn't had chemotherapy. His bone-directed therapy. And that's what, I don't know, maybe they talked because I had gone to answer some things in town. Alice and Dr. Njiraini, should we start using lutetium in these patients up front? Because we are afraid of his bones. How much toxicity would we get? Because this man runs petrol stations, so even if you charge him for the 5 million shillings it's going to cost to do.
My name is Mbudia. I think in this whole discussion, are available ahead of the guidelines, agreeing. I remember when I was on a medical officer, I did locums with the late Dr. Muturi, and the guidelines then were that you waited for CD4 counts to fall to 200 before starting therapy. But for him, he gave way long before. And his argument was very simple. Why are you waiting for renal failure and problems of HIV, And so I'm sure sitting here 10 years or 5 years from now, we will think differently.
It will be the question you'll be asking Dr. Nguku whether...
The question over to the debate Prof is introducing between the subset of patients who have, they describe them as variant histology prostate cancer, and I think this patient falls in that group. Patients who present with high volume ratio et al., they describe them as anaplastic prostate cancer. And in fact, they did a study on upfront platinum-based therapies, not even abiraterone or standard docetaxel. So I think that is something that might be considered on this patient as you weigh the safety and efficacy of upfront lutetium on this patient. But I think there is this patient is atypical in their biology, and going the standard ADT axis might give us a short-term response. The other thing is the follow-up on this patient. PSA is not a very strong, very high volume disease. So this is the kind of a patient where radiological and clinical follow-up combined with the PSA trends, not just the absolute values, would be useful. Now, as I swing it back to Dr. Nguku, you've been using the term SUV. I'm not sure whether the whole audience is comfortable with that term in two settings. At the point of PSMA diagnostics, what does the SUV mean at that point and in follow-up? Because then that would help us know whether PSMA would be of value in following up this patient. Please clarify the use of SUVs in your reports.
Maybe just before I answer your question, I'll just like to respond and add to what you have said regarding, the diagnostics in prostate cancer. And I think, we have the Vision trial results presented in ASCO last year, and very impressive, response for patients who are castration resistant, have metastatic prostate cancer. And the debate, of course, is whether we are reserving this, what we would call the big guns for way too late. Disease when it's already very advanced. But the other question is, when you look at prostate cancer and the spectrum of the disease by itself, it has to be a very long stretch. It's not like breast cancer where, if you don't treat, then you're going to die in a few months or few years. Prostate cancer is very forgiving generally. The issue of this particular patient, maybe considering targeted therapy now, I don't think is a good idea. And for two reasons. One, we may not have very strong clinical justification. And two, as you have seen on the PSMA PET, it's not a very PSMA-hungry cancer. And the therapy trial performed by the people in Australia, so the vision in America was just doing PSMA PET, gallium-68 prior to therapy. The therapy trial, they were actually doing FDG PET and gallium PSMA PET. For patients who are FDG PET positive, regardless of whether they are PSMA PET positive, they would exclude them from lutetium therapy because we know that they are going to be probably responding poorer compared to the other subset of groups. And I think this particular patient, if you are going to go that route, definitely get an FDG PET for him. If it's going to be positive, then probably don't even consider PSMA based therapy because it's most likely not going to be very effective for him. SUV is a standardized uptake value, which basically is the hottest pixel that you can measure within a lesion on a PET scan. It reflects the avidity of tumor, basically the uptake by tumor of the particular tracer that you are using. And when SUV was first introduced with FDG PET, we used to say 2.5 and above is bad, and below that is relatively not too bad. But now we know that it's not as straightforward as that. It reflects tumor aggressiveness somewhat, but not always. When it comes to PSMA PET, we still don't know whether a higher SUV value predicts aggressiveness. Probably, most likely it does. And that's what it has inferred in most of the few studies that have been done comparing SUV PET and aggressiveness of stage at presentation. So when you are using SUV PET, it acts as a baseline reference point, but you have to be very cautious because of one particular reason. The different ligands you use for PSMA imaging have different mechanisms of uptake. So I spoke about gallium-68 PSMA, which is most widely used. We use F18 PSMA. And you will notice that we have seen that SUVs are so variable. That's why they need to be interpreted with a lot of caution. If you are using a different tracer for imaging, then you should be very careful to use them as a line of response. So if it has to be the same tracer, probably same uptake time in terms of time from injection to the time of scanning, and preferably the same scanner. So they have to be used with that information in mind, yes.
As you do your closing remarks, Dr. Nguku, why did they take the FDA so long to approve PSMA PET?
Yeah, and I think it goes to the questions that have been raised here about guidelines and them informing treatment. FDA has always been lags behind the Europeans and Australians in approving drugs and diagnostics for different reasons. They are very cautious. I would say maybe they are very cautious in before they do approve anything. So it's not unique to PSMA, but we know that they have been using PSMA at the same similar duration of time to the Europeans. So it's not that they have not been using it. So they've been using it, but the approvals and the recommendations are usually very late. But it's a typical American thing. No offense to the Americans if there are any here, but yeah.
Final word, Dr. Alan. I think you have run a bit of short time.
My final words, please take care of the biopsy. It takes a lot of effort to do it. So take a few more minutes to make sure that it is submitted well in 10% neutral buff and formalin and in separate containers. clearly labeled. This makes a big difference in actually assessing and giving you very clinically relevant information for that patient.
And thank you, audience, for remaining awake throughout this throughout this afternoon. Back to the leadership.
Thank you very much, Tim. Thank you very much, the gentleman from Aga Khan, for doing a good job, and DK for the superb handling of the session. He's Njau, not Ngugi. Yes. Okay. So this brings us to the end of the successful first day of our conference. Thank you very much for the large attendance and turn up. We'll have to think of ways to deal with that opening ceremony going forward. So tonight I'm informed there will be a dinner. Is that true? Tonight I'm informed there will be a dinner at, what is MMS? It's not in the program, so I don't know what they have planned. So we invite you for this, and there will be the launch of the Kenya Journal of Urology, which is the committee is chaired by Professor Mungai. So tell us more about it, Prof.
Thank you very much. And since I'm at home, I think I'm allowed to sneak out and go to places. So I sneaked out, and so Joki might have, but she knows the patient that you discussed last. So now, this evening, I'm told there is free food. In addition to that, for urological fraternity, Kenya Association of Urological Surgeons finally launches its journal. We, as a committee, invite all of you to come with whatever you have. You can even come with different attire from what you have. And for purposes of cows, make sure you've paid your membership and subscription fees for the journal for you to receive a copy of the inaugural journal, the inaugural edition of the Journal of the Urologist. So please, I think we are meeting downstairs, that's what I was told, and MMS should come and contradict me or otherwise, that we shall be in the dining hall where we usually have our dinner. But I'd like that confirmed, if somebody can call Catherine or Juliet, because there was a debate as to the dinner is sponsored, and I would have liked them to tell us who's sponsoring it. And because I may not have another, I think I'll have the opportunity. We are also asking all our SHOs and our urologists to start publishing in this quarterly journal. But we shall be telling you the rest in the evening. I don't think I would want to tell you anything else about it. But please come all. So you go, do whatever you're going to do, and be here with us at 8 p.m. Kathy, are we at 8 p.m.? And who is sponsoring us? Sisi Pharmaceuticals. I thought it was Steve, yes. So it's Sisi Pharmaceuticals sponsoring our dinner tonight, and it's downstairs in the main restaurant. So you all come there. I might even buy you a beer if you are one of the partakers of alcohol. Thank you very much, and have a night. It's been a long day, yeah? Yeah. Oh. Huh? Yeah.